Good evening, ladies and gentlemen. I am Dr. Anita Saxena, professor in the Department of Nephrology, SGPGI Lucknow, and with me is your co-host, Dr. Shruti Thapiwala, consultant transplant nephrologist at Institute of Renal Sciences Global Hospitals, Mumbai. It is indeed my pleasure to welcome all invitees and participants on behalf of WIN India to the WIN India World Kidney Day celebration which has already begun. And the first session is on the role of nutrition in the management of kidney disease. World Kidney Day is celebrated on the second Thursday of March every year. This year, the World Kidney Day is slated for 10th March 2022, and the theme of the World Kidney Day is Kidney Health for All. It is indeed a pride moment for Indian women in nephrology to enter into the next international event after taking the first big stride of creating a place in World Congress of Nephrology 2022. All facilitations to the team WIN India, headed by Dr. Urmila Anand, the president, Dr. Manisha Sahai, the vice president, Dr. Manjusha Yadva, the secretary, Dr. Swan Letha, the treasurer, and Dr. Shruti Tabiwala, the joint secretary, who have organized this 1 week event. Now, 1 in 10 people have kidney disease, and with the rising incidence of diabetes, hypertension, and obesity, kidney disease has become a global burden on society and healthcare. Our effort is always to bridge the lacunas in what we consider as high quality care and what actually the patient needs. This evening, we have 2 sessions. The first one is patient awareness program, followed by a session for nephrologists and dietitians. In this session, we will have 4 speakers, 3 esteemed members of the community whom we serve with pride and who have witnessed kidney disease from very close quarters. They'll be sharing their experience with us, and we will wrap up the session with a panel discussion. So on this note, I invite Dr. Shruti Tapiwala. Just a moment, I'll share my screen. Why? Well, anyways, I think lost. Stop. Share the screen. Yes. And right, it is my pleasure to invite Dr. Shruti Tapiwala to deliver the first talk. She is presently a senior nephrologist and renal transplant physician, director Advanced Transplant Diagnostics Lab Private Limited, and she has plenty of affiliations. She impresses us with her affiliation with Institute of Renal Sciences Global Hospital Mumbai, Advanced Transplant Diagnostic Labs Private Limited Mumbai, Sir H.N. Reliance Foundation Hospital and Research Center Mumbai, and Clinic Andheri Mumbai. She's secretary ISN West Zone chapter, and she's a working committee member of Narmada Kidney Foundation. Her major achievements are that she's established a specialized laboratory for advanced transplant diagnostics Mumbai. She's also established SOTER registry for sensitized patients, which is the first national registry developed in India. And she's also established robot-assisted transplant program in Mumbai at Sir H.N. Reliance Foundation Hospital and Research Center Mumbai. She has published a lot in the national and international journals, and she's also published books, chapters in the books. So the topic of her discussion is blood pressure control. So now over to Dr. Shruti.
Thank you, Dr. Anita. That was indeed a generous introduction. And dear patients, I would say welcome to everyone to attend this seminar. We have planned this seminar for patients, followed by our diet colleagues, because we want to see that the care in kidneys is optimal. A patient should understand what he or she should be looking after when they are placed in situations where they have a medical issue. Now, blood pressure is a very basic issue which anyone and everyone comes across in their daily life. So let us see what is blood pressure. Now, if you look at what is blood pressure, it is simply the pressure exerted by the blood when it is flowing into the blood vessels. So for patients, I can say in Hindi that आपका खून जब आपकी नलियों में बहता है तो वो जो प्रेशर लगाएगा उस प्रेशर को हम ब्लड प्रेशर बोलते हैं. और हार्ट जब ब्लड पंप करता है तो वो एक प्रेशर के अगेंस्ट पंप करता है, बट जो ब्लड प्रेशर होता है वो किडनी से रिलेटेड होता है. Okay, so that is the simple thing which everyone should understand. I am going to switch between Hindi and English because कुछ patients को हिंदी समझेगा, कुछ patients को English समझेगा. At the end of the session, we will be ready to answer your questions whichever possible. अब जब मैंने बताया कि ब्लड प्रेशर क्या है, नाउ आई वांट यू टू ऑल अंडरस्टैंड व्हाट इज अ नॉर्मल ब्लड प्रेशर एंड व्हाट इज अबनॉर्मल ब्लड प्रेशर. तो जो नॉर्मल ब्लड प्रेशर होता है, ऊपरी ब्लड प्रेशर और द अपर ब्लड प्रेशर इज 120 and the lower blood pressure is 180. Anything less than 120 and less than 80 is normal. What is elevated? मतलब हाई किसको बोलते हैं? 120 के ऊपर अगर ब्लड प्रेशर जाता है, एनी ब्लड प्रेशर गोइंग अबव 120 and or a lower blood pressure going above 80 is known as high blood pressure. जितना ये बीपी ऊपर जाता जाएगा वैसे the grade of blood pressure will keep going up. एंड जितना सीवियर ब्लड प्रेशर होगा उतने शरीर में डैमेज होंगे. ब्लड प्रेशर कितना कॉमन है? नॉर्मल ब्लड प्रेशर इज ओके, बट हाई ब्लड प्रेशर, हाउ कॉमन इज इट? सो द हाई ब्लड प्रेशर मोस्ट ऑफ द पीपल डू नॉट नो. ये एक WHO के रिलीज किया हुआ नंबर है कि भैया लोगों को बीपी है या हाई बीपी है उन्हें पता नहीं है. सो व्हाट हैज WHO मेंशन that 1 in 4 men, मतलब आदमियों को 4 आदमी में से एक आदमी को हाई ब्लड प्रेशर होने की शक्यता है. और लेडीज में, विमेन में 5 में से एक लेडीज को हाई ब्लड प्रेशर होने की संभावना होती है. तो ये एक बहुत बड़ा नंबर है, मतलब इसको हम निग्लेक्ट नहीं कर सकते हैं. डायग्नोसिस कैसे होता है? इट डिपेंड्स कि तुम्हारा बीपी का रीडिंग कैसा है और बीपी एक्यूरेटली कितना लिया गया है. Usually, what do we tell patients? That whenever you are taking BP, you should not have done any strenuous exercise. मतलब कि कोई एक्सरसाइज, सिवियर वर्जिश या एक्सरसाइज करके आप इमीडिएटली बीपी मत लो. आपने जस्ट खाना खाया है, स्मोकिंग किया है, आप चल के आए हो, आप हॉस्पिटल में जस्ट एंटर किए हो, तो ये सारी एक्टिविटीज अगर आपने की है और इमीडिएटली आप ब्लड प्रेशर ले रहे हो तो वो गलत आएगा. तो हमारा डायग्नोसिस हाई ब्लड प्रेशर का कब होगा? जब 2 या 3 बार कॉन्स्टेंटली हाई रीडिंग आए और उसमें ये सारे पॉइंट्स निकल गए हो कि भाई स्मोकिंग किया हो, कुछ खाना खाया हो, चल के आए हो, एक्सरसाइज किया हो, एटलीस्ट 5 से 6 मिनट आदमी ने आराम से बैठा हो इन अ वेल लिट रूम, आराम से 2-3 रीडिंग लिए हैं, फिर भी अगर हाई आता है तो उसको हम हाई ब्लड प्रेशर बोलते हैं. कभी कभी पेशेंट्स क्या हमें बोलते हैं कि नहीं डॉक्टर, वो तो मैं चल के आया था, मैं बहुत टेंशन में था इसलिए बीपी हाई है. तो वो नेगेट करने के लिए वी ऑलवेज टेल पेशेंट्स दैट व्हेन यू कम टू द हॉस्पिटल यू सिट फॉर सम टाइम. और आजकल तो वी ऑलवेज टेल कि होम ब्लड प्रेशर इज ऑलवेज बेटर बिकॉज यू आर इन अ रिलैक्स्ड एनवायरनमेंट. अब हाई ब्लड प्रेशर किसको हो सकता है? तो हाई ब्लड प्रेशर उसको होता है जो स्मोक कर रहा है, जिसको डाइट हैबिट्स बहुत खराब है, मतलब प्रोसेस्ड चीजें खाते हैं, फिजिकल एक्टिविटी जिसकी कम है, जो ओबीज है, मतलब कि जो ओवरवेट है और जिनका वजन बहुत ज्यादा है, जो बहुत अल्कोहल लेता है, मतलब किसी के दारू का सेवन बहुत ज्यादा हो, अल्कोहल इंटेक ज्यादा हो, जिसको बहुत स्ट्रेस रहता हो फॉर वॉट एवर रीजन, ये एक मॉडिफाइबल रिस्क फैक्टर में आता है क्योंकि ये हमारे हाथ में है. मॉडिफाइबल, नॉन मॉडिफाइबल का मतलब ये है कि कुछ चीजें हमारे हाथ में नहीं होती हैं, उनको हम मॉडिफाई नहीं कर सकते. दैट इज नॉन मॉडिफाइड. व्हाट इज नॉन मॉडिफाइबल? हमारी उम्र जैसे जैसे बढ़ेगी कभी ना कभी बीपी शायद आएगा. किसी को फैमिली हिस्ट्री है, हेरिडिटरी हिस्ट्री है, तो उसको आप मॉडिफाई नहीं कर सकते. लेकिन उसको आप कम जरूर कर सकते हैं, क्योंकि अगर आप अच्छा लाइफस्टाइल मेंटेन करेंगे, डाइट अच्छे से मेंटेन करेंगे, आप ऐसी चीजें ना करें जिससे बीपी बढ़े, तो आपको फैमिली हिस्ट्री होने के बावजूद हाइपरटेंशन का असर कम होगा। अगर आपको ऑलरेडी कुछ हेल्थ कंडीशंस है, जैसे किडनी प्रॉब्लम है, हार्ट प्रॉब्लम है, डायबिटीज है, ऐसी चीजें अगर हैं, तो आपको बीपी होने की शक्यता ज्यादा है। अब ये हमारे हाथ में कम है। मॉडिफाइबल क्या है? जो हमारे हाथ में है। हमारे हाथ में क्या है कि हम स्मोकिंग ना करें, हम डाइट अच्छा खाएं, बहुत फाइबर्स, वेजिटेबल्स, फ्रूट्स वाला डाइट खाएं, अच्छा फिजिकल एक्टिविटी रखें, रोज हम थोड़े से स्टेयरकेसेस चढ़े, हम थोड़ा वॉकिंग करें, हम थोड़ा एक्सरसाइज करें, जहां मौका मिले हम एक्सरसाइज करें, वजन कंट्रोल में रखें, दारू की इनटेक की मात्रा हम कंट्रोल में रखें, सोशल ड्रिंकिंग इज ओके लेकिन बिंज ड्रिंकिंग ना करें, और स्ट्रेस लेवल कम करने के लिए हम मेडिटेट करें। तो ये रिस्क फैक्टर्स होते हैं जो सबके ध्यान में होने चाहिए। अब ये मैंने आपको बताया कि कारण क्या होते हैं, तो कारण और रिस्क फैक्टर्स एक दूसरे पे ओवरलैप होते हैं, कि कभी कभी पेशेंट बोलते हैं अरे मुझे तो बीपी होना ही नहीं चाहिए क्योंकि मेरे पास ऐसे रिस्क फैक्टर्स हैं नहीं, लेकिन ऐसा हम सोचते हैं। हमें देखना चाहिए कि हमें ऐसा तो कोई बीमारी नहीं है जिसकी वजह से बीपी हो रहा है, जिसको सेकेंडरी हाइपरटेंशन बोलते हैं, मतलब किसी चीज की वजह से बीपी होने को सेकेंडरी हाइपरटेंशन बोलते हैं। पहली चीज है ऑब्स्ट्रक्टिव स्लीप एपनिया। तो ये क्या होता है कि भाई हम जब सोते हैं तो हम खर्राटे लेते हैं। ये खर्राटे लेने का मतलब ये हुआ कि हमारे ब्रेन को बीच बीच में ऑक्सीजन कम मिलती है, कार्बन डाइऑक्साइड ज्यादा हो जाता है, हमारी नाक में शायद ये हड्डी टेढ़ी होने से ऑक्सीजन अंदर नहीं जा पाता है, हम अगर मोटे हैं, हमारा नेक अगर छोटा है, तो ब्रीदिंग सीधे से लंग में ऑक्सीजन लेने के में रुकावट आती है। ये चीजें अगर हैं तो बीपी बढ़ेगा, और इसका ट्रीटमेंट करने से बीपी रिवर्स भी हो जाएगा। किसी को किडनी प्रॉब्लम है, अगर किडनी प्रॉब्लम को हमने हैंडल किया तो बीपी अपने आप ठीक हो जाएगा, क्योंकि किडनी के हाथ में होता है बीपी कंट्रोल करना। किसी को हार्ट का प्रॉब्लम है, वैल्व का प्रॉब्लम है, तो भी ब्लड प्रेशर हो सकता है। कोई अगर ड्रग्स करता है, मतलब कि कोकेन, हशीश ये सब खाता है, तो इन चीजों से भी बीपी बढ़ता है। और कभी हार्मोनल डिसबैलेंस हो, जैसे थायराइड का प्रॉब्लम हो या एड्रेनल ग्लैंड का प्रॉब्लम है, तो ये सब मेडिकल चीजें होती है। तो कभी भी हमें हाइपरटेंशन दिखता है, हाई ब्लड प्रेशर दिखता है, तो एज डॉक्टर्स हम ये सब जांच पहले करते हैं। फिर जो मैंने आपको बताया कि प्राइमरी हाइपरटेंशन मतलब कुछ भी कारण के बिना बीपी आना, तो वो जेनेटिक है, हेरिडिटरी, मतलब हमें फैमिली हिस्ट्री में आना। कोई स्मोकिंग कर रहा है, कोई बहुत सॉल्ट खाता है, क्योंकि सॉल्ट इज डायरेक्टली रिलेटेड टू हाई ब्लड प्रेशर, कोई एक्सरसाइजेस कम कर रहा है, कोई उम्र वाला हो रहा है और खाने पीने में प्लस माइनस हो रहा है, तो ये सारी चीजों से बीपी आता है। और ये कॉमनली अपने को ध्यान में रखना चाहिए कि हम में ये कुछ भी चीज है तो उसको हमें अभी बंद करना। अगर किसी को हाई ब्लड प्रेशर है तो क्या होगा उस पेशेंट को, मतलब आपको पता कैसे चलेगा कि हाई बीपी है? आदमी ऐसे तनाव में तो नहीं रह सकता कि भाई मुझे हाई बीपी होगा तो क्या होगा, आप रोज रोज तो चेक नहीं कर सकते। तो लोगों को कभी नाक में से ब्लीडिंग हो सकता है, हेडेक्स होने लगे, और हमें लगे कि भाई बहुत टेंशन है इसलिए हमें हेडेक हो रहा है। सो इफ समवन इज गेटिंग परसिस्टेंट हेडेक्स और किसी को पेन किलर्स खाने की जरूरत पड़ जाए, तो उसको चेक करना जरूरी है। किसी को छाती में दुखने आए, मतलब इफ समवन इज गेटिंग चेस्ट पेन, तो दैट कैन बी अ साइन ऑफ हाई ब्लड प्रेशर। Someone getting blood in urine can also be a sign of high blood pressure. Someone feeling short of breath, मतलब सांस लेने में दिक्कत हो, किसी को वॉमिटिंग नौशिया जैसा हो, धड़कन बढ़ जाए शरीर की, हार्ट की, किसी को चक्कर आए और हेडेक हो रहा हो, आंखों से धुंधला दिख रहा हो, ये सारे साइंस हैं कि किसी को बीपी हाई हो सकता है। अगर आप में से किसी को ऐसा लगता है कि नहीं नहीं मुझे ऐसा हो रहा है, तो अपने को बीपी चेक करना है, और ये चीजें ध्यान में रखनी है। क्यों? क्योंकि अपना तो ध्यान रखना है, लेकिन अपने आजू बाजू वालों को भी ऐसा कुछ है तो हमें अलर्ट रहना है। अब हाई ब्लड प्रेशर इतना डेंजरस क्यों है, मतलब हम क्यों इसको इतना दबाव दे रहे हैं कि भाई बीपी को हमें जांचना है, बीपी को हमें डायग्नोज करना है, अगर हमें बीपी है तो हमें सिम्टम्स क्या है? क्यों? क्योंकि बीपी एक हानिकारक चीज है। तो ये क्या हानि कर सकता है, अपने शरीर में डैमेज क्या कर सकता है? तो जो हाई ब्लड प्रेशर है, ये चीज अपनी आंखों को डैमेज कर सकता है। जो पर्दे होते हैं आंखों के, उसमें वो हेमरेजिस कर सकता है, जैसे मेरा एरो बता रहा है यहाँ पे। फिर अपना जो ब्रेन है, अपना जो मस्तिष्क है, जिसमें हमारा दिमाग रहता है, इसकी जो धमनियां रहती है या ब्लड सप्लाई के लिए ब्लड वेसल्स रहती है, इसमें जो नैरोइंग हो जाता है और ब्लड, हमारा जो खून है वो ब्रेन तक पहुंच नहीं पाता है, और ऑक्सीजन की कमी के कारण कभी कभी पैरालिसिस हो सकता है। हार्ट की आर्टरीज में प्रॉब्लम करके वो हार्ट अटैक दे सकता है, हार्ट फेलियर हो सकता है, किसी को किडनी फेलियर हो सकता है। क्यों? क्योंकि हाई ब्लड प्रेशर से किडनी श्रिंक हो जाती है। तो ये चीजें हमें जानना बहुत जरूरी है कि सिर्फ हाई बीपी को हम ऐसे निग्लेक्ट नहीं कर सकते, इग्नोर नहीं कर सकते, क्योंकि इससे हमें धीरे धीरे हमारे सारे जो ऑर्गन्स होते हैं, हमारे जो ब्रेन होता है, हार्ट होता है, किडनी होता है, आईज होती हैं, ये सारी चीजों को नुकसान पहुंच रहा है, और ये इरिवर्सिबल नुकसान पहुंच रहा है। अगर हमने बहुत पहले के दर्जे में हमने पकड़ लिया इसको कि भाई बीपी है, चलो बीपी को हम ट्रीट करते हैं, तो ये सारा नुकसान नहीं होगा। लेकिन अगर हमने उसको छोड़ दिया कि भाई बीपी की दवाई क्यों लेनी है, थोड़ा ही तो बीपी है, तो उससे क्या होगा, अंदर नुकसान चालू रहेगा और हमें पता नहीं चलेगा। कुछ पेशेंट्स हमारे पास ऐसे आते हैं जो हमें बताते हैं कि डॉक्टर 3-4 साल पहले थोड़ा बीपी डिटेक्ट हुआ था, लेकिन हमने सोचा टेंशन के कारण है, तो फिर हमने कुछ चेक नहीं किया और फिर मुझे कुछ प्रॉब्लम नहीं हुआ, तो मैंने कुछ नहीं किया, और अब क्रिएटिनिन 6 है। क्रिएटिनिन मतलब एक किडनी का मार्कर होता है जो किडनी फेलियर के पेशेंट में बढ़ जाता है, तो मतलब वो बीपी कंट्रोल में नहीं रहने से किडनी को नुकसान हो गया। तो ये चीजें हमें ध्यान में रखनी है कि ऐसी चीजों को नजरअंदाज नहीं करना चाहिए। तो अब किसी को पता चल गया है कि बाबा बीपी है, ब्लड प्रेशर अपना हाई है, तो हम दूसरे शरीर के अवयव, मतलब ऑर्गन्स जो मैंने बताया, ब्रेन है, हार्ट है, किडनी है, उसको नुकसान पहुंच रहा है कि नहीं पहुंच रहा है, हमें कैसे पता चलेगा? तो जाहिर सी बात है, पहले तो हम ब्लड प्रेशर मॉनिटरिंग रखेंगे। दूसरा, हम रेगुलरली 6 से 8 महीने में एक बार ब्लड और यूरिन टेस्ट करेंगे। क्यों? क्योंकि खून की जांच से पता चलेगा कि कोलेस्ट्रॉल वगैरह बढ़ा है कि नहीं। पेशाब में अगर प्रोटीन जाने लगा है, पेशाब में अगर ब्लड जाने लगा है, तो समझ में आएगा कि किडनी को नुकसान चालू हुआ है। आइस का चेक करेंगे कि भाई आइस की जो आर्टरीज है, जो रक्त की धमनियां है, उसमें कुछ नुकसान तो नहीं हुआ है। हमें और कुछ बड़ी-बड़ी टेस्ट करने की जरूरत नहीं है, बस हमें पता होना चाहिए कि ब्रेन, आईज, किडनी, हार्ट चेक कर लेना है। उसके लिए बेसिक बेसिक टेस्ट है जो हमने 6 से 8 महीने में अगर किए तो हम सेफ रहेंगे, क्योंकि कुछ भी नया आ रहा है तो हम अलर्ट हो जाएंगे। अब बात होती है प्रिवेंशन की कि भाई हम उतने तक रुके ही क्यों कि हमें बीपी हो। अगर हमें रिस्क फैक्टर्स है तो हमें उसको निकालना चाहिए। अगर हम सीडेंटरी लाइफस्टाइल जीते हैं कि हम बराबर एक्सरसाइज नहीं करते, रोज हम बैठालू जीवन जी रहे हैं, तो हमें रोज एक्सरसाइज करना है। सॉल्ट एक बहुत बड़ी चीज है। सोडियम जो होता है उसको हमें लिमिट में लेना है, और अगर किसी को अल्कोहल की आदत है तो उसको कम से कम देना है। बहुत डाइट रिच इन फ्रूट्स एंड वेजिटेबल्स अगर हम लेंगे और हेल्दी पोषक डाइट लेंगे तो उससे ब्लड प्रेशर, डायबिटीज जैसी चीजें अवॉइड होंगी। स्मोकिंग बंद कर दीजिए, जितना हो सके उतना चालू मत कीजिए, और अगर स्मोकिंग चल रहा है तो बहुत कोशिश करके उसको बंद करना है, क्योंकि उससे हमारी सारी नलियां डैमेज हो जाती हैं। बॉडी वेट को कंट्रोल में रखिए। आपको पता है कि हार्ट अटैक होने के चांसेस बीपी वाले पेशेंट्स में ज्यादा है, तो इसीलिए हम ये कोशिश करेंगे कि जिसको किसी को बीपी हो वो पहले ही लाइफस्टाइल चेंजेस करें, योगा जैसी चीजें ऐड करें कि भाई हम अच्छा खाना खाएं, बाहर का पैकेज फूड ना खाएं, प्रोसेस्ड फूड ना खाएं। बराबर है? तो अगर स्ट्रेसफुल लाइफ है तो योगा ऐड करने से हमें वो बेनिफिट मिल जाता है कि भाई उस फैक्टर की वजह से हमारा बीपी ना बढ़े। ट्रीटमेंट क्या होता है? ऑफ कोर्स पहले लाइफस्टाइल चेंजेस होती हैं, मतलब वो तो करना अनिवार्य है। मतलब रोज अगर 15 से 20 मिनट हम ब्रिस्क वॉकिंग करते हैं, ऐसा बोला जाता है कि 25 मिनट ब्रिस्क वॉकिंग अगर हमने किया तो हमारा ब्लड प्रेशर 10 मिलीमीटर से नीचे आके कंट्रोल में आ जाता है, तो दवाई की जरूरत ही नहीं पड़ेगी। हमारे डाइट को हम रेक्टिफाई करें, हम कम से कम सॉल्टी चीजें खाएं, सॉल्ट जितना जरूरत हो उतना ही डालें और कम से कम खाएं। वेट लॉस करना चाहिए अगर हम ओवरवेट हैं तो। मतलब ये चीजें इंपॉर्टेंट है। लास्ट बट नॉट द लीस्ट, हमारी बीपी की दवाइयां, अगर हमें किसी डॉक्टर ने बीपी की दवाई शुरू की है तो उनसे पूछे बिना, उनसे जांच किए बिना अपने आप से बंद नहीं करना है। कई बार पेशेंट्स को ऐसा समझता है कि चलो तब बीपी हाई था, वी हैव गिवन ब्लड प्रेशर मेडिसिन एंड नाउ बीपी इज ओके, लेट अस स्टॉप। बट दैट इज नॉट द फैक्ट। क्या होता है कि ब्लड प्रेशर की दवाइयां आपने बंद की, थोड़े दिनों के बाद बीपी बढ़ने लगेगा और आपको पता नहीं चलेगा, देन इट विल स्टार्ट डैमेजिंग। सो व्हेनेवर यू फील दैट ओके नाउ द बीपी इज नॉर्मल, आपके डॉक्टर के पास जाइए, वो आपको धीरे धीरे बीपी की मेडिसिन एडजस्ट करके अगर बंद कर सकते हैं तो करेंगे, बट नॉट एट द कॉस्ट ऑफ हैविंग अ हाई ब्लड प्रेशर। ओके, एंड दिस लुक्स लाइक द लास्ट स्लाइड फॉर अस टुडे। बट इन शॉर्ट, हमें ब्लड प्रेशर घर पे मॉनिटर करने की थोड़ी आदत निकालनी चाहिए कि भाई मैं तो अपने पेशेंट्स को बोलती हूँ कि आप जब घर पे हो तो हफ्ते में 2 या 3 बार रैंडम टाइम पे आप बीपी चेक कीजिए, आप बीपी का रिकॉर्ड रखिए और जब भी फॉलोअप के लिए आते हैं वो नोटबुक लेके आई तो हमें पता चलेगा, क्योंकि हॉस्पिटल की बीपी कभी कभी हायर साइड पे दिखती है। और जैसे मैंने बताया, आपको ब्लड प्रेशर रेस्टिंग पोजीशन में लेना है। आपको ये देखना है कि आप इमीडिएटली खाना खा के बीपी लेने नहीं बैठे हैं, आप कहीं बाहर बाजार से जाके आए और इमीडिएटली नहीं बैठे हैं। सो यू हैव टू अंडरस्टैंड कि एक रिलैक्स पोजीशन में 5 से 10 मिनट बैठ के फिर ब्लड प्रेशर लेना है। आपके पास घर पे कोई भी डिजिटल मशीन होगा चलेगा, आपको ये क्रॉस चेक करने के लिए हॉस्पिटल में ला सकते हैं कि भैया ये मशीन ठीक है कि नहीं। दैट वे यू आर श्योर कि आप जो बीपी ले रहे हो वो ठीक है। ओके, सो इससे मैं एंड करती हूँ एंड इन द एंड वी विल टेक क्वेश्चन एंड आंसर्स। लेकिन मॉरल ऑफ द स्टोरी, ब्लड प्रेशर रेगुलरली चेक होना चाहिए और कभी भी बीपी हाई है निग्लेक्ट नहीं होना चाहिए। थैंक यू। ओवर टू यू डॉक्टर अनीता।
Yeah. Thank
I
you,
will
Dr.
stop
Shruti.
share. Yes.
Right. Yeah. Thank you, Dr. Shruti. That was a wonderful, short. Yeah, sorry, there was some interruption. Thank you, Dr. Shruti. It was a wonderful talk. Such a short and crisp way of explaining to the patients and to every one of us how to look after the blood pressure. And also, as Dr. Shruti has already said, that we'll take the question answers later on. So we move on to the next talk, which is, well, it is my pleasure to invite Dr. Sneha Kothari, who is MD General Medicine and DNB Endocrinology, and is a consultant diabetologist and endocrinologist at Global Hospitals, Parel, Mumbai. Her areas of interest are diabetes mellitus, thyroid, polycystic ovaries, and adrenals. And she's going to discuss with us how to control blood glucose. Over to Dr. Kothari.
I'm not getting the option of share screen पे my PPT का thing.
For you have to open the PPT first.
I have opened the PPT in the background, but still I'm not getting that option.
Ma'am.
When I click on the share screen.
Yes, ma'am. And then select the select any screen, select the screen in front of you so that your entire screen will be shared.
It's not showing. I don't know. On the desktop, it's showing some exclamatory marks. I don't know. It's not been able to access the.
Ma'am, kindly drop your PPT in chat. I will share it from here, and
I will email the PPT to you.
ma'am, just drop in chat. Ma'am, just drop in chat. You click on chat. Just behind, just beside the, ma'am, there will be one smiley, and there is one document sign is there.
Okay.
Click on that document sign, select the PPT, and select my name. So your PPT will come to me now, and I will share it from here.
I have shared the PPT. You have got the PPT? I've sent the PPT. Have you received it?
Yes, ma'am. Just 1 minute.
Yeah. Yes. Thank you, ma'am, for the kind introduction. And I'm sorry for the technical delay. So I'm a consultant endocrinologist at Global Hospital. So today we will learn कि डायबिटीज क्या होता है, डायबिटीज को कंट्रोल में करना क्यों जरूरी है, और अगर डायबिटीज को हमने कंट्रोल में नहीं रखा तो क्या कॉम्प्लिकेशंस हो सकते हैं. तो नेक्स्ट स्लाइड प्लीज. We all know that India is a diabetes capital. और कॉमन रीजन इंडिया में डायबिटीज क्यों बढ़ रहा है, वो रीजन है कि मोटापे की वजह से पेशेंट्स में ज्यादा से ज्यादा डायबिटीज का प्रमाण देखा गया है. आज तक हम लोग देखते थे कि टाइप 2 डायबिटीज यूजुअली 50-55 इयर्स के ऊपर के अडल्ट्स में देखा जाता था, बट ओपीडी में आजकल हम देखते हैं कि काफी सारे यंग अडल्ट जो मल्टीनेशनल कंपनीज में काम करते रहते हैं बिकॉज ऑफ मोटापा, उनमें हम लोग अभी 30-35 इयर्स के पेशेंट्स में भी काफी बार टाइप 2 डायबिटीज देख रहे हैं. सो ऑन एन एवरेज 3 में से 1 अडल्ट ओवरवेट होएगा और उसमें से 1 में से 10 ओबीज रहते हैं और उनमें डायबिटीज का प्रोपोर्शन काफी ज्यादा है. नेक्स्ट स्लाइड प्लीज. सो डायबिटीज ना ही हाई, पहले हम बोलते थे कि डायबिटीज है अमीरों की बीमारी है, बट अभी ऐसा नहीं रहा है. हमने देखा है कि डायबिटीज ना कि खाली अमीरों में देखा जाता है, बट लो एंड मिडिल क्लास ग्रुप में भी काफी कॉमनली देखा जाता है. नेक्स्ट स्लाइड प्लीज. ये सिर्फ नंबर्स है. अगर आप देखें तो 10 में से 3 लोगों में डायबिटीज का प्रमाण रहता है इंडिया में. और डायबिटीज को कंट्रोल करना क्यों जरूरी है, हम लोग आज वर्ल्ड किडनी डे के लिए सब एक डिस्कशन कर रहे हैं. तो डायबिटीज इज द कॉमनेस्ट रीजन फॉर किडनी फेलियर. ना कि वो सिर्फ किडनी फेलियर करता है, बट डायबिटीज के हिसाब से ब्लाइंडनेस, हार्ट डिसीज और फुट एम्पुटेशन के चांसेस भी बहुत ज्यादा है. और ऑन एन एवरेज 1 मिलियन पीपल डाई जस्ट बिकॉज दे हैव डायबिटीज विच इज अनकंट्रोल्ड. नेक्स्ट स्लाइड प्लीज. सो हम सुनते हैं कि इंडिया, चाइना, ये 2 कंट्रीज में डायबिटीज का प्रोपोर्शन बहुत ज्यादा है. तो ये क्यों ज्यादा है? नेक्स्ट स्लाइड प्लीज. यहाँ पे एक पिक्चर है. यहाँ पे हम देख रहे हैं कि लेफ्ट साइड में एक फॉरेनर है एंड राइट हैंड साइड पे डॉक्टर याग्निक है जो पूना में काफी फेमस कंसल्टेंट डायबिटोलॉजिस्ट एंड एंडोक्राइन है. ये पिक्चर को हम वाई पैराडॉक्स बोलते हैं. तो अगर आप देखोगे तो प्रोफेसर याग्निक का भी बॉडी मास इंडेक्स जो हाइट और वेट का रेशियो है वो 22 है और प्रोफेसर याग्निक का 22.3 है. तो दोनों का बीएमआई सेम है. लेकिन जब इन दोनों का बॉडी फैट एनालिसिस किया गया तो आप देखोगे कि प्रोफेसर याग्निक के जो टीचर है उनका बॉडी मास इंडेक्स में फैट का पोर्शन सिर्फ 9% है, लेकिन इंडियंस में फैट का पोर्शन इज 21। सो उसी बॉडी मास इंडेक्स पे प्रोपोर्शन ऑफ फैट बेली पे इंडियंस में बहुत ज्यादा है, और ये बेली फैट कॉमन रीजन है ये सब बीमारियों का। तो ये सब बीमारियां जो बेली फैट के हिसाब से होती है वो है डायबिटीज है, ब्लड प्रेशर है, कोलेस्ट्रॉल का प्रॉब्लम है, हार्ट प्रॉब्लम है, फैटी लीवर जो आजकल बहुत ही कॉमनली देखा जाता है, और यंग फीमेल्स में पॉलिसिस्टिक ओवरीज डिसीज का। तो ये सब मोटापे के साथ में लिंक्ड है, और इसको हम मेडिकल लैंग्वेज में मेटाबॉलिक सिंड्रोम बोलते हैं। तो ऑन एन एवरेज ना कि सिर्फ मोटा होना इज अ कॉमन रिस्क फैक्टर, बट जिसके पेट पे चर्बी ज्यादा है उसमें भी डायबिटीज होने के चांसेस काफी ज्यादा होते हैं। नेक्स्ट स्लाइड। सो हम दो पेंडेमिक देख रहे हैं, एक डायबिटीज और ओबेसिटी, जिसको हम टर्मिनोलॉजी में यूज करते हैं डायबेसिटी। नेक्स्ट स्लाइड प्लीज। सो डायबिटीज क्या है? हम दिन रात सुनते रहते हैं कि मेरे इस पड़ोसी को डायबिटीज है, उस रिश्तेदार को डायबिटीज है। तो डायबिटीज को हार्मोन जो मेनली कंट्रोल करता है वो है इंसुलिन हार्मोन। नेक्स्ट स्लाइड प्लीज। तो डायबिटीज ये कंडीशन है जिसमें ब्लड में शुगर कंटिन्यूसली रेज रहती है, और शुगर कंटिन्यूसली रेज होने की वजह से वो बॉडी के डिफरेंट ऑर्गन्स को डैमेज करता है, राइट फ्रॉम हेड टू टो। कॉमन साइड इफेक्ट जो हम देखते हैं वो किडनी और हार्ट को इफेक्ट करता है, और फुट में काफी बार अल्सर्स होके फुट एम्प्यूट होने के भी चांसेस रहते हैं। नेक्स्ट स्लाइड। नेक्स्ट स्लाइड। तो जब हम खाना खाते हैं, तो वो इंटेस्टाइन में से डाइजेस्ट होके ब्लड में शुगर बनाता है, और शुगर पैनक्रियास में जाके बॉडी में से इंसुलिन बनाने के लिए सिग्नल देते हैं, और जब इंसुलिन बॉडी के सेल्स पे काम करता है तो बॉडी के सेल्स ग्लूकोज को लेके उसको मेटाबोलाइज करते हैं। लेकिन जब बॉडी इंसुलिन नहीं बना पाता, जिसको हम टाइप 1 डायबिटीज बोलते हैं, जहाँ पे इंसुलिन की बनावट बिल्कुल भी रुक चुकी है, या तो जहाँ पे इंसुलिन बन रहा है लेकिन इंसुलिन का इफेक्ट नहीं आ रहा है, जिसको हम टाइप 2 डायबिटीज बोलते हैं। इसमें इंसुलिन हो या ना हो, ये तो टाइप 1 डायबिटीज में इंसुलिन है नहीं, और टाइप 2 डायबिटीज में होने के बावजूद भी इंसुलिन काम नहीं कर पा रहा है। तो उसकी वजह से क्या होता है, बॉडी में जो शुगर बना है ब्लड में वो सेल्स में नहीं जाता है, और ब्लड में कंटिन्यूअसली शुगर की लेवल हाई रहती है, जिसके हिसाब से बॉडी में ऑर्गन्स को डैमेज का प्रॉब्लम होता है। नेक्स्ट स्लाइड। तो टाइप 1 डायबिटीज यूजुअली यंग पेशेंट्स में देखा जाता है। इसका कॉमन कारण होता है ऑटो इम्यून मतलब जहाँ पे बॉडी के सेल्स ही खुद के इंसुलिन प्रोड्यूसिंग पेशी को डैमेज करना चालू करते हैं। नेक्स्ट स्लाइड प्लीज। दूसरे प्रकार का डायबिटीज जो ज्यादा कॉमन है वो टाइप 2 डायबिटीज है, और टाइप 2 डायबिटीज आजकल हम, जैसे मैंने बताया कि छोटी उम्र में काफी कॉमनली देख रहे हैं, लाइक 30 ईयर्स के अबो भी देख रहे हैं। इनफैक्ट काफी सारे स्कूल गोइंग किड्स जिनमें मोटापे का प्रॉब्लम कॉमन है, उनमें भी हम लोग काफी टाइप 2 डायबिटीज देख रहे हैं। आज तक ऐसे था कि अगर छोटा बच्चा 10 ईयर्स का अगर आया और उसको डायबिटीज है तो मे बी ही इज मोस्टली टाइप 1 डायबिटिक, but nowadays we see many type 2 diabetic kids also coming into OPD, and that is just because of the obesity prevalence जो बढ़ गया है। जंक फूड का अवेलेबिलिटी बहुत इजीली है, एक्सरसाइज नहीं हो पा रहे, और कोविड के पेंडेमिक में तो देखा है कि बच्चों को ना स्कूल जाना है ना क्लासेस जाना है, सब घर पे बैठे बैठे करना है, तो मोटापे का प्रोपोर्शन भी काफी बढ़ चुका है। नेक्स्ट स्लाइड। तो यही है कि टाइप 2 डायबिटीज में इंसुलिन बन तो रहा है, सिग्नल दे रहा है सेल्स को, लेकिन सेल्स सिग्नल बराबर से नहीं ले पा रहे, और बोलते हैं कि शुगर मैं नहीं लूंगा, सेल्स ऐसे बोल रहे हैं, और इसके हिसाब से ब्लड में कंटिन्यूसली शुगर का पोर्शन हायर साइड पे रहता है। नेक्स्ट स्लाइड। तो पेशेंट्स पूछते हैं कि अगर मेरे पेरेंट्स को डायबिटीज है तो व्हाट इज द चांस दैट आई विल आल्सो गेट डायबिटीज इन फ्यूचर। जैसे डॉक्टर श्रुति ने बोला कि अगर आप लाइफस्टाइल अच्छे से मेंटेन करो तो हाइपरटेंशन को हम प्रिवेंट कर सकते हैं। सिमिलरली अगर फैमिली में स्ट्रॉन्ग हिस्ट्री है टाइप 2 डायबिटीज का, लेकिन अगर आप हेल्दी लाइफस्टाइल फॉलो करो, वजन को ना बढ़ने दो और पेट का घेर ना बढ़ने दो, तो काफी बार डायबिटीज के चांसेस बहुत ही कम हो जाते हैं। हम जीन्स को तो मॉडिफाई नहीं कर सकते, बट मेंटेनिंग हेल्दी लाइफस्टाइल डेफिनेटली अपने हाथ में है। तो अगर पेशेंट को फैमिली हिस्ट्री है, मोटापा है, ब्लड प्रेशर है, और जिस फीमेल्स को प्रेगनेंसी में डायबिटीज की शिकायत थी, ऐसे लोगों में आगे जाके डायबिटीज होने के चांसेस काफी ज्यादा होते हैं। वन ऑफ द कॉमन रीजंस फॉर डायबिटीज इंक्रीजेस स्ट्रेस एंड ऑफ कोर्स सेडेंटरी लाइफस्टाइल। नेक्स्ट स्लाइड प्लीज। तो सिम्टम्स क्या होते हैं डायबिटीज के? ये चीज याद रखना है कि 80 to 90% ऑफ टाइप 2 डायबिटिक पेशेंट्स को कोई भी सिम्टम्स नहीं होते हैं। वो रूटीन चेकअप के लिए जाते हैं और तब पता चलता है कि टाइप 2 डायबिटीज है। और एक चीज याद रखनी है कि 5 to 10% ऑफ पेशेंट्स ऐसे भी होते हैं जिनको पता ही नहीं होता है कि डायबिटीज है, वो सीधा एंड ऑर्गन डैमेज मतलब किडनी फेलियर या हार्ट फेलियर या हार्ट में अटैक आने की वजह से एडमिट होते हैं। तो इसके लिए सबसे इम्पोर्टेंट चीज ये है कि हम रेगुलर ब्लड चेकअप कराएं, ताकि उसमें अपने को पता चले डायबिटीज है कि नहीं। स्पेशली जिनमें फैमिली हिस्ट्री डायबिटीज की काफी स्ट्रांग है, ऐसे पेशेंट्स को साल में एक बार तो एटलीस्ट शुगर का चेकअप करना चाहिए। जिनको शुगर बहुत ही ज्यादा मात्रा में, ऐसे पेशेंट्स को प्यास बहुत लगना, वजन कम हो जाना, बार बार यूरिन के लिए जाना, ये 3 सिम्टम्स काफी कॉमन होते हैं। डायबिटीज के पेशेंट्स में काफी बार इम्यूनिटी कम होने की वजह से स्किन पे फंगल इन्फेक्शन, यूरिन में इन्फेक्शन, ब्लरिंग ऑफ द विजन्स और काफी बार जख्म ठीक से नहीं भरना, ये भी सिम्टम्स होते हैं। बट कीप वन थिंग इन माइंड, मेजोरिटी ऑफ टाइप 2 डायबिटिक पेशेंट्स डोंट हैव एनी सिम्टम्स। नेक्स्ट स्लाइड प्लीज। So what are the normal blood sugar levels? नॉर्मल ब्लड शुगर लेवल, फास्टिंग शुगर लेस देन 100 और खाने के बाद का शुगर लेस देन 140 इज नॉर्मल ब्लड शुगर लेवल। और डायबिटिक स्टेट किसको बोलते हैं? जिसका फास्टिंग शुगर 125 के ऊपर है और जिसका खाने के बाद का शुगर 200 के ऊपर है। पहले सिर्फ फास्टिंग और पोस्ट मील शुगर को चेक किया जाता था, आजकल हम लोग HbA1c भी करते हैं डायबिटीज के डायग्नोसिस के लिए। तो कोई पेशेंट जिसका HbA1c 6.5 के ऊपर है उसको हम डायबिटिक स्टेट में काउंट करते हैं। नेक्स्ट स्लाइड प्लीज। अभी नया टर्मिनोलॉजी, अभी तो नहीं, फिलहाल पिछले 4-5 साल से इम्पेयर्ड प्री डायबिटीज करके एक नया टर्मिनोलॉजी आया है। तो ये प्री डायबिटीज क्या है? जिसको नॉर्मल शुगर और डायबिटीज के बीच वाली शुगर रीडिंग है उसको हम प्री डायबिटीज बोलते हैं। मतलब जिसका 3 मंथ्स का शुगर का एवरेज 5.7 to 6.4 के बीच में है। अब ये प्री डायबिटिक स्टेट को जानना जरूरी क्यों है? एक चीज याद रखना कि प्री डायबिटिक स्टेट काफी बार रिवर्सिबल है। प्री डायबिटिक पेशेंट्स काफी बार ओबीज रहते हैं, अगर एक अच्छी लाइफस्टाइल फॉलो करें, वजन को कंट्रोल करें, वेट लॉस करें, डाइट को रेगुलेट करें, एक्सरसाइज रेगुलरली करें, तो हम प्री डायबिटिक स्टेट को डायबिटिक स्टेट में कन्वर्ट होने से रोक सकते हैं। एंड इतनी चीज याद रखनी, अगर डायबिटिक पेशेंट्स अपने पास ज्यादा है तो प्री डायबिटिक स्टेट उससे भी ज्यादा है। इमेजिन अगर सब प्री डायबिटिक पेशेंट्स डायबिटिक स्टेट में कन्वर्ट हो गए, और क्योंकि अभी डायबिटीज छोटी उम्र में आ रहा है, फ्यूचर में जाके डायबिटीज के कॉम्प्लिकेशंस होने के चांसेस बहुत ज्यादा है। इसके लिए जब प्री डायबिटिक स्टेट है, हेल्दी लाइफस्टाइल फॉलो करें और शुगर्स को कंट्रोल में कर दे। नेक्स्ट स्लाइड प्लीज। तो काफी पेशेंट्स बोलते कि डॉक्टर मेरे को डायबिटीज का कोई सिम्टम ही नहीं है, तो मैंने शुगर नहीं चेक किया, अभी तो ये पैर में जख्म हुआ इसके लिए मैंने शुगर चेक कराया, या तो यूरिन में इन्फेक्शन होता है तब करते हैं। तो एक चीज याद रखना है कि डायबिटीज इज लाइक अ स्लो पॉइजन, दीमक है, वो पूरे घर को खोखला नहीं कर दे तब तक उसके कोई सिम्टम्स नहीं आएंगे। इसके लिए भले डायबिटीज से आपको कोई भी प्रॉब्लम नहीं है, रेगुलरली चेक करते रहना है, शुगर को कंट्रोल में रखना है। काफी सारे स्टडीज में क्लियरली दिखाया गया है कि जब डायबिटीज की शुरुआत होती है और तब हम अगर उसको एकदम बराबर से कंट्रोल में रखें तो आगे जाके किडनी के, हार्ट के, आईज के, पैर के नसों के प्रॉब्लम्स बहुत ही रिड्यूस हो जाते हैं। आज अगर 5 साल के बाद मैंने सोचा कि इतना टाइम तो मैंने निग्लेक्ट कर दिया, बट अभी मेरे को लगता है कि मैंने शुगर को अच्छे से कंट्रोल करना चाहिए, तो जिसने बिगनिंग ऑफ डायबिटीज में अच्छे से शुगर को कंट्रोल किया और जिसने 6-7 साल बाद सोचा कि मेरे को कंट्रोल करना चाहिए, तो ये चीज शरीर को, एक चीज होती है जिसको हम बोलते हैं मेटाबॉलिक मेमोरी, जो स्टार्टिंग में शुगर कंट्रोल की जो मेमोरी रहती है वो लाइफ लॉन्ग सेल्स में बनी रहती है। इसके लिए जब डायबिटीज डायग्नोस होता है तो पेशेंट्स को ये समझना जरूरी है कि डायबिटीज को स्ट्रिक्टली कंट्रोल करना है। काफी बार पेशेंट सोचते हैं कि मेरे को कोई प्रॉब्लम नहीं है, मैं क्यों दवाई लूं, फालतू की इतनी सारी दवाइयां मेरे बढ़ती जा रही है, मैं एलोपैथी ट्राई की जगह पे आयुर्वेदिक या होम्योपैथी ट्राई करूंगा। कोई भी आप ट्राई करिए चीज, बट इंपॉर्टेंट चीज है कि शुगर्स को कंट्रोल में रखना है। ये नहीं सोचना है कि मेरे को दवाई खानी पड़ेगी। और काफी बार पेशेंट्स में ये नोशन भी रहता है कि डायबिटीज की दवाइयों से किडनी फेल होगी। ऐसा नहीं है, अगर आपकी शुगर कंट्रोल में नहीं चली तो किडनी फेल होगी। शुगर्स को कंट्रोल में रखना जरूरी है, और जब डायग्नोसिस होता है उसी टाइम पे आप जितना अच्छे से कंट्रोल करोगे आगे जाके ये कॉम्प्लिकेशंस नहीं होंगे। नेक्स्ट स्लाइड। जैसे इस डायग्राम में हम देख सकते हैं कि डायबिटीज एवरी ऑर्गन को इम्पैक्ट करता है, ब्रेन से लेके, हार्ट से लेके, पैरों की नसों में, किडनी, आईज, सभी कॉम्प्लिकेशंस काफी कॉमन है, और अच्छे शुगर कंट्रोल से हम इसको अवॉइड कर सकते हैं। नेक्स्ट स्लाइड। आजकल डायबिटीज के ट्रीटमेंट में काफी सारी नई दवाइयां आई हुई है, नए ऑप्शंस भी आए। नेक्स्ट स्लाइड। जैसे डायबिटीज और ब्लड प्रेशर ये दोनों लाइफस्टाइल डिसीज है, तो फर्स्ट एंड फॉरमोस्ट मैनेजमेंट कोई भी लाइफस्टाइल डिसीज का होता है कि आप लाइफस्टाइल को मॉडिफाई करो। अभी पेशेंट्स बोलते हैं कि डॉक्टर क्या मेरे को दवाई पूरी जिंदगी लेनी पड़ेगी? अगर पेशेंट स्टार्टिंग ऑफ डायबिटीज है, डायग्नोसिस पे है, अगर अच्छा लाइफस्टाइल मेंटेन करता है, उसके शुगर्स बहुत ज्यादा नहीं है, तो आफ्टर इनिशियल कंट्रोल काफी बार हम लोग दवाइयां कम करके बंद भी कर सकते हैं। बट मोस्ट इंपॉर्टेंट थिंग है कि अगर डायबिटीज नहीं भी जाता है तो अच्छे से डॉक्टर के फॉलोअप में रह के आप शुगर्स को कंट्रोल में रखिए। ये नहीं सोचना है कि हमको दवाई खानी पड़ेगी। नेक्स्ट स्लाइड, नेक्स्ट स्लाइड। सो फर्स्ट एंड फॉरमोस्ट थिंग इज ऑफकोर्स लाइफस्टाइल को मॉडिफाई करना है। नेक्स्ट स्लाइड। अभी डाइट के बारे में डाइटिशियन आपको काफी कुछ बताएंगे, बट एक इम्पॉर्टेंट चीज है कि एक टाइम पे बहुत ज्यादा खाना नहीं खाना है। हम लोग हमारे पेशेंट्स को बोलते हैं कि आपका जो प्लेट रहता है, प्लेट में रफली 50% वेजिटेबल्स चाहिए, 25% प्रोटीन चाहिए और 25% कार्बोहाइड्रेट। कार्बोहाइड्रेट मतलब आपका रोटी है, राइस है, फिर वो रोटी नाचनी का हो, ज्वारी का हो, बाजरी का हो, बट उसका कार्बोहाइड्रेट का प्रोपोर्शन कम होना चाहिए। हमारे इंडियन प्लेट में कार्बोहाइड्रेट का पोर्शन काफी ज्यादा होता है, इसके लिए खाने के बाद के शुगर्स भी काफी ज्यादा होते हैं। नेक्स्ट स्लाइड, नेक्स्ट स्लाइड। डाइट के साथ में रेगुलरली एक्सरसाइज करना भी बहुत जरूरी है। दो प्रकार के एक्सरसाइज होते हैं, एक तो एरोबिक मतलब वॉकिंग, जॉगिंग, जंपिंग, स्विमिंग, उसको एटलीस्ट हफ्ते में 5 दिन 30 मिनट के लिए करना है। और दूसरे प्रकार का एक्सरसाइज होता है जिसको हम वेट ट्रेनिंग बोलते हैं, जिसके हिसाब से मसल मास बिल्ड होता है। ये दोनों एक्सरसाइज से इंसुलिन रेजिस्टेंस कम होता है और शुगर कंट्रोल में हेल्प करते हैं। तो डाइट और एक्सरसाइज ये कोई भी डायबिटीज ट्रीटमेंट का फर्स्ट स्टेप है। काफी बार हम डाइट और एक्सरसाइज नहीं करते, सिर्फ दवाइयों पे शुगर को कंट्रोल करने की ट्राई करते हैं। एक चीज याद रखना है कि काफी सारी दवाइयां बॉडी का इंसुलिन यूज कर रही हैं। अगर आप स्ट्रॉन्ग दवाइयों पे जा रहे हो और डाइट और एक्सरसाइज को नहीं फॉलो कर रहे हो, तो आपके बॉडी का इंसुलिन तुरंत यूज हो जाएगा और बाहर से इंसुलिन की जरूरत जल्दी पड़ेगी। तो फर्स्ट एंड फॉरमोस्ट थिंग, डाइट और एक्सरसाइज से अच्छे से मेंटेन करो, तो ऑटोमेटिकली नंबर ऑफ दवाइयां आपकी कम रहेंगी and you can go on many more years without the need of insulin from outside. नेक्स्ट स्लाइड प्लीज। तो जैसे मैंने बोला, डायबिटीज के ट्रीटमेंट में काफी अलग अलग प्रकार की दवाइयां भी है। इंजेक्शंस में इंसुलिन अवेलेबल है, और इंसुलिन नहीं बल्कि GLP-1 जैसे काफी सारे हॉर्मोन्स भी अवेलेबल है। आपके डॉक्टर के रेगुलर टच में रहिए, और नई नई दवाइयां आ रही है उनका यूज करके भी काफी बार हम लोग शुगर्स को अच्छे से कंट्रोल में रख सकते हैं और कॉम्प्लिकेशंस अवॉइड कर सकते हैं। नेक्स्ट स्लाइड। सो काफी बार पेशेंट्स पूछते हैं कि मेरे फैमिली में रिस्क है, तो कैन आई रिड्यूस द रिस्क ऑफ टाइप 2 डायबिटीज। तो एक स्टडी हुआ था जिसको डायबिटीज प्रिवेंशन स्टडी बोलते हैं। ये स्टडी में दिखाया था कि अगर हम रेगुलरली हाफ एन आवर वॉक करते हैं तो रिस्क ऑफ टाइप 2 डायबिटीज अराउंड 35 to 40% से रिड्यूस हो जाता है। ये बहुत जरूरी है। सो एक्सरसाइज से क्या होता है, बेसिकली आपका वेट कंट्रोल में रहेगा, एंड मोमेंट योर वेट इज अंडर कंट्रोल द रिस्क ऑफ टाइप 2 डायबिटीज कम्स डाउन ड्रामेटिकली। नेक्स्ट स्लाइड प्लीज, नेक्स्ट स्लाइड। अभी शुगर को कैसे चेक करना है। काफी बार पहले ऐसे था कि हम लोग भी पेशेंट्स को बोलते थे अगर टाइप 2 डायबिटिक है, पेशेंट इंसुलिन पे नहीं है, तो आप लैब में मॉनिटर करिए। बट ड्यूरिंग द लॉकडाउन पेशेंट्स वर नॉट हैप्पी गोइंग टू द लैब। सो अभी काफी बार हमने पेशेंट्स को घर पे ग्लूकोमीटर रखने के लिए एडवाइस किया हुआ है। ग्लूकोमीटर के ऊपर शुगर लैब के शुगर से थोड़ा ज्यादा दिखता है, बट ऑन एन एवरेज एटलीस्ट आपको पता तो चलेगा कि शुगर्स कितने हैं। जैसे मैंने बोला, काफी बार डायबिटीज के कोई सिम्टम्स नहीं होते। जब तक शुगर बहुत नहीं बढ़ेंगे, या तो आपको कोई इन्फेक्शन नहीं होगा, आपको पता नहीं चलेगा कि शुगर हाई है। बट अगर घर पे ग्लूकोमीटर है और आप 15-20 दिन में एक आध बार फास्टिंग और पीपी शुगर चेक कर लोगे, तो आपको एटलीस्ट अंदाजा तो रहेगा कि शुगर कितना आ रहा है। तो एक ग्लूकोमीटर रखना जरूरी है। दूसरा चीज मॉनिटर करने का, काफी सारे पेशेंट्स ने सुना रहेगा कि आजकल एबट का वो चिप जैसे है जिसको हम कंटिन्यूस ग्लूकोज मॉनिटरिंग बोलते हैं, जो आम पे लगाया जाता है। एवरी 15 मिनट्स पे शुगर्स मॉनिटर होते हैं और 15 डेज में डेटा जनरेट होता है। अगर वो इसको चिप को रीड करने के लिए आपके पास मशीन है, तो तुरंत भी, जैसे ग्लूकोमीटर पे तुरंत रीडिंग मिलता है, वो चिप पे भी आप शुगर का रीडिंग ले सकते हैं। सेल्फ मॉनिटरिंग ऑफ ब्लड ग्लूकोज में अपने को फास्टिंग और पीपी का अंदाजा आ जाएगा। बट इन एडिशन HbA1c भी कराना बहुत जरूरी है। HbA1c अपने को 3 मंथ्स के शुगर के एवरेज का अंदाजा देता है, और HbA1c लॉन्ग टर्म डायबिटीज कॉम्प्लिकेशंस को भी प्रेडिक्ट करता है। नेक्स्ट स्लाइड प्लीज, नेक्स्ट स्लाइड। सो नॉर्मल ब्लड शुगर रीडिंग कितना होना चाहिए। जब ओपीडी में पेशेंट्स आते तो बोलते हैं हाँ डॉक्टर, मेरा शुगर तो बिल्कुल कंट्रोल में है, मेरा फास्टिंग शुगर 200 रहता है और खाने के बाद का शुगर 250 रहता है, मेरे को कोई प्रॉब्लम नहीं है एंड एब्सोल्युटली अंडर कंट्रोल है। तो ये 200 और 250 शुगर रीडिंग नॉर्मल है क्या? एक चीज याद रखना है, खाने के पहले का शुगर 100-110 के करीबन चाहिए, खाने के बाद का शुगर अराउंड 160 चाहिए, ओकेजनली 180 तक भी चलता है, और HbA1c को लेस देन 7% रखना है। जिसको हार्ट और किडनी की शिकायत है उसमें हम HbA1c थोड़ा हायर साइड पे भी रखते हैं, बट नॉर्मल शुगर रीडिंग को जानना जरूरी है। काफी सारे पेशेंट्स को लगता है फास्टिंग शुगर 200 तक नॉर्मल है, ऐसा नहीं है। फास्टिंग शुगर 100 के आजू बाजू चाहिए और खाने के बाद का शुगर 160-170 के आजू बाजू। जितना शुगर कंट्रोल में रहेगा, लेसर द रिस्क ऑफ कॉम्प्लिकेशंस। नेक्स्ट स्लाइड प्लीज। अभी जैसे डॉक्टर श्रुति ने बोला कि काफी बार ब्लड प्रेशर काफी सारे कॉम्प्लिकेशंस को क्रिएट कर सकता है, वैसे ही डायबिटीज में भी कॉम्प्लिकेशंस होते हैं। तो ये कॉम्प्लिकेशंस को कैसे मॉनिटर करना है? तो फर्स्ट ऑर्गन विच कॉमनली गेट्स इन्वॉल्व इज किडनी। तो किडनी को मॉनिटर करने के लिए साल में एक बार क्रिएटिनिन करना है और यूरिन में स्पॉट यूरिन एल्ब्यूमिन क्रिएटिनिन रेशियो या प्रोटीन लॉस को एस्टिमेट करना है। टाइप 2 डायबिटिक जिसको टाइप 2 डायबिटिक पेशेंट ने आई का चेकअप एवरी ईयरली करना है। जैसे डायबिटीज की वजह से हार्ट की नसें चोकअप होती है, वैसे ही आंखों की भी नसों में दिक्कत हो सकती है और काफी बार पेशेंट्स को ब्लाइंडनेस, सडनली रेटिना में ब्लड हिमरेज होने की वजह से विजन लॉस होता है। तो अगर आप ईयरली आई चेकअप कराते हो तो इस प्रॉब्लम को आप टाइम पे डिटेक्ट करके लेजर ट्रीटमेंट करा के उसको कंट्रोल में ला सकते हो, तो विजन लॉस के चांसेस काफी बार कम हो जाते हैं। जिनको टाइप 2 डायबिटीज लॉन्ग टाइम से है और फूड की प्रॉब्लम है, उन्होंने डेली सेल्फ फूड एग्जामिनेशन करना है। मिरर आता है, मिरर को पैर के सामने रखना है और चेक करना है कि फंगल इन्फेक्शन तो नहीं है, कैलस तो नहीं है, सेंसेशन नॉर्मल है कि नहीं है। और कार्डियक कॉम्प्लिकेशंस को प्रिवेंट करने के लिए ब्लड प्रेशर, कोलेस्ट्रॉल, किडनी, ये सब चीजें कंट्रोल में चाहिए। तो 3 या 6 महीने में HbA1c, कोलेस्ट्रॉल, किडनी प्रोफाइल ये सब कराते रहना है ताकि कार्डियक कॉम्प्लिकेशंस का चांस भी कम हो जाए। नेक्स्ट स्लाइड। Over 300 million people are living with diabetes. It's a global epidemic. We cannot afford to ignore it. Majority out of 100 patients, only 50% patients are diagnosed to have diabetes. 50 में से 30 को 30% of patients are on treatment. 30% में से hardly 10% of patients are adequately treated and their HbA1c is under control. Imagine अगर इतने सारे लोगों को डायबिटीज के कॉम्प्लिकेशंस होना शुरू हो गए तो हेल्थ सेक्टर पे कितना बड़ा बर्डन आएगा, एंड वी विल नॉट हैव फैसिलिटीज टू ट्रीट पेशेंट्स विद कंटिन्यूस डायलिसिस आल्सो, एंड प्लस फाइनेंशियल बर्डन अलग ही चीज है। सो द होल थिंग इज डायबिटीज को कंट्रोल में रखना बहुत जरूरी है। अगर हम प्री डायबिटिक है या ओबीज है तो हमको हेल्दी लाइफस्टाइल फॉलो करके फ्यूचर रिस्क ऑफ डायबिटीज को रिड्यूस करना है। नेक्स्ट स्लाइड प्लीज। तो मोस्ट इंपॉर्टेंट थिंग इज टाइप 2 डायबिटीज इज पोटेंशियली प्रिवेंटेबल अगर आप अच्छा लाइफस्टाइल फॉलो करो। रेगुलर हेल्थ चेक करना जरूरी है, शुगर्स को कंट्रोल में रखना जरूरी है, शुगर को कंट्रोल में रखना जरूरी है। इन एडिशन एंड ऑर्गन डैमेज के लिए भी मॉनिटरिंग करना जरूरी है। बेटर द कंट्रोल, लेसर द रिस्क ऑफ कॉम्प्लिकेशंस। नेक्स्ट स्लाइड प्लीज। So together we can and together we will win this disease. We need good effort and we need to keep our sugars under control. Thank you.
Thank you, Dr. Sneha. That was really a nice presentation. I'm sure patients को भी अच्छा लगा है, उनको थोड़े practical tips मिले हैं. And I am seeing कि chat box में बहुत सारे questions हैं. हम panel discussion के time पे वो questions answer करेंगे. Now we will move forward to the next talk, and I would like to introduce Dr. Anita Saxena. So Dr. Anita Saxena is the professor at the Department of Nephrology, SGPGIMS, Lucknow. She's a member expert for review panel for KDOKI for nutrition in CKD guidelines, member editorial board of Journal of Renal Nutrition. She is editor for the Journal of Renal Nutrition and Metabolism, founder, secretary, and secretary of Society of Renal Nutrition and Metabolism. And to tell everyone, this is a very forthcoming society which is doing a lot of work for nutritionists and for the nutrition in the country. She's an awardee of FICCI Outstanding Woman in Medicine and Healthcare 2020. She was awarded the Bharat Ratna by Dr. APJ Kalam Excellence 2021, International Award of Excellence for Keeping the Indian Flag High for 2019, Bharat Jyoti Award 2017 for contributions to the Society of Prevention of Malnutrition in CKD. International Women Award 1999 to 2000, Cambridge, England. 20th Century Achievement Award and postdoctoral fellowships she has done at Addenbrooke's Hospital, Cambridge University, England. She's a referee for journals, international and national journals. Best Paper Awards, has received international travel grants, has had international podium presentations at ASN, EDTA, and APCN. A lot of publications in books and in journals. So it is our proud privilege to have Dr. Anita address us, and it would be a learning experience for patients and the nutritionists to understand how to maintain phosphorus control if you have a kidney issue. Over to Dr. Anita.
Right. Thank you, Dr. Shruti. And well, I'm going to talk to you about controlling hyperphosphatemia and CKD. And it's actually very difficult to talk about this topic, and then that too in Hindi. I think you'll have to bear with me because I'm not so good in expressing myself in Hindi. So let's see what I'm going to talk to you about is, first of all, what is phosphorus? Phosphorus is an essential macronutrient, and the primary source of phosphorus is food and medications. Then what is hyperphosphatemia? Hyperphosphatemia is actually a compilation of three different words. Hyper means phosphate.
Dr. Anita, your slides are not going ahead.
Oh.
Yeah, I think slideshow we can do on the PowerPoint presentation mode.
That's what I did.
We are just seeing the slides.
Can you see it now?
Yes, I can see, but it is not in the PowerPoint mode. It is showing slides in the editing mode.
Editing mode.
Yeah.
Here's screen, and here I am. Can you see it now?
We can see the slide. Again, go to the presentation mode.
So I am in the presentation mode. It's
Siddharth, can you help Dr. Anita?
Ma'am, probably you just click on share and select the screen rather than the PPT. So probably the two windows must have been open. That's why this problem usually occurs.
All right. I'll stop share, and let's see. Okay, and okay, screen. Can you see the slides now?
Yeah,
ma'am, we can see the slides, but again, they are in normal mode.
Again, you have to do in the presentation mode.
I have, and it's this in
the. That's what I'm requesting. Probably two windows must have opened. So instead on click share screen, instead of ma'am slides, you just click on the screen option. So your desktop will be shared.
Screen. All right. Okay. Okay. Yeah. Share. Can you see it now?
Yeah, ma'am. Now we can see.
All right. So I'm sorry for having wasted your time. But yes, I'm going to talk to you about controlling hyperphosphatemia in CKD. So what is phosphorus? Phosphorus is an essential micronutrient, and the primary source of phosphorus is food and medications. And 95% of phosphorus is excreted in the urine. So that is the reason we're going to talk about, because for the CKD patients, they know that their renal excretion is impaired. So that is the reason these things start going up. Now, what is hyperphosphatemia? Hyperphosphatemia is a compilation of three different terms. The hyper means high, phosphate means phosphorus, and emia means presence in the blood, which means hyperphosphatemia implies increased concentration of inorganic phosphates in the blood, which is more than 4.5 milligrams per deciliter. It is the most common metabolic complication of chronic kidney disease, especially in the end-stage renal disease. The key players in hyperphosphatemia and CKD are the kidneys, the gut, that is your intestines, the stomach, and the bones. So phosphorus retention occurs when net intestinal absorption exceeds renal excretion and or dialysis removal. So why does hyperphosphatemia occur in patients with kidney disease? What is the reason? So if you have a look at this figure is showing you the normal physiology of phosphorus balance. So what happens is every day an individual eats about 1200 milligrams of phosphorus, out of which 60 to 70% of it is absorbed in the gut. And this absorption is aided by vitamin D. And then about 400 milligrams is excreted in the feces and about 800 milligrams is excreted in the urine. So here the patient started with 1200 milligrams, I mean a normal individual, and he's excreted 400 milligrams in the feces and 800 in the urine. So the balance is zero, okay? So there is no excess. Now 1% of it stays in the as phosphorus pool in the blood. And remember that the bones are the hub of the store of phosphorus. So a total phosphorus content in an adult body is about 700 grams. The kidneys balance the amount of phosphorus and calcium in the blood. Then parathyroid hormone and FGF23 are the primary hormones that regulate phosphorus reabsorption in the proximal tubules of the kidney. So as now that was the normal physiology. What happens when the kidneys are not working well? As the glomerular filtration rate declines to less than 60 ml per minute, the phosphorus excretion becomes altered in the nephron. And half of the nephrons are not able to excrete phosphorus. Now, remaining nephrons compensate by hyper-excreting the daily phosphorus load to maintain normal serum phosphorus concentration. And this is the reason why another hormone called the FGF23 levels start going up. Now, compensation to maintain normal serum phosphorus concentration continue until the GFR declines to less than 25 or 40 ml. That is less than 25% of the kidney function. And at this stage that hyperphosphatemia is detected. But actually, high phosphorus levels start increasing right in the stage 1. I'll tell you later on. So, and this is exactly what the figure is showing you what I have told you, that as the renal function reduces, the phosphorus retention increases, it ensues hyperphosphatemia, the PTH secretion increases, then parathyroid hyperplasia ensues, and it leads to secondary hyperparathyroidism. And meanwhile, because the kidneys are not functioning well, so therefore the vitamin D synthesis in the kidney is not appropriate and it's not sufficient. So therefore, the intestinal absorption of calcium is low, and hence you have a hypocalcemia, that is you have low ionized calcium in the blood. And again, that leads to a high parathyroid hormone level. So how does high phosphorus harm the body now? Now, hyperphosphatemia is a risk factor for cardiovascular disease. And you know that all our patients are susceptible to cardiovascular disease. And therefore, hyperphosphatemia causes development and progression of cardiovascular disease. High calcium and phosphorus products causes soft tissue and vascular calcification. Here you can see all these things. And also hyperphosphatemia is responsible for secondary hyperparathyroidism, I showed in the picture, and mineral bone disease. And in non-dialyzed CKD stages 2 to 5, hyperphosphatemia also reduces antiproteinuric effect of your antihypertensive medications and the very low protein diets also. And it is a strong predictor of mortality in advanced CKD stages. And here you can see these are the abnormalities that happen with the hyperphosphatemia, the mineral bone disease. And here you can see that as the serum phosphorus levels increase beyond 6.5, the relative risk of mortality increases. So in CKD patients, in CKD stages 3 and 4, the reference normal range for, the reference range for maintaining phosphorus is 2.7 ml and no higher than 4.6 ml milligrams per deciliter. And in patients who are on dialysis, that is CKD stage 5 or non-dialysis, their phosphorus should be maintained between 3.5 and 5.5 milligrams per deciliter. Now, how can one take care of high serum phosphorus? In CKD stages 3 and 5 non-dialysis. So diet control is 1, medications are number 2, with the use of phosphate binders, and dialysis is number 3. So here you can see this figure. This is the 3 cornerstone approach that collectively work on control of calcium, phosphorus, and PTH is in CKD MBD includes the diet, the dialysis, and the drugs. And the drug treatment with phosphate binders is given, active analogs of vitamin D is given, or calcium mimetics are given to the patients. Now, you see, this is kind of a ghost here. So phosphorus burden is like a ghost. It's like a boot. The phosphorus burden depends upon multiple factors, including the food sources, whether phosphorus is coming from the animal source or the plant-derived, or whether it's plant-derived. Food labeling of phosphorus contents, they are not very well labeled. When you go to the market, you won't find it very well done. And phosphate additives like pH regulators, stabilizers, and flavor, color enhancers, these are all, adding on to, these are the additives for keeping the shelf life of the food long, and for keeping the meats and its frozen stuff soft and succulent. And so the phosphate additives can contribute up to 1/3 of dietary phosphorus. The method of food preparation, which can all impact the bioavailability, and the method of food preparation is also very, very important, and that can impact the bioavailability of phosphorus. Now, medications are also hidden sources of phosphorus, like antidepressants, calcium and channel blockers, antihypertensives, anti-diabetic medications, and the cardiovascular and central nervous system drugs account for approximately 90% of phosphorus-containing medications. Now, CKD specific recommendations suggest maintaining phosphorus intake between 800 and 1000 milligrams in patients with CKD, and phosphorus control should be initiated right in the beginning, right from CKD stage 1, because what happens is, as I said, that FGF23 is a phosphaturic hormone. When the kidneys start to work, slightly below the normal, the FGF23 levels start rising as the phosphates, in order to maintain the normal range of phosphates in the blood. So this is what you see as phosphates and protein have a close linear relationship. So as the protein intake goes up, the phosphorus intake also goes up. So therefore, though the KDOQI guidelines or international guidelines, they do not advise initiating phosphate binders before CKD stage 3, or if the PTH levels are really high, what we should plan is right from CKD stage 1, we should start controlling diet of the patient so that they do not take very high phosphorus diet, and all these abnormalities do not ensue. Now, dietary phosphorus restriction is a very good therapeutic strategy, which should be started very early in order to control phosphorus. Reducing intestinal absorption should be done with phosphorus binders or phosphate binders. Removing phosphorus with dialysis therapy is very well known. One should avoid eating foods with additives, as I just mentioned, and additives increase the phosphorus content of the food as much as by 80%. So if you have a look at this figure is showing you that as the protein content increases, the phosphorus content also goes up. So we're talking about dietary phosphorus restriction. So the strategy is to take low protein diet, because protein has a linear relationship with phosphates. 1 gram of protein brings 13 to 15 grams of phosphates, of which 30 to 70% is absorbed through the intestines. So if you keep your phosphates low in the food, the phosphorus levels will not go up. And then low protein diet is what is advised to the patients in CKD stages 2 to 5 non-dialysis, which is about 0.5 to 0.6 grams of protein is given to the patient. And one has to restrict foods which are rich in phosphorus, like legumes, chocolates, walnuts, all kinds of dry foods, then egg yolk and chicken. Now, if you have a look at this figure, you can see that the phosphate levels were high, but towards the end of the right side, you see the phosphate levels are coming down. So another approach is to give a very low protein diet to the patient. And with that, you give some keto analogs, the essential amino acids, so that the nutritional status does not suffer, the protein synthesis goes on, and at the same time, because they'll be consuming less of milk products or less of high phosphorus foods, so therefore the phosphorus content in the body will come down. And as you can see from here till here, the phosphorus load will come down. Now, prefer foods rich in vegetables, and particularly vegetables which are low in potassium. Otherwise, the patient would end up with hyperkalemia. And avoid foods like cola beverages, enhanced or restructured meats, frozen meals, cereals, snack bars, processed or spreadable cheeses, instant products, refrigerated bakery products, red meat, and avoid convenience foods, because all these contain phosphorus as additive. And also the highest load comes from protein-rich foods like nuts, hard cheeses, egg, yolk, meat, poultry, and fish. So one has to be very careful as to what the patient is eating, and your dietitian is your best friend in advising you which food is high in phosphorus and which food is suitable for you. So prefer cereals and legumes, and use the phosphorus pyramid for choosing kind of foods you want to have. So the first base level and the second base level, they are very patient friendly, because these are telling you a lot. You can take a lot of cereals and legumes, and you can have egg white in plenty and olive oil or whichever vegetable oils you have. But the level 3 is milk products. Milk products are high in phosphorus, so you have to be careful in how many servings you have. And your dietitian is your best friend in advising you about this. Then boiling vegetables can reduce phosphorus content. And that is a very good way of also leaching potassium in case you have hyperkalemia. Strategy 2 is prefer plant protein, because only 40 to 60% of plant protein is absorbed, as humans do not express the enzyme called phytase. And here is what is plenty of things. You've got a lot of choice, cereals and whole grains, which you can really have. Okay. So, and here you see this figure is showing if you're on a regular diet, then your serum phosphorus levels are high. But if you are on a restricted diet, the serum phosphorus levels are low. And I mean, they are low as you would want them to be. And here, when you're on a regular diet, the phosphate excretion is higher. And when you are on a phosphorus restricted diet, the phosphorus excretion is low. But what happens is, in order to restrict phosphorus, the dietitians end up restricting a lot of protein. And if you restrict a lot of protein, the one thing that is important to remember is that our patients are at the risk of malnutrition, protein energy wasting. So if you're restricting a lot of protein to our patients, then the patients will become nutritionally, I mean, they're already nutritionally compromised and they can become malnourished. So this is something one has to remember. And a lot of equations are available in the literature, so you can use those equations to calculate how much your food is rich in phosphorus. And for that, the most important thing is you should be educated. The patient should learn about phosphorus content of the foods, and your dietitian is the best friend, can teach you all these things. Now, strategy 3 is restrict foods with high protein to phosphorus ratio. So avoid cream, butter, cheese, egg yolk, dry fruits like almonds and walnuts, chocolate, milk. And here, if you have a look at this figure is showing you that if you have a if you consume foods which have high phosphorus to protein ratio, which is beyond 16 milligrams per gram, the risk of death increases many times. So one has to be careful with this. And egg white is a very good friend of our patients, because it has one of the lowest protein to phosphorus ratio and is also devoid of cholesterol. So you have a double benefit in this case. Strategy 4 is to go for oral phosphate binders with meals to reduce intestinal absorption of phosphorus. And remember, the common questions that are asked about phosphate binders are that what time should the phosphorus binders be taken? The phosphate binders should be taken shortly before or with meals to achieve maximum efficacy and avoid unwanted effects. When taken in an empty stomach or hours after eating, there is an increased risk of hypercalcemia with calcium-based binders and nausea, vomiting with other kind of binders. But binders are most effective when food is present in the stomach and small intestine, where most phosphorus is absorbed. So you should take it immediately after taking food. And if a dose is by chance missed by the patient, then what should be advised? Then if the moment you remember that you have missed your phosphate binder, you should take it. However, if it is very close to the next dose, then you may skip it. And the chewable phosphate binder should be chewed and not swallowed, because it will not have complete effect. Now, the fifth strategy, which is non-nutritional, is to preserve the residual renal function. Patients who have a good urine output, their phosphate levels do not go as high, and they require less of phosphate binders. And one has to avoid contrast and nephrotoxic drugs like NSAIDs and brufen. And also, if the patient is on dialysis, then during dialysis, prevent renal ischemia while, because the patient undergoes renal ischemia because of ultra filtration. And and also by monitoring microbiological quality of the dialysate, and also preserve residual renal function so that you will require less of phosphate binders. Here you can see this patient has no urine output, so this patient is requiring more than 6 tablets of phosphate binders in a day. However, even if the patient has a small residual renal function or small urine output, the patient will not require as many phosphate binders. So it is important to preserve residual renal function with low protein diet in pre-dialysis stage. And strategy 6 is dialysis. You remember the 3 Ds: diet, drugs, and dialysis. So this is do not miss your dialysis session. You should know that 1 day of peritoneal dialysis clears about 300 milligrams of phosphates. However, the phosphate clearance will be affected by the transport characteristics, and one regular hemodialysis session clears about 500 to 600 or maybe up to 800 milligrams of phosphates. So the take-home message of my talk is prefer plant-based proteins, calculate phosphorus content of diet with the help of your dietitian, take low phosphorus containing foods, learn phosphorus targets, do not miss phosphate binder dose after meal, avoid foods with phosphorus-based additives, and thank you for your attention.
Thank you, Dr. Anita. That was a wonderful talk. I'm sure the patients have gained a lot of practical knowledge as regards what is to be done for phosphorus, what are the side effects of phosphorus, what is to be done to control the phosphorus in such a way that the nutrition is not hampered. And that is very, very important. So now let us go to the next subject, patient counseling on eating well, which is going to be taken by Dr. Suniti Ashwini Khandekar. Dr. Anita, if you want to introduce her.
Yeah, sure. What's happening here? Can you see the slide?
Yes, you just have to advance it. Yes, now we can see.
Okay. It's in the slideshow?
No, it is in the editing mode. Okay. But it's okay. I think for this, just go ahead with this so that we can go ahead with the program.
All right. So, can you see it now properly? Okay. It is my pleasure to welcome Dr. Suniti Ashwini Kumar Khandelkar. She is an MBBS from North Maharashtra University. She's done post-graduation in dietetics and clinical nutrition. She's been a lecturer in medical physiology at SNDT Mumbai, and she's a clinical nutritionist. She's been a clinical nutritionist at Hinduja Hospital, Mumbai. She was a part of community nutrition work in the Array Milk Colony, Mumbai in 2006. She has been faculty for medical nutrition for courses run by Central India Nephrology Society, Nagpur. She teaches pregnancy nutrition at Garbhasankar classes in Nagpur and has conducted pediatric school nutrition programs in various schools across Nagpur. She has authored 2 books on nutrition in kidney. One is in English and the translation is also in Hindi. And she's contributed chapters in the book, Handbook of Dialysis for Technicians. And she's going to talk about patient counseling on eating well. So now over to Dr. Suniti.
Thank you, Dr. Anita Saxena, ma'am, for giving me this opportunity to have a dialogue with you all. Now, eating right for kidney patients is what we are going to discuss today. We have learned a lot about how to control blood pressure, how to control our blood sugars, और हाइपरफॉस्फेटेमिया के बारे में भी हम काफी जान चुके हैं. तो सबसे पहले why protein, energy, malnutrition and inflammation are of great concern in all the patients who are suffering from kidney diseases. तो हम लोग काउंसलिंग के बारे में जब बात करते हैं तो we have in our minds as what is it, but when we say that we are going to discuss about something, then that becomes easier for us. So let us discuss about protein, energy, malnutrition. सो प्रोटीन एनर्जी मालन्यूट्रिशन बड़े बड़े शब्द हैं, लेकिन अगर उनको ब्रेक किया जाए, प्रोटीन कहाँ से मिलता है? एज एन मिल्क्स, कर्ड्स, दाल्स, पल्सेस, स्प्राउट्स, eggs, fish, meat, and the energy which we get from eating whole grains, legumes, pulses, fats, oils, ghee, vegetables, fruits, which are complex carbohydrates. So when we understand this PEM, it has something to do with this. Now, when the proteins are not consumed in sufficient amounts and the calories or energy intake is reduced, in case of uremia, nausea, किडनी डिसीजेस के पेशेंट्स में जो होता है, तब माल न्यूट्रिशन सेट होता है, जिसे हम कुपोषण यानी कम पोषण या गलत तरीके का पोषण कहते हैं। नाउ दिस प्रोटीन एनर्जी माल न्यूट्रिशन, it leads to increase in morbidity, that is, it increases the chances of progression of your disease, progression of your kidney disease or illness, as well as it has increased chances of early demise, sad deaths, that is mortality, amongst patients of maintenance hemodialysis or on other type of treatments. But do you think that this protein energy malnutrition, it starts from the point the patient goes on dialysis or peritoneal dialysis or CAPD? No, the timeline goes back to the era where the patient was silently having disturbances in the blood sugar levels, disturbances in the blood pressure levels, and also in early stages of CKD when the patient was not aware कि उनका blood sugar high हो रहा है या blood pressure high हो रहा है, जैसे डॉक्टर स्नेहा और डॉक्टर श्रुति ने हमें बताया, या they are not revealed कि अभी तक की किडनी में problem हो रहा है. So the malnutrition has been setting right from the time they are having all these disturbances in blood sugars or blood pressures or eating less, and then it is revealed in their later stages. So let me explain it in a very simple manner. That is, any bankers in the audience here, I'll just give you a very simple example of if you are depositing ₹1,000 in your bank every month, and from January 2021, if you had decided that मैं ₹5 कम डालता हूँ, तो by the year end ₹60 का डेफिसिट होता है, नहीं? Okay, so now if we don't forget the interest you get on it, so it is a deficit of 70 to 75 rupees. Okay, now इसको अगर 5 साल के लिए ले तो डेफिसिट बहुत वूपिंग हो जाता है, बहुत बड़ा हो जाता है. Similarly, in case of protein and energy, if we are consuming less of proteins knowingly or unknowingly, and if we are consuming less of calories knowingly or unknowingly, this deficit becomes whooping and it builds gradually and reveals when there is a major deficit. This protein energy malnutrition leads to increased markers of inflammation. Now these are related or directly linked to causing blockages in your arteries and blood vessels, which we call atherosclerosis, and cardiovascular illnesses and deaths due to cardiovascular problems. That is the reason why we need to be very careful as far as our protein and calorie intake in case especially of diabetics, hypertensive patients, as well as chronic kidney disease patients. Now, these inflammatory markers are certain chemicals and which are directly causing a toxic effect on the endothelium, that is blood vessels and other organs, and it causes an inflamed atherosclerotic plaques which are likely to rupture and increase the likelihood of directly myocardial infarction or stroke, that is heart disease हो सकता है या stroke हो सकता है. Now, CKD में जो malnutrition है उसका एक विशियस साइकिल है जो एक से दूसरे पर जुड़ा हुआ है और वो खत्म ही नहीं होता है. जैसे किडनी फंक्शन जब कम हो जाते हैं तब हम खाना कम खाते हैं तो माल न्यूट्रिशन सेट होता है. नोशिया, वॉमिटिंग, यूरेमिया, अच्छा नहीं लगना, जी मिचलाना, ये होता है तो हम खाना कम खाते हैं. हमारा बॉडीली फंक्शन भी कम होता है, हमारा ऑर्गन्स का फंक्शन भी कम होता है, तो हम लोग ऐसे ही खाना कम खाने लगते हैं, इच्छा नहीं होती, उससे अगेन माल न्यूट्रिशन सेट होता है. तो ये माल न्यूट्रिशन इन क्रॉनिक किडनी डिसीज का, क्योंकि हम आज ज्यादातर किडनी की बात कर रहे हैं, तो ये सेट इन हो जाता है बिकॉज जस्ट हम खाना कम खा रहे हैं या प्रोटीन कम खा रहे हैं या एनर्जी कम ले रहे हैं. तो न्यूट्रिशन केयर इन सीकेडी का पर्पस क्या है? हम क्यों कहते हैं पेशेंट्स को कि न्यूट्रिशन केयर इज द बेस्ट केयर इन केस ऑफ डायबिटीज, इन केस ऑफ हाइपरटेंशन एंड अगर डायबिटीज और हाइपरटेंशन को अच्छे से हम लोग प्रिवेंट कर सकते हैं तो क्रॉनिक किडनी डिसीज के स्टेजेस को भी हम आगे बढ़ने से रोक सकते हैं। तो वी नीड टू मेंटेन अवर न्यूट्रिशन स्टेटस टू स्लो द प्रोग्रेशन ऑफ द डिसीज, टू मिनिमाइज द अक्यूमुलेशन ऑफ वेस्ट प्रोडक्ट्स जो किडनी के फेलियर के कारण हमारे ब्लड के अंदर जमा होते रहता है, वो कचरा हम जमा होने से बचा सकते हैं अगर हम अच्छा न्यूट्रिशन खाते हैं तो, और हम हाइपरटेंशन को और ब्लड शुगर को कंट्रोल कर सकते हैं। तो अगेन पर्पस ऑफ न्यूट्रिशन केयर इन सीकेडी, व्हाट अ पेशेंट नीड्स टू फॉलो इज patients need to have a nutritious, balanced and calculated diet, and in calculation should be proper as far as their proteins are concerned and their calorie intake is concerned, as well as minerals like sodium, potassium, phosphorus and blood and sugars in their diet need to be calculated, and you have to follow the guidelines. जैसे डॉक्टर अनीता सक्सेना मैम ने अभी कहा कि your dietitian is your best friend, your nutritionist is your best guide to give you the advice and also your nephrologist tells you as to how to have a nutritious and balanced diet. Your medicines, food, exercise, water should be under expert guidance. Do not skip the expert guidance and just Google it, because remember social media and Googling is not aware of your blood reports. आपका blood sugar कैसा है, blood pressure कैसा है, वो एक blanket statement हमें मिलता है उसपे। तो what's going on inside your body organs is only your nephros and your nutritionists are aware of. इसीलिए your आपके medicines, food, water, exercise इनको आप expert guidance से ले सकते हैं। प्रोटीन की मात्रा सही amount में ले। We have seen earlier as to how protein intake is important for a longer and healthier life, and how proteins are important in building our body. हमारे बॉडी ऑर्गन्स और टिश्यूज को बनाता है, और अगर हम खाने में प्रोटीन कम खाते हैं तो हमारे बॉडी के अंदर का यही प्रोटीन डिसॉल्व होके निकल के हमारी बॉडी को एनर्जी देने का काम करता है, तो हमारा शरीर अंदर से खोखला भी हो सकता है। That is the reason why right amount of protein intake is very important. Now we need to check our salt intake, we need to keep a check on our potassium intake, and a very excellent presentation we got to learn a lot from Dr. Anita Saxena about phosphorus content. Now all these food items we consume either homemade or hotel made or ready made, you need to check the labels. Now check it out with your nutritionist, उनके आप संपर्क में constant touch में रहे। काफी बार हमें कंफ्यूजन होता है कि हम ये खाएं या ये खाएं, is it good for us or is it against our kidneys? So you talk to your nutritionist often as to what is to be taken in our body. Choose low fat diet. Now there are guidelines which say that fats को हमारे डेली डाइट में 30% से भी कम रखने की कोशिश करी जानी चाहिए, जिसमें से सैचुरेटेड और ट्रांस फैट्स को बहुत ही कम रखना चाहिए, बिकॉज ट्रांस फैट्स तो सबसे ज्यादा डेंजरस है, जो ब्लॉकेजेस, आर्टेरियल ब्लॉकेजेस कॉज करते हैं, बिकॉज दे आर गोइंग थ्रू हाई टेम्परेचर्स, और बेकरी प्रोडक्ट्स में ये सबसे ज्यादा देखा गया है। इवन इन चॉकलेट सर्टेन ट्रांस फैट्स आर प्रेजेंट एंड विच मे be harmful. Even we have learned that for phosphorus we need to keep a control on the chocolate intake of our body. Now you need to measure 24-hour salt and water intake as guided by your nutritionist. So किडनी डिसीज की हम जहां बात कर रहे हैं, किडनी हेल्थ फॉर ऑल 2022, ये इस साल का वर्ल्ड किडनी डे का थीम है। तो क्रॉनिक किडनी डिसीज एक है, एक हीमोडायलिसिस के पेशेंट्स है, एक पेरिटोनियल डायलिसिस के पेशेंट्स है, किडनी स्टोन्स वाले पेशेंट्स है, और नेफ्रोटिक सिंड्रोम। ये किडनी हेल्थ फॉर ऑल में सब हमें देखना है। तो क्रॉनिक किडनी डिसीज के पेशेंट्स में क्या होता है कि यूरिया राइज होता है, क्रिएटिनिन राइज होता है, हीमोग्लोबिन कम होने लगता है और धीरे धीरे काफी कम हो जाता है, सोडियम में डिरेंजमेंट्स होते हैं, पोटेशियम की वैल्यूज में डिरेंजमेंट्स होते हैं, फास्फोरस की वैल्यूज में जैसे हमने अभी पढ़ा डिरेंजमेंट्स होते हैं, पानी की मात्रा कम ज्यादा होने लगती है पैरों में और बॉडी में सूजन आने लगती है और विटामिन डी में डिरेंजमेंट्स होने लगते हैं। तो हमें क्या करना है? क्रॉनिक किडनी डिसीज के पेशेंट्स में कैलोरीज हम जैसे हमारे डाइटिशियंस हमको बताते हैं वैसे 25 to 30 किलो कैलोरीज पर किलोग्राम बॉडी वेट पर डे होना चाहिए। प्रोटीन की मात्रा कम ज्यादा हो सकती है डिपेंडिंग ऑन योर स्टेटस ऑफ स्टेज ऑफ सीकेडी। अगर आप कीटो एनालॉग डाइट पर है तो प्रोटीन की मात्रा और भी कम ले सकते हैं। दैट इज completely up to the guidance from your nephrologist and your nutritionist. So let your nephrologist and nutritionist be your friends. कार्बोहाइड्रेट इंटेक कॉम्प्लेक्स कार्बोहाइड्रेट होना चाहिए जिनमें फाइबर होना चाहिए। तो मिलेट बेस्ड डाइट्स जो रहते हैं वो डायबिटीज के पेशेंट्स के लिए भी अच्छे हैं, हाइपरटेंशन के पेशेंट्स के लिए भी अच्छे हैं और आगे जाकर क्रॉनिक किडनी डिसीज के पेशेंट्स के लिए भी बहुत अच्छे हैं। मिलेट्स हम बात करते हैं तो मिलेट्स में आते हैं जवारी है, बाजरा है और रागी है, नाचनी है और हम लोग मिक्स्ड ग्रेन्स भी खा सकते हैं। पल्सेस, लेग्यूम्स की अगर बात करें तो वहां से हमें कार्बोहाइड्रेट लेना आवश्यक है। फैट्स की मात्रा हम कम रखें। सिमिलरली हेमोडायलिसिस के पेशेंट्स में भी कैलोरीज और प्रोटीन इंटेक थोड़ा बढ़ा हुआ रहना चाहिए बिकॉज हेमोडायलिसिस के पेशेंट्स में प्रोटीन डायलिसिस की जरिए निकल जाता है। सिमिलरली कार्बोहाइड्रेट्स और फैट्स कम रहने चाहिए। पेरिटोनियल डायलिसिस में भी प्रोटीन और ज्यादा होना चाहिए क्योंकि पीडी के पेशेंट्स प्रोटीन और ज्यादा होते हैं पीडी फ्लूइड में से, इसलिए उन्हें भी प्रोटीन ज्यादा लेना चाहिए। सिमिलरली कार्बोहाइड्रेट्स और फैट्स कम रहने चाहिए और कार्बोहाइड्रेट्स कॉम्प्लेक्स रहना चाहिए क्योंकि पीडी के पेशेंट्स में पीडी जो फ्लूइड जो होता है उसमें शुगर्स रहते हैं। तो सिंपल शुगर्स के हम कम से कम ले और कॉम्प्लेक्स कार्बोहाइड्रेट्स अगेन हमारे खाने में गेहूं है और जवार है, बाजरा है, मिलेट्स है, लेग्यूम्स है, पल्सेस है जिसमें फाइबर की मात्रा है। लेकिन हमें ये ध्यान रखना है कि अगर हम फाइबर युक्त कार्बोहाइड्रेट्स ले रहे हैं तो हमारा पोटेशियम सही रहना चाहिए और हमारा फास्फोरस भी सही रहना चाहिए। हालांकि प्लांट बेस्ड कार्बोहाइड्रेट्स या प्लांट बेस्ड प्रोटीन्स में फास्फोरस की मात्रा थोड़ी कम रहती है कंपेयर टू एनिमल बेस्ड प्रोटीन, फिर भी आपकी डाइटिशियन और नेफ्रोलॉजिस्ट के सलाह के अनुसार ही आप ये सब लें। किडनी स्टोन्स ये एक बड़ा प्रॉब्लम है बिकॉज हम एक गर्म प्रदेश से आते हैं और हमारी बॉडी में का जो नॉर्मल वाटर है वो भी कम होता है। प्लस इंडियंस में हाइपरटेंशन ज्यादा देखा गया है। इंडिया इज द कैपिटल ऑफ डायबिटीज, तो डायबिटीज के पेशेंट्स में ब्लड में शुगर की मात्रा ज्यादा होती है एंड वो भी काफी बार थर्स्टी रहते हैं। तो किडनी स्टोन्स होने के चांसेस भारतीयों में ज्यादा देखे गए हैं। तो प्लेंटी ऑफ वाटर, हमें ज्यादा से ज्यादा पानी पीना है जिसे हम हाइड्रोथेरेपी कहते हैं। तो किडनी स्टोन्स के पेशेंट्स में हमें हाइड्रोथेरेपी लेना जरूरी है। डेली यूरिन आउटपुट 2 लीटर से ज्यादा होना चाहिए अगर हमें किडनी स्टोन्स प्रिवेंट करने हैं। कैल्शियम इंटेक सही रहना चाहिए। हाई ऑक्सलेट फूड्स सही रहने चाहिए। सॉल्ट इंटेक हमें कम लेना चाहिए और एनिमल प्रोटीन को हमें मॉडरेशन में रखना चाहिए। नेफ्रोटिक सिंड्रोम की बात की जाए तो प्रोटीन यहाँ भी ज्यादा लेना है और प्रोटीन की मात्रा कैलकुलेटेड होनी चाहिए और इन एडिशन टू इट जो यूरिन में हम लोग प्रोटीन लॉस हो रहा है तो वो प्रोटीन भी हमें डाइट में से लेना जरूरी है। और नेफ्रोटिक सिंड्रोम में देखा जाए तो सोया बेस्ड प्रोटीन, सोयाबीन वाला प्रोटीन जो है और प्लांट प्रोटीन किडनी स्कारिंग को यानी किडनी की हानि को कम रखता है और इसीलिए हमें प्लांट बेस्ड प्रोटीन और सोया प्रोटीन पे ज्यादा ध्यान देना है। वाटर प्लस अदर लिक्विड्स हमें ज्यादा लेने हैं। तो रिकमेंडेड डाइटरी एजुकेशन किसी भी पेशेंट का अगर काउंसलिंग करने की हम कोशिश करते हैं तो डाइटरी एडवाइस इज एन एसेंशियल एस्पेक्ट इन एनी सीकेडी मैनेजमेंट। और ये डाइटरी रिकमेंड एजुकेशन जो है वो 4 स्टेजेस में होना चाहिए। सबसे पहले तो पेशेंट का असेसमेंट होना चाहिए कि पेशेंट को क्या जरूरत है। एक गोल को सेट करना चाहिए कि हमें यहाँ तक पहुंचना है, हमें ब्लड प्रेशर को इन लेवल्स पर मेंटेन रखना है, हमें ब्लड शुगर को इन लेवल पर मेंटेन रखना है, हमें पोटेशियम को, हमें फास्फोरस को एक मात्रा पर। और एक मुख्य बात यानी किडनी के पेशेंट्स में, क्रॉनिक किडनी डिसीज और अदर किडनी प्रॉब्लम्स के पेशेंट्स में लिपिड्स का भी मात्रा ज्यादा होता है। ब्लड में फैट की मात्रा जिसे हम डिसलिपिडेमिया बोलते हैं वो भी ज्यादा होती है। तो वो भी एक गोल सेटिंग में बहुत बहुत जरूरी है। तो ये जो गोल सेटिंग है, असेसमेंट है, गोल सेटिंग है, मॉनिटरिंग है और फॉलोअप है, ये एक विजिट में नहीं होता है। तो इसीलिए आपके न्यूट्रिशनिस्ट से, आपके डाइटिशियन से आप बार बार संपर्क में आए, उनसे बात कीजिए। और एक डाइटरी एजुकेशन को अगर हम अपने आप में लेते हैं तो आगे जाकर क्रॉनिक किडनी डिसीज को या अदर किडनी प्रॉब्लम्स को हम आगे बढ़ने से अच्छे से रोक सकते हैं। रीनल न्यूट्रिशन के सब सीज है जहाँ पे हमारे क्लिनिशियंस, हमारे डाइट काउंसलर्स और हमारे केयर टेकर्स हमें मदद करने की काफी कोशिश करते हैं, बिकॉज रीनल न्यूट्रिशन इज वेरी कैलकुलेटिव। हर माइक्रो और मैक्रो न्यूट्रिएंट को कैलकुलेट किया जाना चाहिए। चैलेंजिंग रहता है क्योंकि पेशेंट्स के स्ट्रेस लेवल्स, ब्लड पैरामीटर्स लेवल और मूड लेवल्स पे भी काफी डिपेंडेंट होता है। तो एक चैलेंजिंग फैक्टर रहता है किडनी न्यूट्रिशन में। फिर कंसेप्चुअली चेंजिंग होता है। पुराने जमाने में कुछ चीजें थी जो मान्यता रहती थी कि किडनी के पेशेंट्स ने ये प्रोटीन बिल्कुल बंद कर देना चाहिए, बिना सोचे समझे सॉल्ट बंद कर देना चाहिए। तो ये सारी चीजें अभी इमर्जिंग न्यूट्रिशन साइंस और इमर्जिंग मेडिकल साइंस जो हमें पता चला है कि ये सारी धारणाएं जो थी वो अभी बदल रही है। और काफी सारे स्टडीज जो अनीता मैम ने भी अभी बताया कि जिसमें से चेंजेस दिखते हैं और धीरे धीरे हमें वो फॉलो करना जरूरी होता है। तो इन सब के लिए रीनल न्यूट्रिशन के लिए हमें अपने डाइटिशियंस से हमेशा संपर्क में रहना बहुत जरूरी है, क्योंकि हमारे कुकिंग मेथड्स को हमें बदलना है, हमारे कुलिनरी स्किल्स को हमें बदलना है। और कॉस्ट इफेक्टिवनेस, जहां एक बर्डन न्यूट्रिशन का है, आगे जाके ट्रीटमेंट मोडालिटी का भी है, तो कॉस्ट इफेक्टिवनेस ऑफ अ पर्टिकुलर डाइट शुड बी टेकन इनटू कंसिडरेशन एंड द कंफर्ट लेवल ऑफ द पेशेंट। हाँ, ये भी बहुत जरूरी है कि पेशेंट का जो आज तक का कंफर्ट लेवल था वो चेंज होना जरूरी है, क्योंकि जब तक पेशेंट का कंप्लायंस या पेशेंट का इच्छा जब तक इस डिसीज को प्रिवेंट करने का नहीं है, तब तक आप तक मदद नहीं पहुंच सकती है। सो दैट इज द रीजन व्हाई the dietitian is a link between your clinicians and your nephrologists and your patients. Now, 6 stages of effective dietetic counseling which needs to be done is there should be an effective communication in developing a rapport with your patients. Then there should be an assessment of the current diet plan of the patient as well as the current disease state of the patient. Now, goals and objectives are to be established, which should be mutually agreed upon by patients and diet consultant. As we have discussed, you develop a implementation plan. There should be food adjustments, modifications, imparting nutrition related education to the patients, and follow up of the given diet plan, which is very important. So these 6 effective stages in diet counseling, in which a nutrition expert must be able to understand the illness and dietary experience of the patients. She should be able to perceive each patient's experience as unique, because every patient is different. Foster a friendly relationship with the patient and his family members. Mutually decide goals on diet therapy. It should not be a one-way traffic or one-sided thing, but the patient's involvement is very important as far as goal setting is considered, and development of an awareness of diet and its long-term effects on the patient is very important. The nutrition expert should encourage patients to share their experiences with diet therapy, as कुछ unanswered questions रह गए हैं क्या, कुछ misconceptions है, कुछ myths है, कुछ misunderstandings है, क्या यूज करना चाहिए, कौन सा सॉल्ट यूज करना चाहिए, किस तरह से लीचिंग करना चाहिए, किस तरीके से वेजिटेबल्स बॉईल करना चाहिए, एनिमल प्रोटीन लेना है या प्लांट प्रोटीन लेना है. So all these misconceptions and misunderstandings should be dealt with and explained well. Any problems they are experiencing during diet therapy needs to be discussed. और patients खुद का diet monitor कर सकते हैं, और they have to maintain a diet diary wherein the nephrologists as well as the dietitians are being helped by the diet diary which they are maintaining. And they should be empowered to make the diet choices and the decisions independently, because unless and until the patients know as to what they are eating, how much they are eating, and what is the macro and micronutrient that needs to be taken, his blood pressures, his blood sugars, and his kidney parameters are difficult to maintain on a larger level by the nephrologist as well as the dietitian alone. So patients participation बहुत जरूरी है. Sometimes patients reveal नहीं करते हैं information जब तक आप उनके साथ एक dialogue initiate नहीं करते हैं. तो be friendly with your patients and think Indian. Thank you, ma'am. Thank you.
Thank you, Dr. Suniti, for the wonderful talk. It was a wonderful journey right from the beginning of one spectrum of the disease to the next, to the last spectrum of the disease. So I think we'll take up questions later on. Now we move on to the sharing experience of patients. So Dr. Shruti, would you like to start this session?
So the next session is by Ms. Zamrud Patel. So let me introduce Zamrud Patel. Ms. Zamrud Patel is the Chief Dietitian at Global Hospitals, Gleneagle Global Hospitals, Mumbai. She's also the president of the Mumbai chapter Indian Dietetics Association. She is a specialist in renal nutrition, honored with multiple awards, and has multiple chapters, and is a faculty in renal nutrition in the country. She is also a teacher in multiple of the renal nutrition courses for our students. So with that, I would like to invite Ms. Zamrud for giving us an enlightening session to our patients as to how can we give them handy tips to maintain their day-to-day activities.
So thank you very much for the kind invite and this kind introduction, Dr. Shruti. I will just start my screen sharing and hope my slides are visible. You can see my slides, right?
Yes.
Okay. तो मैं शुरू से सुनते आ रही हूँ, हमारे सारे डॉक्टर्स और हमारे डॉक्टर्स ने हमें बताया है कि कैसे हमें पहले हेल्दी रहना है, बीपी नहीं होना है, डायबिटीज नहीं होना है, अगर ये तकलीफें हो गई हैं उसकी वजह से किडनी को इफेक्ट है तो हमें क्या डाइट लेना है, किस किस न्यूट्रिएंट को हमको मॉडिफाई करना है, डॉक्टर अनीता ने हमें बताया, डॉक्टर सुनीति ने हमें बताया। तो मैं आपको एक सिंपल और हैंडी तरीके से एज अ पेशेंट के लिए जो इम्पोर्टेंट है मैं आपको वो समझाऊंगी कि व्हाट इज द डाइट जो आपको फॉलो करना है। बेसिकली सबसे पहले तो मैं ये बोलना चाहूंगी कि रीनल डाइट्स जो हम बोलते हैं ना, सीकेडी डाइट, वैसी कोई डाइट नहीं होती। हर पेशेंट अलग होता है, हर पेशेंट का रिक्वायरमेंट अलग होता है और उसके हिसाब से हमको डाइट मॉडिफाई करनी पड़ती है। जो भी रिस्ट्रिक्शंस के बारे में अभी हमने बात की, पोटेशियम का रिस्ट्रिक्शन, फॉस्फोरस का रिस्ट्रिक्शन, प्रोटीन का रिस्ट्रिक्शन, सब रिस्ट्रिक्शन सब पेशेंट को लागू होते हैं, ऐसे नहीं होता। तो आपको आपके डाइटिशियन के साथ में बैठना है और सीखना है कि आपके लिए क्या क्या है जो आपको नहीं खाना या आपको खाना है। ओके, और डेफिनेटली डाइटिशियन आपके सबसे अच्छे दोस्त हैं जो आपको समझाएंगे कि व्हाट यू आर सपोज्ड टू ईट एंड व्हाट यू आर नॉट सपोज्ड टू ईट। तो देयर आर सम बेसिक न्यूट्रिएंट्स जिसके बारे में ऑलरेडी बात हुई है जो हमें ध्यान में रखना है जब हम किडनी पेशेंट्स के लिए हम बात करते हैं। और मैं आपको जो भी हैंडी टिप्स और गाइडलाइंस दूंगी वो सीकेडी, जिनको क्रॉनिक किडनी डिजीज है, जो डायलिसिस पे है या जिनका ट्रांसप्लांट हो चुका है, मैं सब कैटेगरी के लिए बात करूंगी। और जो मेजर न्यूट्रिएंट के बारे में मैं बात करूंगी वो है प्रोटीन, कैलोरी, सोडियम, पोटेशियम, फ्लूइड और फॉस्फोरस। और अपने डे टू डे खाने में अगर आपको ये न्यूट्रिएंट्स का मॉडिफिकेशन बताया गया है तो क्या हम इंक्लूड कर सकते हैं और क्या हमें इंक्लूड नहीं करना। प्रोटीन्स बेसिकली अगर आप इंडियन डाइट्स देखोगे, इंडियन प्रीडोमिनेंटली एक कंट्री है जो वेजिटेरियन है। हमारे नॉन वेजिटेरियन लोग पे जो लेते हैं फूड वो भी बेसिकली जितना नॉनवेज लेते हैं वो बहुत कम मात्रा में होता है। तो वेजिटेरियन डाइट्स आर लो प्रोटीन डाइट्स। तो जब हम प्रोटीन के बारे में सोचें किडनी पेशेंट के लिए, मोस्ट ऑफ द टाइम हमारे पेशेंट उतना ही प्रोटीन खा रहे होते हैं जितनी जरूरत है। तो हमें घबराना नहीं है, जो हम खा रहे हैं हमें वो लिखना है, हमें डाइटिशियन को बताना है, कैलकुलेट करके देखना है कितना इनटेक है। क्योंकि इस बीमारी से यू गेट डिप्रेस्ड, यू आर नॉट एबल टू ईट वेल, आपका एपेटाइट कम होता है। डॉक्टर सुनीति ने हमें बताया कि कैसी एक डिजीज में हमारा एपेटाइट कम होता है, हमारा खाना कम होता है और हम लोग मैल न्यूट्रिशन की तरफ जाते हैं। तो इसके लिए एक जनरल रिकमेंडेशन ये है कि आपको प्रोटीन खाना है, बंद नहीं करना है। पहली चीज, आपके डाइटिशियन को आपका फूड डायरी दिखाइए, उन्हें कैलकुलेट करने दीजिए कि आप कितना प्रोटीन खा रहे हैं और अकॉर्डिंगली वो आपको ये माप दिख रहे हैं कटोरी के डेफिनेट यहाँ पर, तो आपको कितना खाना है। अगर नॉन वेजिटेरियन है आप तो आपको कितना नॉनवेज खाना है या दाल कितनी खानी है वो आपको डाइट में आपको बताएंगे। अगर आपको पोटेशियम भी रिस्ट्रिक्ट करना है तो आपको दाल कैसे लीच करके खाना है, बेसिकली पानी में उबाल के खाना है, वो आप खा सकते हैं। सब दालें आप यूज कर सकते हैं, उसमें कोई परहेज नहीं होता। सिर्फ प्रोटीन नहीं, हमें कैलोरीज भी अच्छे से चाहिए हमारे किडनी पेशेंट्स के लिए। ये कैलोरीज आएंगी कहाँ से? डेफिनेटली खाने से ही आएंगी। तो जो मक्खन आता है, जो व्हाइट मक्खन बोलते हैं बिना नमक का, किडनी पेशेंट्स वो मक्खन यूज कर सकते हैं। वो मक्खन को अपनी ग्रेवी में डाल सकते हैं, रोटी के ऊपर लगा सकते हैं। क्रीम जो आती है, दूध की मलाई, जितना आपका, अगर आपका लिपिड प्रोफाइल खराब नहीं है, आपका कोलेस्ट्रॉल ज्यादा नहीं है, तो आप क्रीम भी यूज कर सकते हैं। आजकल बाजार में सैलेड ड्रेसिंग्स मिलती है जो लो सोडियम की होती है, तो आपको लेबल पढ़ना है, देखना है। अगर आप डायबिटिक नहीं है तो आप हनी जो मिलती है, शहद जिसको हम बोलते हैं, या घर का बनाया हुआ जैम या जेली आप यूज कर सकते हैं। शक्कर का यूज हो सकता है, या साबूदाना या अरारूट जो स्टार्च बोलते हैं ना, आप वो यूज करके आपके डे टू डे खाने में अपनी कैलोरी की मात्रा बढ़ा सकते हैं। तो ये थोड़ी सी रेसिपी मैं आपको दिखा रही हूँ। जैसे आप रोटी बनाते हैं, खाखरा करते हैं, थेपला करते हैं, भाकरी करते हैं, तो नॉर्मली हम लोग गेहूं का आटा यूज करते हैं। तो गेहूं के आटे का कम प्रमाण करके अरारूट का आटा बढ़ाइए, और उबला हुआ अगर आप आलू उसमें डालो तो आप एक सीकेडी पेशेंट अपना कैलोरी बढ़ा सकता है। ये चपाती को या खाकरे को या थेपले को आप व्हाइट बटर लगाएंगे तो इसकी कैलोरी और बढ़ जाएगी। तो आपका न्यूट्रिशन अच्छा होगा विथ रिगार्ड्स टू द कैलोरी इनटेक। सिमिलरली नाश्ते के लिए आप ये जो सेव, पूरी, शक्करपारा, जीरा, अगर आपका लिपिड प्रोफाइल अच्छा है तो अगेन वही प्रोपोर्शन आप यूज कर सकते हैं। ये फ्राई आइटम आपके लिए बना सकते हैं, और आपके डाइटिशियन को बता के हफ्ते में 1 से 2 बार आप ये नाश्ता ले सकते हैं, ताकि आपका कैलोरी कंटेंट ऑफ द डाइट बढ़ा सके विदाउट इंक्रीजिंग द प्रोटीन कंटेंट। ओके, लेकिन कैलोरी सिर्फ बढ़ाना नहीं है, डायलिसिस के पेशेंट को प्रोटीन भी अच्छे से खाना है। और ये प्रोटीन कहाँ से आएगा? चीज से आएगा, पनीर से आ सकता है, दही से आ सकता है, नट से आ सकता है। डॉक्टर अनीता ने हमें बताया था कि अंडा बहुत अच्छा है। फॉस्फेरस की अगर किसी को तकलीफ है तो सिर्फ एग व्हाइट यूज करके आप आपका प्रोटीन ला सकते हैं विद, एंड अगेन मिल्क पाउडर यूज कर सकते हैं मिल्क के साथ में। तो ये तरीके हैं हमारे डायलिसिस पेशेंट का कैलोरी के साथ साथ प्रोटीन बढ़ाने के लिए भी। अगेन बहुत से सप्लीमेंट्स जो अवेलेबल हैं, हाई प्रोटीन और लो प्रोटीन दोनों अवेलेबल हैं। अगर आपको सीकेडी है, क्रॉनिक किडनी डिजीज है, तो आप लो प्रोटीन सप्लीमेंट यूज कर सकते हैं। ये डायलिसिस के पेशेंट सप्लीमेंट यूज कर सकते हैं। प्रोटीन के बिस्किट्स आते हैं, प्रोटीन के बार आते हैं जो चॉकलेट फ्लेवर्ड होते हैं, अलग अलग फ्लेवर में आते हैं, आप ये यूज कर सकते हैं। आप ये सप्लीमेंट्स के साथ में भी अपना डेली का आटा बना सकते हैं। जैसे कि मैंने आपको पहले बताया था कि कैलोरी सिर्फ बनाना है, प्रोटीन नहीं बढ़ाना है, तो आप अरारूट का आटा यूज कर लीजिए अपने रोटी में, खाकरे में, थेपले में, भाकरी में। यहाँ अगर आपको कैलोरी और प्रोटीन दोनों बढ़ाना है तो बेसन, जो चने का आटा होता है, आलू के साथ में मिक्स करके कैलोरी और प्रोटीन आप दोनों बढ़ा सकते हो। सिमिलरली आप ये फ्राई नाश्ता भी बना सकते हो, ये प्रोपोर्शन यूज करके डायलिसिस के पेशेंट, ताकि आपका कैलोरी और प्रोटीन दोनों बढ़ सके। ओके, और ये सब न्यूट्रिशनल रेसिपीज हैं। अब ट्रांसप्लांट के पेशेंट्स में हम नॉर्मली क्या करते हैं, ट्रांसप्लांट करके लोगों को नियर नॉर्मल डाइट की तरह बोला जाता है। प्रोटीन की मात्रा चाहिए, तो ये जितने भी फूड आपको दिख रहे हैं, वेजिटेरियन और नॉन वेजिटेरियन, जिसमें है दाल है, पल्सेस है, नट्स, ऑयल सीड्स है, नॉन वेजिटेरियन फूड है, अंडा है, दूध है, दही है, मक्खन है, तो ये सब चीजें आपको प्रोटीन्स दे रहा है प्रीडोमिनेंटली, नॉट बटर। बटर विल नॉट गिव यू प्रोटीन्स, बट अगर आप चीज यूज करते हो तो आपको डेफिनेटली प्रोटीन मिलेगा। तो हमारे जो ट्रांसप्लांट के जो पेशेंट्स हैं उनको भी कैलोरी और प्रोटीन दोनों चाहिए, क्योंकि लेकिन ट्रांसप्लांट के बाद में नॉर्मली एक प्रॉब्लम जो नॉर्मली देखा जाता है कि वजन बढ़ता है। तो हमें कैलोरीज कंट्रोल करनी है, तो हमें कॉम्प्लेक्स कार्बोहाइड्रेट्स यूज करने हैं। तो उसके लिए हम आप क्या यूज कर सकते हैं? गेहूं हुआ, ज्वार, बाजरा, पल्सेस और लेग्यूम्स। डॉक्टर सुनीति ने बात करी थी कॉम्प्लेक्स कार्बोहाइड्रेट के बारे में, जिन्होंने बताया था कि पल्सेस और लेग्यूम्स आप यूज कर सकते हैं, मिलेट्स आप यूज कर सकते हो, फ्रूट्स और वेजिटेबल्स बढ़ा सकते हो। तो आपका कैलोरी कंटेंट कम होगा बट प्रोटीन एडिक्वेट आएगा, और कॉम्प्लेक्स कार्बोहाइड्रेट की वजह से आपका वजन ज्यादा नहीं बढ़ेगा, क्योंकि ये हमको फाइबर देगा। तो ये जस्ट एक रेसिपी मैंने डाली है ट्रांसप्लांट पेशेंट के लिए, नॉर्मली बेक्ड वेजिटेबल इन। तो आप यहाँ पर व्हाइट सॉस जो बना रहे हैं, अगर आप देखोगे तो आप स्किम मिल्क का यूज कर रहे हो, और आप यहाँ पर नॉर्मली जो बेक्ड रेसिपीज हैं इसको हम लोग चीज से गार्निश करते हैं और बेक करते हैं। यहाँ हम पनीर से कर रहे हैं, वो भी लो फैट का है। तो ट्रांसप्लांट पेशेंट अच्छे से ये इस टाइप के रेसिपीज मॉडिफाई करके यूज कर सकते हैं। ये जनरल हिंट्स हैं जिसको आप मतलब कैसे आपको आपका वजन कंट्रोल करना है पोस्ट ट्रांसप्लांट। तो खाना अच्छे से चबाइए, डायरेक्टली प्लेट में रख के खाइए, डब्बों में से मत खाइए। जिस सिर्फ हम लोग नॉर्मल इंफॉर्मेशन देते हैं, 2 बार दिन में खाने के बजाय स्मॉल एंड फ्रीक्वेंट मील लीजिए। जो भी कैलोरी डेंस फूड है वो अपने घर में स्टोर मत कीजिए, ये जनरल गाइडलाइन है। और एक्सरसाइज जरूर कीजिए ट्रांसप्लांट पेशेंट के लिए। अभी जो मैं रिस्ट्रिक्शंस की बात करूंगी, किडनी पेशेंट जिनका क्रॉनिक किडनी डिजीज है या डायलिसिस है या ट्रांसप्लांट है, सबको ये परहेज जरूर लगता है, जो कि है नमक का परहेज या लो सोडियम डाइट। लो सोडियम डाइट में हम नॉर्मली पेशेंट को समझाते हैं कि उसको कितने ग्राम नमक लेना है, डाइटिशियन आपको बताते हैं। तो ये जो 1/4 टीस्पून यहाँ पर आपको दिख रही है ना, अगर आप इसमें लेवल करके नमक लेंगे तो 1 ग्राम नमक आता है। तो आपको आपके डाइटिशियन ने अगर बोला है कि आप 3 ग्राम नमक ले सकते हो, तो ऐसे 3 चम्मच नमक आप पूरे दिन में यूज कर सकते हो। हमेशा याद रखिए कि पैकेट फूड्स, जो प्रिजर्व फूड्स आते हैं, उनमें सोडियम की मात्रा ज्यादा होती है, तो उनको यूज नहीं करना है। बट उसकी जगह जो लिमिटेड पोर्शन सॉल्ट का है वो यूज कीजिए। फ्रेश फ्रूट्स और वेजिटेबल्स यूज कीजिए, क्योंकि जब आप वो यूज करोगे तो आपका खाना टेस्टी भी बनेगा और अच्छा भी बनेगा, और आपके लिए आपका सॉल्ट का पोर्शन कंट्रोल रहेगा। ऑलवेज जो किडनी पेशेंट है, ये जो सॉल्ट सब्स्टिट्यूट्स अवेलेबल हो रहे हैं मार्केट में, जो लोना बोलते हैं, डाइट सॉल्ट बोलते हैं, इनका उपयोग नहीं करना, क्योंकि ये पोटेशियम बेस्ड सॉल्ट होते हैं, आपका पोटेशियम बढ़ जाएगा। जैसे कि मैं आपको यहाँ पर दिखा रही हूँ कि ये लो सोडियम सॉल्ट जो मार्केट में आई है, जिसमें सोडियम 15 से 30% कम रहता है, ये दिखा रहा है यहाँ पर 15% सोडियम कम है, बट उसमें आपका पोटेशियम कंटेंट अगर आप देखोगे तो है। लेकिन इसमें क्या होता है, हमारे दिमाग में ये आता है कि अरे इसका सोडियम कम है, लो सोडियम सॉल्ट है, तो हम इसका मात्रा ज्यादा यूज करना चालू करते हैं, तो हमारा सोडियम उतनी हो जाता है। इसको भी आपको लिमिटेड पोर्शन में ही यूज करना है, अनलिमिटेड पोर्शन आप यूज नहीं कर सकते। दूसरा, ये लोना या जो लो सॉल्ट आता है, अगेन अगर आप यहाँ देखोगे इसका परसेंट, इसमें पोटेशियम की मात्रा ज्यादा होती है, तो आप ये सब्स्टिट्यूट यूज मत कीजिए। आपको जो यूज करना है वो ये फ्लेवर्स हैं जो हमारे घर में अवेलेबल है जब हम नमक कम करते हैं। नींबू का रस हुआ, इमली हुआ, कोकम हुआ, अमचूर पाउडर हुआ, विनेगर हुआ, या फूड जैसे कि टमाटो है, हरी मिर्ची है, स्प्रिंग अनियन है, अदरक है, गार्लिक है, जो लहसुन बोलते हैं, अगर आप ये बारीक काट के अपने खाने में डालो कम नमक के साथ, तो खाने का स्वाद अच्छा होता है। एक आपको सिर्फ एक सिंपल एग्जांपल दे रही हूँ अमचूर पाउडर का। इसको आप नमक की जगह पे एक्सचेंज कर सकते हैं, क्योंकि जब हमने इसका स्टडी किया तो इसमें सोडियम सिर्फ 6 मिलीग्राम दिखा रहा था, और पोटेशियम की भी कंटेंट इसमें ज्यादा नहीं है। तो मतलब जब आप खरीदते हो ड्राई मैंगो पाउडर, नॉर्मली क्या होता है कि आम को सुखाया जाता है, तो आम को नमक लगा के सुखाते हैं हम घर के लेवल पे। जब कमर्शियली उसको सुखाया जाता है तो नमक की मात्रा नहीं लगाई जाती, वो आम को मशीन में उसको सुखाया जाता है, तो उसकी सॉल्ट की मात्रा इतनी ज्यादा नहीं होती। तो ये जो कमर्शियली अवेलेबल अमचूर पाउडर है, लेवल पढ़ के आप उसको ले सकते हो। उसकी पोटेशियम की भी वैल्यू यहाँ दी होती है, लेकिन मैंने सिर्फ दिखाने के लिए कि इसका सोडियम कंटेंट कम है आपके लिए, ये आप इस तरीके का प्रोडक्ट यूज कर सकते हो। और डेफिनेटली हमने काफी रेसिपीज जनरेट करी है। एक सिंपल रेसिपी यहाँ पर है एक चाट मसाले की, जिसमें आप जीरा पाउडर, पेपर पाउडर, सिनेमन पाउडर और अमचूर पाउडर, इसको रोस्ट करके इसका पाउडर बना के रखेंगे, आप ऊपर से खाने में डाल के खाएंगे तो आपको खाने में स्वाद लगेगा। इसको आप सैलेड्स में भी यूज कर सकते हैं, आप आपके पराठा या पूरी के साथ में या रोटी के ऊपर भी स्प्रिंकल करके ऐसे भी खा सकते हो। ये थोड़ी चटनीज है, पेरू की चटनी, एप्पल की चटनी, कोकम की चटनी, इसकी रेसिपीज में आपको आगे दिखाऊंगी, मेरे बुक में है, तो आप वो बना के यूज कर सकते हैं, आपके खाने को स्वादिष्ट कर सकते हैं। जब हम सॉल्ट के परहेज की बात करते हैं तो फ्लूइड का परहेज भी आता है, और आपको एज अ पेशेंट ये मालूम होना जरूरी है कि क्या क्या फूड्स हैं जिसको हम फ्लूइड में काउंट करते हैं। सिर्फ पानी नहीं आता, चाय, कॉफी, दूध, लस्सी, छाछ, दही, सूप, जेली, कस्टर्ड, आइसक्रीम, जो भी जूसेस हैं वो सब हमको लिक्विड में गिनने जाते हैं। और अगर आपको फ्लूइड का रिस्ट्रिक्शन कहा गया है तो यू नीड टू कंट्रोल ऑल दीज फूड्स। और डिफरेंट मेथड्स आप छोटे कटोरी से यूज कीजिए। दही हंग कर्ड जिसको हम बोलते हैं ना, गाढ़ा दही यूज कीजिए दही की जगह। दूध की जगह पे उसका पनीर बनाइए ताकि वो लिक्विड में काउंट नहीं हो। जब आप कप या ग्लास का इस्तेमाल करें तो छोटे साइज का यूज कीजिए ताकि आप अपना फ्लूइड सेव कर सको। सॉल्टी फूड की मात्रा ज्यादा नहीं खानी है। पोटेशियम हाइपरकैलेमिया के लिए जो पोटेशियम का परहेज है, ऑल फूड्स गिव यू पोटेशियम, बट आप एक लो पोटेशियम फ्रूट यूज कर सकते हैं। डॉक्टर अनीता ने हमें बताया था कि हम कैसे पोटेशियम लीच कर सकते हैं। बेसिकली सब्जी को जनरस अमाउंट ऑफ पानी में रख के उसको बॉईल कीजिए, उसका वो पानी फेंक के ठंडे पानी में डाल के टेक्सचर मेंटेन कर सकते हो आप वेजिटेबल का, और फिर उसको पका के ले सकते हैं। इसको लीचिंग बोलते हैं। पोटेशियम भी जाएगा, सोडियम भी कम होगा और फास्फोरस भी थोड़ा कम होगा। अगर आप आटे यूज कर रहे हैं तो उसको छान के यूज कीजिए, उससे उसका पोटेशियम कम होगा। और ये लो पोटेशियम फ्रूट है। नॉर्मली फ्रूट्स में पोटेशियम ज्यादा होता है, ये लो पोटेशियम फ्रूट आप डेफिनेटली खा सकते हो। एक फ्रूट दिन का अराउंड 100 to 150 ग्राम के बीच में आप अपने डाइटिशियन के साथ बात करके यू कैन यूज दिस फ्रूट। अगेन फॉस्फरस के बारे में मैं ज्यादा बात नहीं करूंगी क्योंकि डॉक्टर सक्सेना ने बहुत अच्छा टॉक हमें बताया कि फॉस्फरस कहाँ से आता है। बेसिकली एक चीज याद रखिए कि तीनों पीस साथ में आती है। जो फूड हाई इन प्रोटीन होता है वो हाई इन फॉस्फरस होता है और हाई इन पोटेशियम होता है। तो अपने को वो ध्यान रखे, जो हाई प्रोटीन के फूड्स हैं, नॉन वेजिटेरियन फूड्स है, दाल्स और पल्सेस, जितनी मात्रा हमारे डाइटिशियन ने हमें बताई है हमें उतना ही यूज करना है, उससे ज्यादा यूज नहीं करना है। और सबसे इंपॉर्टेंट चीज जिसका हमें ध्यान रखना है, हमें हमारे फूड लेबल्स पढ़ना है। हमारे फूड लेबल पे न्यूट्रिशनल इंफॉर्मेशन रहती है कि क्या क्या है, कौन कौन सी कैलोरी आती है, कहाँ से कैलोरी आ रही है। फैट से देखिए यहाँ लिखिए 40 कैलोरी आ रही है, सोडियम कंटेंट कितना है, पोटेशियम कंटेंट कितना है, प्रोटीन कंटेंट कितना है, बाकी विटामिन जैसे फॉस्फोरस यहाँ पर 10% है। तो आप ये सब पढ़ेंगे, न्यूट्रिशन के बारे में समझेंगे, तो आप खुद अपना फूड चॉइसेस वाइजली कर सकते हैं और अपने लिए अच्छा खाने का चॉइस कर सकते हैं। तो इतना ही मैं आपको बताना चाहती हूँ कि डाइटरी मॉडिफिकेशन सब किडनी पेशेंट्स के लिए जरूरी है, बट सब रिस्ट्रिक्शन सब पेशेंट के लिए ऐसा नहीं है। डाइट को इंडिविजुअलाइज करना है और अपने डाइटिशियन से अपना डाइट डिस्कस करके अकॉर्डिंगली आपको अपना मील पैटर्न बनाना है। सो ये कुछ पब्लिकेशन है जिसमें मैंने पेशेंट्स के लिए बुक्स लिखे हैं, रेसिपी बुक्स भी हैं इसमें। तो आप हमारे वेबसाइट पे जाके ये सब बुक्स देख सकते हैं। दीज आर अवेलेबल ऑन दी वेबसाइट, यू कैन यूज दीज बुक्स। So thank you for your patient listening.
थैंक यू जमरूद, दैट वाज अ रियली एनलाइटनिंग टॉक। आई एम श्योर पेशेंट्स ने बहुत एंजॉय किया है। इनफैक्ट मैं चैट बॉक्स में देख रही हूँ कि लोगों ने पूछा है। एक क्वेश्चन ऐसा था कि सेंधा नमक लोग बहुत प्रेफर करते हैं एंड वही खाना है, तो मैंने रिप्लाई किया है कि सेंधा नमक में सॉल्ट थोड़ा सोडियम कंटेंट ज्यादा होता है, तो वो अपने लिए अच्छा नहीं है।
Yes.
अब हम नेक्स्ट सेशन की तरफ जाएंगे जो कि पेशेंट एक्सपीरियंस है। हमने आज ऐसे पेशेंट्स बुलाए हैं जिन्होंने बखूबी अपना डाइट मेंटेन किया है किडनी डिसीज के करियर में। किडनी डिसीज करियर क्या होता है कि भैया एक पेशेंट को क्रॉनिक किडनी डिसीज हो जाए, वो उसको कैसे मेंटेन करे, फिर अगर वो डायलिसिस पे है तो कैसे मेंटेन करे, और ट्रांसप्लांट हो जाए तो कैसे मेंटेन करे। तो लेट मी इनवाइट मिस्टर असीम चंद्रा, जो अपने क्रॉनिक किडनी केयर के बारे में हमको समझाएंगे कि उन्होंने कैसे अपना डाइट मेंटेन किया और कैसे अपनी हेल्थ को संभाली। मिस्टर असीम, यस, welcome Mr. Asim. Are you there?
Good evening. Yes, I am there. Good evening, everyone.
Good evening.
Can you hear
We
me?
can hear you. Go ahead.
See, I am a lawyer practicing in the Supreme Court of India. I had a very hectic lifestyle and I neglected my health. Let's be very fair about it. I had some blood pressure issues, but I thought that it's nothing. And I did not take any medicine, and it culminated in this kidney disorder. But I said I should follow a strict regimen and balance my work and treatment. I follow the diet prescribed by the dietitian. Mainly it's a vegetarian diet. Once in a while I may have non-vegetarian food. That's very rare, extremely rare. I do some exercise, yoga and all. And since I have a blood pressure issue, I try to avoid stress also. I have limited my work and I'm awaiting a transplant at the moment. My experience is that dialysis is a necessary mode of treatment. One should not avoid dialysis. And mentally, you have to be strong. You should feel that the disease is not taking over your mental faculty. And try to lead as normal a life as you can.
So,
It's
Mr.
been 3
Asim,
years.
thank you. Yeah. So we
Been
would
3
like to
years.
know that on dialysis, how good is your care on dialysis? That how do you follow the diet? How do you do some fluid restrictions?
I do not take more than 500 to 600 ml. That includes tea and water. I avoid fluids, so my water retention is extremely low. And exercising also helps. Fitness levels are good, and I feel everyone should. I am awaiting everyone should follow this. Be mentally strong. This disease is not that it will end your life. It has to be taken as a part of life. And you should consult your doctor regularly, be in touch with the dietitian, get the tests done so that you are not caught unaware that some parameters are going haywire. I think so. Thank you very much. Anything? I'm
So excellent. Yeah.
grateful to you, to Dr. Anita, and to you also for affording this opportunity to me to speak about the disease. Thank you very much.
So excellent. So from my Mr. Asim's message to us, we come to know that if you end up getting a chronic kidney disease because you were not guided or alerted right in time, maybe you did not get the opportunity to come across the right guidance, and you have landed up on dialysis. One, I would like to give a message at this point of time to all the patients, dietitians attending this meeting, that if you have diabetes, if you have blood pressure, if you have any risk factor because of which the kidney is getting damaged, it should be regularly followed. One, this is the time when diet is going to help your kidneys, not make you land up on dialysis. Two, if at all the kidney fails for whatever reason, that diet was done or not done, but the first preference initially should be transplantation followed by dialysis. So in our centers and based on the literature and the statistics, what we do is that if we see a patient progressing towards CKD stage 5, which is end stage kidney disease where dialysis is indicated, if possible, we try to go to a transplant immediately, because that saves the patient to go through the dialysis procedure, which is not required. But when you're on dialysis, you have to maintain your phosphorus, you have to maintain your salt, you have to maintain your water, and that makes you healthy to reach a transplant whenever possible, if it was not possible in the first place. But transplant remains the best option for the care of end-stage kidney disease. Now, going to the next patient, Dr. Manisha Hegde. She is a patient who has been a diabetic. She has a hereditary history of diabetes, and despite all her care, she is a diabetic, and she has been through dialysis and transplant. And I would like her to share her experience as to how she tried to maintain her health while a chronic kidney disease care, then on dialysis, and then on transplant. Manisha.
Good evening, everyone. This is Dr. Manisha Hegde. I'm a dental surgeon from Mumbai, and I've been Dr. Shruti Tapiawala's patient. I was diagnosed with CKD around late 2018, 2019. And although we had, as it started getting worse, I was considered for the transplant, and my husband agreed to donate his kidney to me. But because the pandemic set in around 2020, I had to wait for that, and I had about 1 year of dialysis, hemodialysis. And so the thing is that the fact of the matter is, everyone, all the doctors here, and the dietitian, nutritionist, everybody has spoken about everything. So the only thing I want to add is, first, as a doctor, many times you keep on giving instructions to the patients. Do this, do that, don't eat this, don't eat that, ye mat karo, ye mat karo. But when it happens to you, you're standing on the other side of the fence. And then the difficulties that the patient faces, they come to you. And with chronic kidney diseases are rather complicated. Agar diabetes hai ya hypertension hai, so most of the things are common sense that, meetha mat khao, tala hua mat khao, and packaged food and all. So it's like everyone knows that even if you just want to stay healthy, you don't have to eat that. Even if we all eat it once in a while, but we know that we shouldn't be eating that, drinking Coke and all that. But here it becomes complicated, because then all these things which you had heard in the 12th standard and forgotten about, all those elements come back. Sodium hai, potassium hai, phosphorus hai, and then protein hai ki nahi, and then wo usko balance karo. So as Zamrood ma'am was saying, and as everyone, all the doctors said, that between the nephrologist and the nutritionist, they are indeed your best friends. And like they make a joke that you say unko puchna padega, so that's literally what you have to do if anybody. And in another thing, I just want to say that at least India may, everybody wants to advise you when they hear that something. तो जितने मुंह उतनी बातें, like people will tell you, कोई बोलेगा cow urine पियो, कोई बोलेगा कि ये बाबा के पास जाओ, कोई बोलेगा take this puri, this जड़ी बूटी. So just one bit of advice. Everything else the doctors have told, that please ignore WhatsApp forwards. There was one doing the round saying keep the bricks under the bed and you can stop dialysis, and ridiculous things. Like, I mean, if all that was working, तो फिर बात ही क्या थी, मतलब किसी को कुछ नहीं होता. And please don't take any herbal supplements, any jari buki, anything you want to do, any medicine you want to take. My bit of advice is please check with your nephrologist, check with your nutritionist, and then only go forward. And I found the toughest part, I think, especially in a weather like India, is the water, the fluid. The moment I had my transplant, I had told everybody the first thing I want is unlimited cold water, like once you have the transplant. So, but most other things you can find, a replacement for every food. But for water, for fluid, there's no replacement. So, for that, I used to keep the bottles separate, 500 ml bottles. So you know that when you finish this is, and when you finish your tea or coffee, you pour it out, that much water. So you know. Other than that, I have nothing else to say except that thank you to all the nephrologists and all of you doctors, the nutritionists who are working so hard to, India being unfortunately the diabetes capital of the world and therefore following closely with chronic kidney disease. I just hope that all our voices are heard and our laws for organ transplant become better, so that those who are all suffering with dialysis and don't have a husband as kind as mine who is ready to give the kidney can move ahead and lead a better life. Thank you so much, everyone.
So thank you, Dr. Manisha, and that was indeed inspiring. And जो भी patient सुन रहे हैं, it becomes difficult. पता है कि पानी restrict करना, लेकिन एक अगर ठान ली तो वो हो जाता है. जब हमें बताया नहीं जाता है कि पानी कम मत पियो, तो हम पानी पीते ही नहीं है. पर जब हमें किसी ने बताया कि कम पियो, तो पहले ही पानी की तरफ ध्यान जाता है. तो अपना मन बनाइए, उसके लिए टिप्स निकालिए कि चलो पानी इतना भरा हुआ है, इतना ही लूंगी. अगर प्यास लगी है तो गार्गल कर लीजिए. ये एक बहुत हेल्पफुल ऑप्शन है कि आप पानी का एक घूंट लीजिए, उसको गार्गल करके फेंक दीजिए, तो आपका मुंह थोड़ा वेट हो जाएगा, आपको प्यास थोड़ी कम हो जाएगी और पानी शरीर के अंदर भी नहीं जाएगा. फिर आप पेपरमिंट्स ले सकते हो, आप लवंग है, इलायची है, चबा सकते हो ताकि सलाइवा ज्यादा जेनरेट हो. तो डायलिसिस लोगों को हेल्दी रहने, और ये पानी क्यों इतना इम्पोर्टेंट है, क्योंकि 2 डायलिसिस के बीच में अगर बहुत पानी बढ़ जाएगा, आपके हार्ट को लोड पड़ेगा एंड दैट विल वीकन योर हार्ट, व्हिच इज नॉट गुड फॉर यू. इसीलिए बहुत इंपॉर्टेंट चीज है. अगर हमने वेफर्स खा ली, हमने कुछ सॉल्टी चीजें खा ली, तो उसके पीछे पानी बहुत खींचेगा. So try to avoid salty stuff because it will pull water. You will want to drink more and more. दूसरी चीज, Dr. Manisha, yes, the government is working towards organ donation, but ये important है कि हम at our level are aware of organ donation after death. क्योंकि आए दिन इतने deaths हो रहे, rather than the government relaxing the laws, it is important for us to educate our society कि मरने के बाद भी जीवन है. हमारी डेथ में अगर हम 10 लोगों को हेल्प कर पाते हैं, लिटरली 10 पीपल, आईज, कॉर्निया, you have ears, cartilage, nasal bones, you have face transplants, you have hand transplants, heart, lungs, pancreas, liver, intestines, kidneys, skin. So इतने सारे लोगों को हेल्प होगा कि किसी को अपने नियर एंड डियर वंस को के पास ऑर्गन्स मांगने की जरूरत नहीं पड़ेगी. So that is a very important message we should take from here, that we all have to live healthy so that after death we can help people. अगर हमारा शरीर अनहेल्दी है तो हम किसी को हेल्प नहीं कर पाएंगे, वो ऑर्गन्स किसी के काम नहीं लगने पाए. तो ये भी बहुत important चीज है.
Right, Dr. Shruti, we'll have to wrap up the session now, and with the message that, well, I think patient counseling is the most important thing here. If the patient is clearly told why are these restrictions there, then I think then because he wants to live for a long time, why is it opted for dialysis? Because he wants to live, right? And he's opting for transplant because he wants to live. He loves life. So one has to explain. The counseling plays a very, very important role. So if you are able to explain to your patient, and if he understands very well, I'm sure he's going to take all the precautions. On this note, I'd like to thank all my wonderful esteemed invitee speakers and friends for making this session very lively with your thoughts. And I do hope that whatever has been discussed today is going to be of great benefit to our patients, and they're going to discuss to be more friendly with their dietitians and nephrologists, and sort their myths out and sort their problems out and discuss what are the ways out for them to lead a better life, eat well, and have a good quality of life. Thank you very much. So, Dr. Shruti, shall we start with the next
Yes,
session?
I think so. I'm just going to, Mr. Ganesh, you were here, you wanted to share your experience, but due to lack of time, we are not taking it, but we will take your experience and will display it on the website.
No, we can have him here. Let us start.
He's here already, but Mr. Ganesh, are you here? Sandhya ji and Ganesh ji?
Yeah, we are here, ma'am.
You want to just say 2 minutes?
Okay, ma'am. 2 minutes, ma'am.
So,
Okay,
Mr. Ganesh, if I can introduce him, Mr. Ganesh and Mrs. Ganesh, their son is Mr. Vignesh, who has studied law while he was on dialysis. And Mrs. Sandhya, who is his mother, has donated a second kidney. First time he underwent a cadaveric transplant, that is a deceased donor transplant. And then that kidney unfortunately failed in a few years. And then his mother, Mrs. Sandhya, has come forward and donated. Vignesh is busy at work. He's a lawyer by profession now, and he studied law while he was on dialysis. And it's a proud moment, you know, when he graduated as a lawyer and he was discharged as a transplant patient. So that was a very good birthday for him, I would say. So, Mr. Ganesh, you want to tell us how Vignesh is so particular on his care, his medications, his diet? Just 2 minutes before we wind up the session.
Sure, ma'am. Sure, ma'am. Thank you, ma'am. Very briefly, ma'am, I would like to thank all the doctors for this wonderful presentation this evening. In fact, so many things are unknown to us about BP or diabetes or even this kidney disease. Kidney disease is known to us only when we reach that stage 4 or stage 5. In my son's case, at the age of 17, he had symptoms. We went to the doctor, then the doctor sent us to a nephrologist, and then only we came to know the word creatinine. The creatinine word was not in our dictionary till that time. Nobody had any issues in our family. Ultimately, I won't take much time. Then he had to undergo dialysis for 1.5 years at the age of 17. Then, as Dr. Shruti rightly said, we went for a cadaveric transplant. We registered in Madras, Chennai, and that was done in 2013. He did his CA intermediate. We came back, and unfortunately, in the year 2018, roughly after 5 years, he had to undergo dialysis again because that transplanted kidney failed. Then my wife, that is my son's mother, had given. One more thing I want to tell: the blood groups didn't match. My son's blood group was O, and we all had A group. So my wife's blood group, which is A, across the blood group, was done in Global Hospital in the year 2019 May. I would just conclude that many of us don't know what is BP or diabetes or kidney disease, even knowledgeable people. In my own case, my son's case, we never came to know that he was suffering. Otherwise, we could have taken maybe preventive action much before. And as some doctors said, that don't go for jadi booty and all. I have seen even doctors asking, sorry to say this, ma'am, kidney fail हो गया, दोनों fail हो गया क्या? ऐसा ही पूछते हैं. Many people ask kidney failure, दोनों fail हो गया. Kidney failure means it is basically both. That is there. But even medical people ask, okay, I won't take much time, ma'am. My son is under the care and benign care of Dr. Shruti Tapiawala. He follows her dictums, her instructions regularly. He is very regimented. He knows, and I am proud that he has done his law also. But the point is, he understood his condition. Second transplant is also over, and he knows how to live with it, and he is a very happy-go-lucky person. He follows all the regulations, medicines meticulously, and we are under the control of Dr. Shruti Tapiawala, and we are also under control of many other doctors. And hopefully, my son will be doing very well. And this session, which we have listened to, and many people have listened to, is a wonderful session to bring to the awareness of all the people about the BP, diabetes, nutrition, and kidney disease, etc. I hope that people have benefited a lot about this, and I thank all the doctors here for the opportunity given to me to tell briefly about my son. Thank you so much, ma'am. Thank you so much, all doctors. Thank you for all the participants.
All right.
All the best.
Thank you, Mr. Manisha. If you would like to stay on with us for the next session, we can take you up more of your thoughts in the panel discussion. That's what I was thinking. If the patients want to stay back, they can, so that they can learn and we can have some more discussion. So
Sure.
we'll straight away move on to our next session. And for this session, we have 5 speakers. And without taking much of your time, I'd like to start with the first session and the first talk, and that is, I'll have to take up the first talk that is on dietary recommendations in CKD. So I'll share my screen. I hope the screen is visible.
Yes, but again in the non-presentation mode.
Non-presentation mode.
Yes.
Ma'am, I will request you again to share your screen on that.
All right. Okay. Got it. Good. So I'm sharing the screen, and I just click on to the. Is it okay now?
No, ma'am, don't click on presentation. Ma'am, just click on the desktop so that like your entire presentation will be visible, like you have done previously, ma'am.
I go to the share screen and then I go to the screen, right?
Yes, ma'am. Yes, ma'am.
Okay. Yeah. And now is it visible?
Yes, ma'am. Now it is visible full screen.
All right. Okay.
You're good to go, ma'am. Yeah,
right. So, so I'm going to talk to you about dietary recommendations in CKD. It's not, everybody knows everything about what to eat and what not to eat. Let me talk more about theory now. So kidneys, we know, are key homeostatic organs. And kidneys are involved in a series of life-sustaining mechanisms like excretion of body waste and nitrogenous waste, electrolyte balance of potassium and sodium, blood pressure regulation, fluid balance, hormone synthesis like EPO, renin, and vitamin D, then metabolic balance of pH through excretion of hydrogen ions and absorption of bicarbonate. Now, why are dietary recommendations required at all in CKD? Now, renal disease is very complicated. The term renal disease embraces a number of clinical conditions whose common feature is one, loss of kidney function. It's a progressive disease. There's a decrease in GFR with time, development of cardiovascular disease, and malnutrition. So undernutrition causes muscle protein loss and is the key contributor to the development of sarcopenia and frailty in CKD, which affects nutritional status. Therefore, nutrition has a vital role in chronic kidney disease. Now, as kidney disease progresses, the metabolic changes that take place in the body include inflammation, oxidative stress, insulin resistance, impaired glucose metabolism, protein catabolism, endothelial dysfunction, lipid abnormalities. And we have actually discussed a lot about blood pressure today and also about how to keep your blood sugars under control. Now, individuals with the CKD may have multiple comorbidities, including hypertension, type 2 diabetes mellitus, and cardiovascular disease, all of which are amenable to treatment with changes in nutrition. Now, the CKD Registry of India has shown that with increasing CKD stage, the BMI decreases. As you can see, the GFR, at the GFR of 90, the BMI is 26, and at the GFR of, when the patient is in CKD stage 5, GFR declines to something between 10 and 19. The BMI has dropped down to 21.7. Now, therefore, the objectives of nutritional intervention in CKD are to address the root causes of CKD, the diabetes, the hypertension, and obesity, decrease proteinuria, achieve and maintain optimal nutritional status and nitrogen balance to prevent malnutrition, wasting, fatigue, nausea, shortness of breath with optimization of fluid intake and poor quality of life, prevent buildup of toxic metabolites, metabolic products, such as minimizing the risk of uremia, and to avoid complications such as hyperphosphatemia, we've already discussed, to reduce the risk of secondary hyperparathyroidism and mineral bone disease, anemia, hyperkalemia, hypervolemia, metabolic acidosis, heart failure, and hypertension. So the aim of the nutritional intervention is to retard progression of disease. So let's talk about establishing healthful dietary patterns to prevent cardiovascular disease and chronic kidney disease. Now, the common elements of healthful dietary patterns include a variety of vegetables like fruits, grains, which 50% are whole, fat-free or low-fat dairy, which includes milk, yogurt, cheese, and fortified soy, purified and muffa oils, sources of protein such as legumes, nuts, seeds, soy, eggs, seafood, and lean meats. These patterns are also reduced in saturated fats, added sugar, and sodium. Now, there are several studies like DASH diet, the dietary approach to stop hypertension, OmniHeart study, the Mediterranean diet, the cardiovascular risk reduction. They all have suggested that reduce intake of saturated fat. So if you have a look at this table is showing you the higher saturated fat consumption is associated with the presence of high albuminuria. And lowering dietary intake of saturated fat may be associated with improved outcomes through reducing the risk of high albuminuria. Now, Nurses' Health study showed that higher dietary intake of animal fat is associated with presence of high albuminuria. And the multi-ethnic study of atherosclerosis, the MESA, has reported a direct association between each additional serving per day of non-dairy animal food intake with albumin-creatinine ratio. So we have to be very, very careful to avoid saturated fats and also the red meat. I'm going to talk about red meat also. MESA cohort reported that a diet pattern high in fats and processed meats was directly associated with markers of inflammation, including CRP levels. The high CRP levels have been directly and significantly associated with albuminuria levels in patients with type 2 diabetes mellitus. Inflammation may be a pathological link, therefore, between the saturated fat intake and presence of high albuminuria. The OmniHeart study has shown that if carbohydrates are partially replaced with unsaturated fat, predominantly the monounsaturated fat, then it lowers blood pressure, triglycerides, and increases HDL cholesterol. Now, AHA recommends a DASH diet for control of hypertension, but can our patients really afford to have such a high servings of fruits and green vegetables? It also recommends 2 to 4 servings of cereals and whole grains products as major sources of calories in diet from foods high in starches like bread, pasta, fortified cereal, potato, low-fat dairy products. Now, this is a DASH diet pyramid, which patients can use. And the most important thing that AHA always recommends is include soluble fiber in diet to reduce total and LDL cholesterol. Because for every 1 gram increase in soluble fiber, there's a concomitant decrease of LDL cholesterol by an average of 2.2 milligrams per deciliter. And the soluble fiber you can get from oats, from beans, from barley, and from lentils, and apples. The JNC report, this JNC7 report and the European Society of Cardiology, European Society of Hypertension recommend non-pharmacological interventions such as DASH diet and Mediterranean diet, along with weight loss, physical activity for primary and secondary prevention of hypertension. This is the Leonhardt study that recommends a Mediterranean diet. So Mediterranean diet is really rich in fruits, vegetables, bread, cereals, nuts, seeds, eggs, and poultry and olive oil. Well, in Indian scenario, you can always replace mustard oil for olive oil, and that's got enough amount of mucus, and potatoes and beans and, well, fish and poultry, well, everybody can take. That it strictly says avoid taking red meat, and such a diet is actually low in saturated fat. That is, it has about only less than 9% of the total energy. Plant foods and nuts are rich in fiber, antioxidants, polyphenols, along with extra virgin oil. So they put together, this combination confers a vasoprotective effect. Now, what do our guidelines for the kidney disease say? The kidney disease KDOQI, the KDOQI guidelines recommend a low protein diet for our patients, that is 0.55 to 0.6 grams per kg body weight per day of protein, along with, and at least 50% of this protein should be of high biological value. And the second option is the patient can go for a very low protein diet, that is 0.3 to 0.4 grams per kg body weight per day of protein, along with keto analog tablets, that is 1 tablet per 5 kilograms body weight. Or you can increase the protein intake to 0.4 to 0.5 grams per kg body weight per day, and add 1 keto tablet, that is 1 tablet per 10 kilograms body weight. This will prevent uremic symptoms and delay time to dialysis, and also lower phosphates. Now, if a patient is diabetic, then of course to start him, put the patient on 0.8 grams per kg body weight per day of protein. But as the GFR declines, you have to bring it down to 0.6 grams per kg body weight per day. And as far as the visible fat is concerned, you have to restrict fat. Zamrud has just now said that, well, once in a while you should go for, you can have fried stuff. Absolutely, that is a very good way of, increasing calories and keeping the psyche of the patient really, really good. But at the same time, for a regular routine thing, one has to restrict fat, which is about 15 to 20 grams per day. And a combination of fats should be used, that is peanut oil with mustard oil or rice bran oil or sunflower oil. And the dietary cholesterol should also be restricted to less than 200 milligrams per day. And omega-3 fatty acids, if the patient can take, will be really, really nice. And that will come only through the fish and the seafood. Sodium, of course, has to be restricted because our patients are edematous, and we do not want them to retain water or fluid, and also they are hypertensive. So keeping in mind their hypertensive state, one has to restrict sodium to between 1.5 to less than 2.4 grams per day. Now I'm going to talk about potassium. Potassium is very, very interesting in my talk here, because we're going to talk about more of plant-based diet. So the KDOQI guidelines, normally it is, if the patient's urine output is really good, you don't have to restrict potassium. But if it is hitting more than 5, if it is increasing to 5 milliequals per deciliter, then you have to restrict potassium intake. Or if the patient is taking potassium-sparing medications, then also you have to restrict potassium in these patients. However, if the urine output is low, then of course one should prescribe less than 1 milliequal per kg of potassium to the patient, and the patient has to avoid high potassium vegetables and fruits. Phosphorus restriction is between 800 to 1000 milligrams per day, that I've already discussed, and calcium should preferably be kept between 1200 to 1500 milligrams per day. And then anemia is very, very important. Anemia cannot be corrected with diet. That is one thing I always say. So you have to take, you can't follow the AHA guidelines to take plenty of grains and fruits and vegetables and have a and correct hyperhomocystinemia. No, we have to give folic acid to our patient to correct anemia. We have to correct the iron profile. We have to, give them EPOs and iron supplements and folic acid to combat anemia. Now, what is the effect of dietary protein on renal hemodynamics? Should we keep our patients on low protein diet or a normal to high protein diet? Now, we know that kidneys play a crucial role in amino acid and protein metabolism, including breakdown and excretion of protein metabolites. Dietary protein intake not only impacts metabolic processes regulated by kidney, but also on kidney function itself. So if you have a look at this figure, it's a very popular figure these days. This is showing you that a low protein diet has an independent therapeutic effect. The low protein diet causes vasoconstriction of afferent arterioles and vasodilation of efferent arterioles, reducing intraglomerular hypertension. And that's what is going to injure the patient. If the patient's gloms are having intraglomerular hypertension, then that's what is going to injure the patient's gloms, and thus preventing decline in renal function through angiotensin modulation. So what are the benefits of restricting protein in patients with chronic kidney disease? The benefits are that the postprandial hyperfiltration is reduced, proteinuria is reduced, and there's reduction in uremic toxins, phosphorus, PTH, metabolic acidosis, oxidative stress, insulin resistance, and blood pressure. And the overall result is that you have a better control of uremic symptoms, and you can delay progression of disease and delay dialysis initiation. However, there are some drawbacks to this very low protein diet. One is that you cannot really give adequate amount of calories with this. So the calorie intake is usually less than 30 kilocalories per day. We've done a study and we found that our patients were not deficient in protein intake, but they were actually deficient in energy intake. And protein loss and hypercatabolism will occur, of course, because you're not giving them enough calories. So whatever protein they're taking is also being utilized for providing energy for maintaining the metabolism of the body. And inflammation and worsening of acidemia and also glucose homeostasis. And so eventually the patient will get into protein energy wasting or malnutrition. And this is what we are directing towards. We're trying to prevent malnutrition from setting in our patients. And so the patient can have a worse clinical outcome. This is, if you have a look at this table is on the plant-dominant low-protein diet, which has recently become very, very popular. It's a talk of the town sort of a thing. So this is a diet which is predominantly plant, saying that you should take a lot of plant-based protein, and the protein can be between 0.6 to 0.8 grams, and at least 50% of the protein should be of plant sources. However, the sodium that I have marked in red is that it says take less than 4 grams per day of sodium. Although we prescribe with less than 2.4 grams of sodium per day, but this is, I think, a bit liberal about this. And of course, the good point about this diet is that it provides a lot of fiber to the patient, and the patient should be given adequate energy, that is 30 to 35 kilocalories per day. But what are the benefits of the low protein diet here? And at least with 50% of protein from the plant sources, it lowers intraglomerular pressures, and it is a synergistic effect with the RAS inhibitors and SGLT2 inhibitors. It controls uremia and delays dialysis. It prevents cardiovascular harm of meat. And less, because plant phosphorus is not really absorbed completely, so there's this less absorbable phosphorus, so you have less of hyperphosphatemia in these diets. And then there's lowering of acid load with the less acidogenicity, high dietary fiber, enhancing GI motility, and there are favorable changes in microbiome. Dysbiosis is something which is the talk of the town these days, because it is actually leading to more of a cardiovascular disease. So dysbiosis has to be tackled, and therefore, if it is a plant-based diet, you expect a lot of fiber to be there in the diet, and so we can expect some good results with that. And there's less of inflammation and oxidative stress with this kind of a diet, and therefore you will have less of uremic symptoms. However, the potential challenges of low protein diet, this kind of a diet, would be a high potassium load and hyperkalemia. So how will you restrict the patient from getting into a high potassium diet? That's very, very important. And then the patient may also be getting inadequate essential amino acids, and the patient may go into protein energy wasting. And so that is a very, very important thing. And the only talk about the renal nutrition, where the intervention is required, is to prevent protein energy malnutrition. This slide is showing you that restriction of protein in a low protein diet and encouraging plant protein up to 50% can be challenging for an already nutritionally compromised patient population of CKD, as malnutrition is an important concern. So low protein diet should be supplemented with calorie dense and low protein supplements, and keto analogs can be added to the diet. And if you add keto analogs to a very low protein diet, then the proteinuria, you have a beneficial effect on proteinuria reductions you can see here. Then metabolic acidosis is controlled, and also the phosphate levels reduce, because you're not taking too much of protein diet, animal-based protein diet. And the metabolic acidosis can be treated with an increased fruit and vegetable intake and oral alkali supplements in the absence of hyperkalemia. And this is our study in which we have shown that when you give a low protein diet supplemented with keto analogs, there is a lesser decline in renal function compared to the controls. And the annual rate of change in GFR is very, very low compared to the control population. Now, a second camp in the field of renal nutrition opines that even a protein intake of 0.6 grams per kg body per day needs to be supplemented by essential amino acids or keto analogs. In both the low protein diet and the very low protein diet, at least 50% of the dietary protein intake should be provided by high biological value proteins. And actually, the study that we did in that, the patients did not really restrict protein to 0.5, they were actually taking 0.6 grams per kg body weight per day of protein. So even the source of protein has independent therapeutic effect. We know that the plant protein is preferred over animal protein because there's 20% less proteinuria in soya-based diet, and fibrosis is lowest in soya group compared to the casein group, and reduced animal protein intake reduces glomerular hypertension. And if you have a look at this figure, these two figures are showing you that with animal protein load, then there's increase in the GFR and renal plasma flow compared to what happens when you give a soya-based protein. And here, similarly, you see that the percent change in fractional clearance of albumin and IgG is reduced in soya protein diet. So another study, the REGARD study, that's the reasons for geographical and racial differences in stroke, has shown that high intake of processed meats, saturated fats, fried fruits, refined grains, and sweetened beverages is associated with increased risk of all-cause mortality and ESRD. So the patient is bound to move faster towards ESRD if he's taking this kind of a diet, whereas patterns of eating characterized by high intake of nutrient-rich items such as fruits, vegetables, lean proteins, that is fish, and whole grains are associated with lower risk of all-cause mortality and ESRD. So here you can see that with the plant-based diet, there's low fat and high protein, while in the southern diet, that is meat-based diet, there is high fat intake. And so the high southern scores are associated with greater risk of incident ESRD. And here, this study has clearly shown that there's a strong dose-dependent positive association of red meat as a risk factor for ESRD, and that's what we're trying to stop patients from getting into. And there's no significant association with risk of ESRD with the intake of poultry, fish, and shellfish, eggs, and dairy products. So it's the red meat that is the culprit here. And here, if you have a look at this figure showing an inverse relationship between consumption of soy food, legumes, and the risk of ESRD. And here also, this is showing you the effective food replacement. So if you replace the food, substitute 1 serving of red meat with either 1 serving of poultry, fish, egg, or soya and legumes, it results in 48%, significantly 48% decline in the risk of ESRD. And if you replace one's daily serving of red meat with soya and legumes or eggs, it results in 50.4% and 44.9% reduction in ESRD risk respectively. So sticking to the plant-based diet is definitely a much better bargain. So proteinuria is an early and sensitive marker of kidney damage, we all know. So when you combine ACE inhibitors, have antiproteinuric effect, but if you combine low protein diet with ACE inhibitors, you have an additional advantage in the reduction of proteinuria. So one can combine plant-based diet with ACE inhibitors. Now, what about hyperphosphatemia? I've already spoken so much about hyperphosphatemia. Well, we have to restrict phosphorus, but which kind of protein would you prefer? Animal protein or plant protein? I would say a plant protein would be much better because there is 40 to 50% absorption of phosphates from the plant protein, and that would be much better. And of course, prefer foods with the low phosphorus to protein ratio, because otherwise the mortality risk can go up, and patients can use the phosphorus pyramid for guidance. Monitoring nutritional compliance to diet requires regular visits to renal dietitian and maintaining dietary diaries. So avoid foods with phosphorus-based additives like colas, enhanced restructured meats, snack bars, processed spreadable cheeses, instant products, and refrigerated bakery products. And remember that highest load of protein comes from hard cheese and nuts and eggs, yolk, meat, and poultry and fish. And this figure is showing you that in phosphate restricted diet, you have a better advantage in terms of serum phosphorus levels. So if you have a meat-based diet, you see the serum phosphorus levels are high. If you have a meat-based diet, you have a plasma calcium levels which are high. And if you have a meat-based diet, then the fractional excretion of phosphorus is high. So the take-home message of my talk is low-protein diet in CKD stages 2 to 5 non-dialysis can retard progression of renal failure and delay time to dialysis. Plant-based diets can alleviate hyperphosphatemia and metabolic acidosis, improve blood pressure control, insulin sensitivity, lipid profile, reduce proteinuria, and very low protein diet can preserve nutritional status. When you supplement it with keto analogs, and monitor potassium to prevent hyperkalemia. Excessive restriction of protein without monitoring of nutritional status can lead to malnutrition. And thank you for your attention.
Thank you, Dr. Anita. We will take the questions at the end, and as we have tried to request everyone, since we started the session 15 minutes late, we would request everyone to cut their talk by 5 minutes so that we can finish in time and do the panel discussion and take the questions so that we can finish in time.
Right, so now I invite Dr. Shruti to speak on preserving nutritional status in dialysis patients.
Okay. Thank you, Dr. Anita. So we thought, when we were making the program, we thought let us try and keep all practical sessions so that the attending dietitians, and if at all patients are attending, then they understand that what is our thinking and why we are so worried about your nutrition. So let us look at a case first. I always like to be clinical because everyone can correlate this with the patients they are seeing. So this is a 62-year-old lady who is an end-stage kidney disease on maintenance hemodialysis at a peripheral center. Diabetes mellitus, long-standing, hypertensive, has a diabetic neuropathy, vasculopathy, and has gangrenous digits. So you can understand that diabetes has damaged a lot of stuff around. She has decreased appetite and vomiting. Her labs are showing 8 gram per dl of hemoglobin. Albumin is 2.6, cholesterol is 100. That is total cholesterol. Her urea reduction ratio, now for the benefit of dietitians and for a few patients who might be attending, this means that, when you are dialyzed, we want your urea, blood urea level to be reduced by more than 60% after the dialysis, so as to understand that you have got adequate dialysis. But her urea reduction ratio was only 40, which means that she was not optimally being dialyzed. And she had a loss of muscle mass and a lot of wasting. She was skin and bones, and she presented to us in OPD. Keeping this case in background, let me take you through the nutrition issues in a dialysis patient and what should we focus. So, nutrition and dialysis. Catabolism of a body and metabolism is equal to nutrition. So, what you eat, what you destroy is nutrition. That is what your body understands. Nutritionally, you need proteins, carbohydrates, lipids, vitamins, minerals, essential things to maintain your nutrition, provided these are not destroyed by the catabolic state of the body. A disease Any disease, liver disease, kidney disease, any intervention like dialysis is going to alter all this balance. So now let us see what happens in a dialysis patient. So there are nutrient losses. So I'm going to try and focus it in such a way that, we understand how doctors think. Being a nephrologist, I like to see patients improving every day. So I want to make it simplified. So I want to understand, okay, this patient is coming on dialysis, what is happening? So there are nutrient losses. Amino acid losses are approximately 8 to 10 grams during dialysis, depending on the type of the dialyzer used. Now, the dialyzer has big pore sizes sometimes. You may be using high flux dialyzers and you may be losing more proteins. About 25 grams of glucose is removed during hemodialysis sessions with a glucose-free dialysate. That means you're losing calories also. And 30 grams of glucose is absorbed when dialysate containing glucose is used. So this is the difference which I want every dietitian to understand, that in a dialysis unit, what happens to the patient's body. Vitamin B1, B2, B6, ascorbic acid, folic acid are prone to be lost while on dialysis because these are water soluble. Whereas the loss of vitamin B12, which is protein bound, is negligible. So you all must have seen when you all are seeing patients that the vitamin B12 level somehow is more than 2000 when you see reports. But most of the other vitamins are deficient and the patients are showing vitamin deficiency signs. Sodium and water must be tightly restricted because you know that on dialysis you can remove only XYZ amount of water in the prescribed amount of time, and patients should not be left out with excess water. So patients have to be counseled against ingesting high sodium diets. Excessive sodium intake will lead to intradialytic weight gain, hypertension, edema, congestive heart failure, and increased risk of death. So you have to balance what you want to do on dialysis, you want to balance what you want to avoid on dialysis. Restriction of sodium intake and glucose control will further reduce the water intake. Like we heard our patient giving us her experience that, how tightly patients have to walk so that their heart is protected. Potassium, magnesium, phosphate. These are very poorly cleared on hemodialysis. In fact, phosphate, if you go to see, is a highly water-bound molecule. And what happens is the phosphorus clearance will only start after 6 to 8 hours of being on dialysis. And that is why on a normal dialysis, you will never be able to remove phosphate. Dietary intake of potassium of 70 MEQs or a 2 gram potassium in the diet should be restricted because potassium is going to go into overload if at all the patient does not restrict. For example, in India, in the season when mangoes are available, grapes are available, all the potassium rich fruits are available, juices are available, patients tend to get hyperkalemic because one way or the other these products. So we have to think what can happen and we have to counsel the patient. If 1 MEQ per liter of magnesium is there in the dialysate, magnesium intake should be only 200 to 300. Maintenance dialysis patients should be prescribed only XYZ amount of phosphorus. But very low phosphorus diets are extremely unpalatable and phosphate binders usually will be required. So we are worried about sodium, we are worried about potassium, we are worried about the minerals, we are worried about phosphorus, magnesium, we are worried about proteins being lost, glucose being lost. So everything is going haywire in this patient's body. That was hemodialysis. Now what is peritoneal dialysis doing? It again causes nutrient losses, but phosphorus and potassium have an increased clearance, so we can allow the intake to have a balance so that they can eat a little more. Potassium intake can be liberalized from 2 to 4 grams when patients are on PD. Phosphorus intake can also be increased because the clearance is better with a peritoneal membrane. Because of sodium sieving in peritoneal dialysis, water may be lost preferentially to the sodium. Very tight sodium restriction will be required and positive sodium balance should be avoided because it can lead to cardiac issues. Protein losses are more and in a peritoneal dialysate, which vary from 5 to 15 grams in 24 hours with albumin as the major constituent. average dialysate losses of free amino acids in dialysate during a CAPD, which is continuous ambulatory peritoneal dialysis, will vary from 1.2 to 3.4 grams in 24 hours. Hence, the protein intake will require to be higher in a peritoneal dialysis patient as compared to a hemodialysis patient. Now that makes a background of what dialysis does to you. Now I have only shown you protein losses. I have shown you what the patient has in excess. I have shown you what is lost in dialysis. Now let us see the major issues which we tackle every day. Malnutrition. Now this is very closely linked with dialysis patients and CKD stage 4 patients because it is a very important complication and around 34% of patients will display malnutrition. Presence of PM is one of the predictors of morbidity and mortality in CKD. So better fed patient, a better dialyzed patient is always going to have a better outcome. So why malnutrition? We understood what is happening on dialysis. Now let us see what are the other causes. So it has numerous causes in these patients. The nutrient intake declines. We as doctors, we as nutritionists tell the patient, "अरे ये क्यों खाया? इससे ये हो गया. ये मत खाओ, ये हो जाएगा." So patient is thoroughly confused, and the nutrient intake totally declines because by the time the patient reaches dialysis, he is so scared of eating that because of his eating, he has lost his kidney. Now he doesn't want to do anything. So he is confused. He is losing his interest. He is malnourished at this point of time. Decreased nutrient utilization happens. There are intercurrent illnesses. People can have cardiac events. People can have strokes. People can have severe blood losses. There are altered hormonal and metabolic functions. Loss of appetite due to increased leptin levels. Nausea and vomiting because of uremia and under dialysis like our patient had. If you remember, I told you she's under dialysis and she had nausea, vomiting and she was not eating. So that is also an important factor. Superimposed restrictions which we give, that, oh, you can't eat phosphorus, oh, you can't eat potassium, oh, you can't eat this. Then there is inflammation. So this adds to the catabolism because there is oxidative stress, there's carbonic stress, there's metabolic acidosis. Dialysis procedure itself is catabolism and there is so much of loss. Then there is a increase in the cytokines because the clearance is reduced on dialysis. So if you have cytokines circulating in your body, they are constantly adding to a catabolic state, which uses a lot of energy. Coexisting comorbidities again add to the dysfunction. So this is a beautiful chart which was made long back where a malnutrition and inflammation complex syndrome was identified, wherein you are adding the comorbidities, you are adding the dialysis stress, you are adding the inflammation, the malnutrition causative factors which lead to this syndrome. And this is the syndrome, if we understand, we will be able to help our patients better. People who are waiting on the list to get transplanted because they do not have a living donor will make it very well to the stage of transplant. So we saw the association that there is a link of inflammation and malnutrition, and it is very important to assess this. Now, what are the usual ways we assess? Standard is we look at the measurements, we look at the weight, we look at the ideal body weight, we will look at the height weight measurements, diet recall, anthropometry, biochemistry. What biochemistry do we see? We see transferrin saturation, we see ferritin, because these are signs of nutrition also, these are signs of inflammation also. We also look at cholesterol. Now, why cholesterol? Cholesterol is a reverse epidemiological factor in the nutrition because lower the cholesterol, the more you are malnourished. Why reverse epidemiology? Because in healthy individual, higher the cholesterol, the worse is your outcome. But in a dialysis patient or in a CKD patient, the lesser the cholesterol, the worse is your outcome. So we look at these things in biochemistry. Then there are multiple scores which have been generated wherein you can day to day assess the patients and understand whether the patient is really doing well or deteriorating. Because if you don't measure nutrition, you will lose the chance to help the patient have better outcomes and there will be more morbidity and mortality. So subjective global assessment is the simplest, so I thought I will concentrate in it a little bit. So it has a correlation with the medical history, with the physical examination, and it agrees with the objective methods of assessing nutrition. It is inexpensive, and as dietitians, you all will agree that it can be rapidly performed. And you can teach someone very quickly as to how to do it. It is easily reproducible. And these are the main factors that you have to see: the weight change, you have to see the dietary intake change, you have to see presence of GI symptoms, functional state, subcutaneous loss of fat, muscle wasting, edema. Higher the score, higher the SGA, worse is the nutrition. So this was a little bit of our study which we had done. And we were looking at CKD patients who were not on dialysis. We were looking at ESKD patients on hemodialysis, and we were looking at ESKD patients who were on peritoneal dialysis. And we found that 48% were mild to moderately malnourished as per the subjective global assessment. And this correlated very well with the anthropometric measurements. SG, however, did not correlate with the diet recall because the patients may forget what they ate and we might not be able to correlate. SG also did not correlate with the serum albumin levels in our study. Very understandable, because if you have an acute illness, serum albumin will drop because it is an acute phase reactant. So you may not be able to rely on it individually. Then there is something known as a malnutrition inflammation score. This was attempted because they wanted to add inflammation along with the nutritional status. So all of the SGA score was there, but they wanted to add biochemical parameters also. So nutritional history, physical examination, BMI, lab values, all these were added. So it makes it a composite score. And there were 4 levels, again 0 to 3, which was severely abnormal. And the sum of all the elements would have ranged from 0 to 30, 30 being severely malnourished. So this was how MIS came into being, but this was a little more complicated. So somewhere down the line, it became clear that we'll have to merge SGA with a little bit of biochemistry and go ahead. Then how do you check whether the patient is adherent to whatever advice you have done? So you have assessed the nutritional status, and you have given the patient that you are malnourished and you need to improvise on your diet because your nutrition is going down. Once the nutrition is down, you will talk to the doctors, you will talk to the patient, you will find out why the nutrition is down. The doctor will also try to find out, is there any medical reason why the nutrition is going down? And once the diet has been given, you will try to monitor the adherence. And this can be done with a 24-hour urinary, 24-hour nitrogen excretion with the dialysis nitrogen excretion, which is difficult. But I would say in a day-to-day status, SGA and a diet recall together work really well. And the caloric intake can be monitored. Now, how do you treat all this? So the treatment always depends on treating the acute illness. So if someone is ill with an infection, say this lady had a gangrene, had infections, and if I treat that, obviously the inflammation will come down. We will then count the proteins and calories, and we will try to build the muscle mass, and we will try to build the stores. So the dietary protein intake needs to be liberalized, and we need to reduce the inflammation. Sometimes supplements are necessary, not always. I see that many a time supplements are added initially and the patient stops eating normal food and eats only supplements. That should not be done. We should try to see that the patient can eat natural food, the food of his or her liking, and then you add a supplement. Sometimes intradialytic parenteral nutrition also appears to be effective, but it is not still superior to oral feeding. Okay, so we have to understand that we have to know what the patient is going through. We have to understand why is he not eating. That if you answer the why, you will be able to reach the end. Anabolic agents sometimes are helpful. You may want to add exercises to the dialysis, which will help the muscle mass to build. Optimal regimes need to be used. Carnitine is sometimes used, but not proven. Now let us go back to our case. So this was a 62-year-old lady, end-stage kidney disease, diabetes with diabetic complications with gangrene. Now we reviewed her SGA score when she came, me and Zamrud. We reviewed the SGA score and we found that her SGA score was 40. We were horrified. We were wondering now what we were going to do. There was a lot of muscle mass and wasting. We liberalized the intake. She said, I still cannot eat anything. You give me what you want, but I will not eat. We realized she was underdialyzed. I gave her aggressive dialysis for the first whole month, 4 times a week, giving her good dialysis, slow dialysis, and did URRs to find out if she was optimally diagnosed. She was not able to eat, hence we added nutritional supplements, and we gave her oral nutritional supplements during the dialysis session so that she could have it during the dialysis, and it was under our supervision before she went home. IV water-soluble vitamins were given thrice a week post-dialysis. Persistent counseling with the family, with the patient, encouragement, and important tender loving care. You need to give motivation to the patient that you will be able to do it. Outcome at 6 weeks, the HGA score came down. Patient started walking. Her oral intake reached a protein intake of 0.8 gram per kg per day. The calories reached 2000. She continued the supplements because she was scared of leaving it, given that she will again deteriorate. Dialysis, once optimized, was reduced back to thrice a week. So this was a success story which happened only because we were vigilant. We wanted to help the patient come out of this, and on war footing, we were working with her. So to summarize, malnutrition is very common in patients with ESKD on maintenance dialysis. In fact, if you go around your dialysis unit, you will find most of them, I would say 60% of people are malnourished. To level 1, level 2, level 3 SGA. Liberalization of oral intake, understanding their medical issues is very important. Regular nutritional assessment is required in patients on dialysis. And this is important, even if patients say that, no, I had met the nutritionist or the dietitian 1 month ago, abhi koi zarurat nahi hai. No, as doctors, we have to explain to them that this is needed, because a joint partnership of care is always what helps the patient. Appropriate medical and nutritional measures will improve the quality of life and give better outcomes. How to monitor? Practical tips. You do monthly SGA, and that is very easy. If the dietitian is just rounding once a month for all the 3 shifts, it is done. 6 to 8 weekly dialysis adequacy test, so that you know that the patient is well dialyzed. Do a serum albumin, do a phosphorus. Do lipid profile 6 monthly. Iron studies, ferritin. This is not extremely costly if followed like that. So the patient's pocket is also taken care of. Then you counsel the patients, clear their misconception, give helpful tips. 1, if you reduce food, you cannot reduce dialysis, because many patients have this misconception that if I don't eat, my dialysis will be lesser. And in that lalach, they don't eat. So we have to make them understand that you will lose your health rather than decreasing dialysis. It is not going to improve your kidney. Eat well, eat what you like is what we tell them. In fact, our patients eat ice cream, rasgullas, mangoes, whatever they want, because I tell them, when you come for a consult monthly, you tell me what you want to eat, I will adjust. Restrict fluid, restrict potassium, but tailor and adjust. Don't restrict food what the patient likes. Like if you want to give a potassium-rich food, you monitor the potassium. You give a low potassium bath. You say that you eat the mango just before you come for dialysis, and then give a low potassium. So, everything, we cannot say no to a patient. We have to say that we will adjust for you. You tell me what you want. So that's all for me today. Thank you.
Thank you, Dr. Shruti, for the wonderful advice and how to, go about monitoring nutrition status in our patients, and how friendly you can be with you must be a very popular doctor, I'm sure, amongst your patients. I think you have a very strong renal nutrition unit, because if you and Zamrud keep discussing all these things, it must be really great. Anyways, we now move on to our next presentation. Right. It's my pleasure to invite Dr. Nivedita Kamath, who is Associate Professor in the Department of Pediatric Nephrology at St. John's Medical College, Bangalore. Her area of interest is chronic kidney disease, chronic dialysis, and neonatal AKI. She's a pediatrician, by the way. And she holds an honorary faculty position at Kasturba Medical College, Bangalore. She's a member of Bulletin Editorial Board, Indian Society of Pediatric Nephrology, and member committee for Priorities in Low-Income Countries, International Pediatric Nephrology Association. And today she's going to talk about post-transplant care in children. So over to Dr. Kamath.
Thank you, ma'am, for the kind words of introduction. I hope you can hear me clearly.
Yeah, sure.
Ma'am, I think you'll have to stop sharing.
I already did.
I'm not able to share my screen.
Is it okay? I have. I'm not sharing the screen.
No, I'm not.
Mr. Siddharth, can you help? Are you there?
I'm not able to share my screen.
Just click on this share screen option, ma'am.
Yeah, it says screen, whiteboard, and iPhone, iPad, something. It doesn't give me the option of sharing my presentation. Can you see now? Ah, yes. Yeah. Can you see my screen now?
Yes.
Okay, thank you, ma'am. So we've had two wonderful talks about management of nutrition in patients with CKD and on dialysis. The most important aspect of nutrition needs to continue even in the post-transplant care. And today I'm going to focus on management of post-renal transplant care in children with a focus on nutrition, growth, and metabolic issues. So we'll look at three major aspects that are related to nutrition: obesity and metabolic syndrome, growth post-transplant, and post-transplant diabetes. So is nutritional status important in the post-transplant state? And are patients overweight or underweight? What is the scenario? So if we look at the large databases, this is data from the ERA EDTA registry, which is pertinent to children 0 to 15 years of age, including all children on dialysis as well as transplant. What you will notice is that
Dr. Nivedita, can I interrupt? Can you please be a bit louder because we're not able to hear you very well?
Okay, can you hear me better now, ma'am?
A little.
Okay. So if you look at this registry data that shows the 0 to 15 years, you will see that underweight is a very small percentage, especially in transplanted children. And as the children proceed from CKD to dialysis and to transplant, the prevalence of overweight and obesity increases significantly. So what did this registry show? That the prevalence of overweight was about 20%, obese was about 12.5%, and only 3.5% of patients were underweight. Mostly they were infants and on dialysis. The overweight and obesity was associated with a longer duration of dialysis, transplant with a functioning graft, short stature, and those who were on steroid therapy. So this is an important risk factor for obesity or overweight post-transplant. Is the nutritional status important in terms of graft and patient survival? This is interesting data which is done on about 18,000 patients from the OPTN registry from the US, which has shown that obesity and overweight greatly increase the risks of delayed graft function and acute rejection. Obesity itself was associated with prolonged hospitalization, graft failure, and mortality. So definitely it has an overbearing influence on the graft outcome. What about the patient survival? The patient survival also, it showed that those who were underweight had a lower risk of 1-year graft failure, overall graft failure in older children, and lesser amount of acute rejection. The patient survival was also better in those who were normal weight and underweight, showing that overweight definitely affects both the patient and the graft survival. Again, this is data from the ANS registry, which shows that the prevalence of overweight and obese was similar to that of the European and the United States cohort. Obesity was associated with an increased risk of graft failure, but no increased risk of acute rejection or mortality. All in all, we definitely know that obesity and overweight are important risk factors for poor graft and patient survival in the post-transplant period. But in the CKD and dialysis population, what do we see more commonly? Unfortunately, we do not have much data of post-transplant from developing or LMICs in children. So I'm looking at the IPPN data, which is the International Pediatric Peritoneal Dialysis Registry data, which shows us that the prevalence of underweight was very high in LMIC in children on chronic peritoneal dialysis. Obesity in infants and underweight in older children is associated with a higher risk of mortality. So this is probably commiserating with the kind of scenario that we see in countries like ours, and which is also seen in adult population, where both overweight and underweight are associated with higher risks of morbidity as well as mortality through the CKD, dialysis and transplantation period. So you can see that the prevalence of underweight in India was much, much higher than United States, Europe, and the Middle East. What about the experience from our center? In a study that was done by Dr. Arpana, we found that PEW was seen in about 47% of our children with CKD stages 2 to 4, and it goes up to 73% in children on dialysis. Short stature in another cohort study that we did was seen in about 2/3 of our patients with CKD stages 2 to 4. And you can see that the weight and height Z-scores are extremely low in our patients on peritoneal dialysis. Overall, what we can gather is our patients have weight and height that is much less than the expected in the CKD as well as in the dialysis population. Unfortunately, we do not have published data of what happens to them post-transplant, but from our experience, we have found that though there is a significant height gain post-transplant, they never reach their adult height because they have a huge deficit of height. The weight gain occurs rapidly, especially in the first 6 to 12 months, almost always causing overweight and obesity in our patients in the first year of transplant. So what are the risk factors and consequences of obesity? The risk factors are obvious. One is the baseline BMI and the short stature itself, the improvement in the appetite, the taste sensation, lesser dietary restrictions, a sedentary lifestyle, and low physical fitness in the post-transplant period with a good functioning graft, and of course the most important culprit, the use of corticosteroids. Obesity itself is one of the important components of the metabolic syndrome, in which in addition to obesity, there is hypertension, low HDL cholesterol, hypertriglyceridemia, and hyperglycemia. In addition, calcineurin inhibitors themselves contribute to the metabolic syndrome in the form of hypertension and dyslipidemia. All these are important risk factors for cardiovascular disease, most importantly demonstrated as left ventricular hypertrophy in children, but of course microvascular changes have also been studied. And we know that cardiovascular disease is the second most important cause of mortality, next only to infections in children in the post-transplant period. There are both transplant related as well as non-transplant related, which are mainly related to the genetics and environment that contribute to the metabolic syndrome after transplant, which as Dr. Shruti has already demonstrated in the dialysis population, increases the inflammatory cytokines and results in both early cardiovascular outcomes that are not favorable as well as late cardiovascular outcomes. Of course, there is no much data about the late cardiovascular outcomes in children, but it is probably just a logical sequence that is waiting to happen in young adults. How do we measure obesity? The recommendation or the most commonly used parameter is BMI percentile for age, where 85th to 95th is defined as overweight and greater than the 95th is defined as obesity. Of course, abdominal obesity is a much better marker and has shown better correlation with cardiovascular outcomes, and measurement of the waist circumference and waist to height ratio are what are recommended. However, there are no guidelines as yet to use them in regular practice. They have been used more in the research scenario. The Pediatric Renal Nutrition Task Force guidelines for children post-transplant have categorized them based on their age. Children aged 2 to 5 years and children aged more than 5 years. And overweight in children less than 5 years is defined as weight for height more than 2 standard deviations, and obesity is based on weight for height more than 3 standard deviations. In children above 5 years, overweight and obesity are based on the BMI for age, more than 1 standard deviation and more than 2 standard deviation respectively. Metabolic syndrome we know is the presence of overweight or obesity along with 2 out of 4 additional cardiovascular risk factors. That is hypertension, which is defined as systolic or diastolic blood pressure more than 90th percentile or more than 130/80 in adolescents, or on antihypertensive medications. Fasting triglycerides, which are more than 100 milligram per deciliter in less than 10-year-olds or more than 130 milligram per deciliter in more than 10-year-olds. Fasting HDL, which is less than 40, and serum glucose more than 100 milligram per deciliter, or a known type 2 diabetes mellitus. Let's go to the next problem, that is growth. This is something that is unique to children. How important is this? Again, short stature both in CKD and post-transplant has been associated with increased mortality, increased risk and duration of hospitalization, lower adult final height, and also has a bearing on the quality of life of these patients. What are the risk factors for growth after kidney transplant? Of course, there are some non-modifiable risk factors like SGA, that is small for gestational age, born low birth weight, parental height, which is an important determinant of the final adult height, the age at which transplant is done, the pre-transplant growth deficit and growth hormone use in the pre-transplant period, and some transplant-related risk factors like the graft function, EGFR. There is not much data whether preemptive transplant is useful, but some studies have shown that a live donor and preemptive transplant are important factors for growth after transplant. But the most important probably is exposure to steroids and steroid dosage. This is data from the Napritics. It's slightly old, but this is the most recent data that is available. You can see that the catch-up growth occurs in the first 2 to 3 years or maximum of 4 years of transplant, and then finally plateaus, and they actually do not gain much height in terms of change in Z-scores. So the height gain is maximum in the younger age group of 0 to 1 years and 2 to 5 years, and much lesser in the older children. What is it that can make a difference? The most important is steroid therapy. So steroid avoidance or withdrawal protocols, as you can see in this forest plot, in the prepubertal age group has a significant impact on increasing the growth. In the post-pubertal or pubertal age group, the impact is not as much, but definitely there is some improvement in growth in some studies. Again, comparing the complete withdrawal to early withdrawal and late withdrawal, it was shown that early withdrawal has the best impact on growth. So early withdrawal or avoidance protocols have been recommended in children who are undergoing transplant. Not only is steroid avoidance and withdrawal beneficial in terms of growth, but it is also found to have a significant reduction in hypertension and new onset diabetes, or PTDM as it is now called, but no significant reduction in the risk of infections. The second most important therapy that can be used is growth hormone replacement in the post-transplant period. Again, there aren't many studies, but the studies have shown that use of growth hormone in the post-transplant period results in a significant increase in the height standard deviation scores in children, especially in the prepubertal age group, and also when it is used with steroid minimization protocols. Coming to the third important problem, that is new onset diabetes after transplant, which is now it's gone back to the old terminology of post-transplant diabetes mellitus. The prevalence is Probably this problem is not faced as much by pediatric nephrologists as it is by adult nephrologists, but definitely it is a known problem. It can occur in about 3 to 20% based on different databases. It is associated with cardiovascular and infectious complications, both of which are important causes of mortality and morbidity in the transplant group, and adversely affects the patient and graft survival. The OPTN data showed that the prevalence is about 3.5%. However, this data did not show an impact on patient or graft survival. This is one of the studies that is done from India, which elegantly shows that in the earlier decade, from 1991 to 2005, the prevalence of NODAT was about 15%, which has increased in the next 10 years, that is in the more recent times, to almost 20%, and this is statistically significant. So we know that PTDM or NODAT is increasing, and what are the important risk factors for this? Reduced insulin secretion mainly happens in the post-transplant scenarios due to calcineurin inhibitors that are the immunosuppressive drugs of choice. Tacrolimus is more predisposing to this condition rather than cyclosporin. Sirolimus and mTOR inhibitors are also equal culprits. Certain native kidney diseases itself, like cystinosis, may contribute to this. Increased insulin clearance due to the normal function and the good graft function itself. Increased insulin resistance is another important aspect. This could be related to the ethnicity, to increasing obesity and metabolic syndrome, the rapid post-transplant weight gain, which is very typically seen in our malnourished children, HIV and CMV infections, the use of steroids, and sirolimus also. There are certain genotype carriers which significantly increase the risk of developing PTDM. The diagnostic criteria is similar to that which is used in adults. The screening protocols are, as we know, the risk of PTDM is highest in the first year after transplant. So very aggressive monitoring for fasting glucose, OGTTs, and HbA1c weekly for the first 4 weeks, every 3 months for the first year, and annually thereafter is recommended. The therapeutic options are 3: lifestyle modifications with diet, exercise, and weight control, and options for an alternate immunosuppressive regimen. We'll look at that shortly, and pharmacological therapy to treat hyperglycemia. The treatment targets are maintaining the fasting glucose between 90 and 126 or 130, a 2-hour plasma glucose of less than 200, and a HbA1c, at least in the initial period, less than 7%. What are the important lifestyle modifications? Diet therapy to reduce carbohydrate, high fiber, and low fat diet. Weight loss is recommended, and this should be based on the BMI. Studies have shown that daily exercise of about 60 minutes significantly improves the glucose tolerance. Immunosuppression modification, we know that steroid avoidance does help, or steroid withdrawal, early steroid withdrawal has a significant benefit on reducing the risk of PTDM. CNIs may be reduced to the minimum possible dose, but we know that this is the major immunosuppression that we need to keep the graft going. So this has to be done carefully with regular monitoring of the trough levels. Metformin is the drug of choice, especially in EGFRs more than 30. In the initial phases of severe hypoglycemia, insulin may be used. SGLT2 inhibitors and GLP-1 receptor antagonists are approved in adults with cardiovascular risk, but there is no data regarding its use in children. So these are all the options that are available as glucose reducing agent, and only metformin and insulin have been approved for use in children. Prevention is by preventing the rapid weight gain or encouraging weight loss in the post-transplant period. Exercise, we have seen the benefits of exercise in the CKD and dialysis period, and this continues into the transplant period too. Modified immunosuppression protocols have actually not shown any significant benefit, and the benefit versus risk ratio of reducing immunosuppression to maintain graft function should be kept in mind. Magnesium supplements have been found in some small studies to be beneficial, but there are no recommendations on this as yet. Early detection and treatment of hepatitis C and CMV viruses is required in high-risk patients. Coming to what are the guidelines for nutrition, The recommended calorie and protein intake. The previous speakers have alluded to a significant amount of protein restriction for preserving the residual renal function and preventing the progression of CKD. This is something that is very different in the pediatric age group, where children are in the phase of rapid growth and no protein restriction is advocated at any stage. So the calorie and protein intake is almost equal to that of the normal that is normally recommended for age itself, with no restriction being advised. We've also discussed about Mediterranean diet, the DASH diet, and in patients with CKD. In children, surprisingly, it has been studied in great detail in normal, healthy children with obesity or overweight, and it has found to decrease the BMI or metabolic syndrome in these children. However, there are no studies in children with CKD. But in a transplant patient with a normal graft, probably we could recommend these dietary modifications to reduce the metabolic syndrome and obesity. Similarly, the DASH diet also has found to significantly reduce the BMI and systolic blood pressure in the pediatric population, that is the general population with obesity, but no data from children in CKD. A high fiber diet of about 10 to 25 grams based on the age of the child is recommended. Along with nutrition, we also need lifestyle management. Studies in children with CKD have found that they have significantly lower physical activity compared to the general population. Increased screen time, which is now also a problem with the general population, is present. A meta-analysis of children with obesity showed that exercise for 50 minutes thrice a week, which includes both aerobic and combined with strength training, both either aerobic or aerobic and combined strength training, both had equal efficacy in reducing the BMI significantly. And probably this can be translated into the transplant population as well. Certain behavioral modifications, again, studied in the general population of children. Longer sleep, better sleep quality are associated with lower obesity and better emotional outcomes, and increased screen time is associated. So reducing screen time is something that is very important in the counseling phase. No studies in children regarding the use of anti-obesity drugs or surgery, so this would definitely not be recommended. Now, we said that growth hormone is an important aspect of nutrition and post-transplant care in children as compared to adults. So growth hormone therapy, it should be done only after optimizing nutrition, if possible steroid minimization or withdrawal, and taking care of all the other risk factors like acidosis or hyperparathyroidism, if it is there, should be taken care before growth hormone therapy is instituted. In CKD stages 3 to 5D, the recommendations are to give it in if the height centile is less than the third centile or less than minus 1.88 z-scores, height velocity is less than the 25th centile, and after treating all potential causes of growth retardation. In the post-transplant phase, it is recommended only after 1 year of transplant if there is no catch-up after adequate nutrition and steroid minimization has been attempted. The dose is the standard recommended of 0.045 to 0.05 mg per kg subcutaneously every day. For a maximum of, most of the growth potential is achieved in the first 2 years, and it can be given for a maximum of 4 years till the growth velocity reduces below 2 centimeters per year. One of the more important concerns in the post-transplant period is the risk of rejection and progression of kidney disease. But there is all the large trials done in CKD and in transplant have not shown any increase in the risk of rejection or progression of kidney disease with the use of growth hormone. So it is definitely safe. We know the other side effects that need to be monitored, like raised intracranial hypertension, the risk of slip capital femoral epiphysis, and all these need to be monitored on a regular basis. To summarize, obesity and metabolic syndrome are common in the post-transplant period as opposed to the CKD dialysis phases, and have an important bearing on the graft and patient outcomes. Growth retardation, unique to the children who are undergoing transplant, can be effectively treated by steroid minimization and growth hormone therapy. Post-transplant diabetes, regular monitoring is required for early detection, and Along with the pharmacological therapy, we need diet, modification, physical activity or exercise, and these are key aspects in post-transplant care. So with every child who's in the post-transplant phase on follow-up, we must pay attention to these aspects. Thank you. Ma'am, you're muted.
Dr. Anita, you're
Yeah,
muted.
yeah. Hi. I'm sorry. Dr. Nivedita, thank you so much for that excellent talk. And we now move on to the debate on whether the CKD patient should be advised a vegetarian diet or a non-vegetarian diet. And for this, we have two expert dietitians, Ms. Zamrud Patel and Ms. Ipshita Chakravarti. Let me introduce them to you first. Okay. Ms. Samrut Patel, she's already presented a talk earlier on. She is a registered dietitian and head department of dietetics. She's the chief dietitian at Global Hospitals, Mumbai. And she's very active academically as well as in research. And she's published several books for a good care of nutrition in patients. And she's chapter convener, Indian Dietetics Association Mumbai chapter. She's guide and co-guide for graduate and postgraduate students at the University of Mumbai. And she's given several lectures at various national conferences and seminars, and that's how we know her. And so she'll probably be talking on pro-vegetarian diet. And also, let me introduce the other speaker, Mrs. Ipshita Chakravarti. She's also a registered dietitian at Bellevue Clinic, Kolkata. She's been in this field for the last 22 years, and she's worked in hospitals of repute like Woodlands Medical Center, Wokhad Hospital as chief dietitian, in Fortis Hospital and the Kidney Institute, and also headed the quality department here. And she's a former HOD dietetics, the Calcutta Medical Research Institute. She has special interest in renal nutrition, and she holds 5 LLL certification from IPN ESPN, also done certification from American Academy of Continuous Education, and she's done her FODMAP course from Monash University, Australia. She's also been the General Secretary of Indian Dietetics Association from 2011 to 2018 and is presently holding the National Treasurer post. She's been in the scientific committee of different conferences, and she's published articles in various languages, in various magazines and e-publications. And she's going to speak in favor of non-vegetarian diet because she comes from Kolkata and she finds fish a very, very attractive option for good protein of high biological value. So over to you two girls, and let's hear what you have to say.
Should I start, Dr. Anita?
Yeah, sure.
So firstly, I would like to thank you for making my debate topic very easy, because from your talk, everybody has got the feel that what are the vegetarian diets and what are the benefits of a vegetarian diet. Okay, so can you see my slides? So when we are talking of vegetarian diets, basically we are talking of low protein diets, right? The benefits that a low protein diet gives to a patient of chronic kidney disease are visible with a vegetarian diet. And that is why I think for a country like ours, where we are vegetarian, that is one part to it. And second thing, the economical burden can be reduced by using these diets and giving better quality of life to our patients is very important. So So just to highlight the fact that kidney is an organ which actually, what is the main function of the kidney is to clear the waste products generated from protein metabolism. Okay, it eliminates from the protein metabolism, and that is the reason we need to give our patients a low protein diet, and vegetarian diets actually give us that type of protein intake. And what happens in chronic kidney disease? Basically, as the disease progresses, the number of functioning nephrons are reduced. And when you continue to eat the same food, the load on the kidney relatively increases because you're eating the same amount of proteins, and the flushing capacity of your kidney is now less. So you definitely need to understand this model. I'm sure Dr. Anita has explained it beautifully in her talk, that when we are eating proteins, there is a afferent arteriole which expands, and there is contraction of the afferent arteriole which increases the intraglomerular pressure, which causes hyperfiltration. And that is the reason we should not be eating more proteins. We should be eating a low protein diet. And what best than the normal intake of a vegetarian Indian who eats that much amount of proteins. Now this is just to show that in experimental studies which were done in rats, where they removed 90% of the kidney mass from the rats, and they put them into two groups, one the control group who was fed their usual proteins, and the other group which was given a protein restricted diet. They found that, you know, in the study group, that hemodynamic changes that we just spoke about were significantly less, and this was associated with less of proteinuria, hypertension, and retardation in the rate of decline of kidney functions. So probably the benefit of a vegetarian diet is tremendous for our kidney patients. So why should we not opt for this diet for our patients? Again, if you see the Brenner's hypothesis, hemodynamic changes that occur which cause the progression of the disease are again because when you eat unrestricted protein intake, it decreases the number of functioning nephrons, which increase glomerular blood flow, which causes increase in the capillary pressure and thereby causes further sclerosis. So why should we be using such proteins which will cause us problem, and why not stick with a vegetarian diet which would be beneficial? And there are a number of studies which show us the benefit of these low protein diets. Of course, that means a vegetarian diet. The chemical changes that are also associated with chronic kidney disease, that is azotemia, acidosis, hyperkalemia, hyperphosphatemia, hypocalcemia, all this play a major role in the progression of the disease. Okay, and Dr. Anita beautifully explained to us, talking about phosphorus, that how from a vegetarian protein diet, you do not absorb much amount of phosphorus. Of course, hyperkalemia may be a challenge, but if you give your patients the right type of vegetarian protein, which is calculated in potassium, you're using a low potassium source, definitely that would also not be a problem for our patients. These chemical changes will also not have an impact on the progression of the disease. Okay, that this means restricting proteins can minimize these hemodynamic and chemical changes in our patients. So vegetarian diet is giving us this benefit in our patients. And if you see the MDRD trial, this clearly showed that people who ate 0.6 grams of protein had a stable function for a longer period of time. And when the cumulative incidence of renal function or death was calculated, it found that it was higher in people who ate a higher protein compared to people who ate a lower protein. So when we are advising our patients a vegetarian diet, it is a low protein diet, they are getting this benefit, and we should be offering this benefit to our patients. This is again an article from the MDRD which clearly showed a 50% reduction in the risk of going to end stage or even death. So why not reduce the protein intake, give vegetarian diets which are lower in protein and get the benefit? Again, the right type of vegetarian proteins can be blended together to get a better quality of protein, because again, people will say that vegetarian proteins are incomplete proteins. But if you blend the right type of food, you do not have this challenge at all. So meta-analysis are showing a role of these low protein diets. So we should definitely be using these. And they did conclude that dietary protein restriction effectively slows the progression of the disease in both diabetic and non-diabetic kidney patients. So when we are talking of a vegetarian diet versus a non-vegetarian diet, I feel that vegetarian diet is associated with less hemodynamic changes compared to the animal proteins or the non-vegetarian diets, and they are also associated with lower sodium and phosphorus load. So definitely a vegetarian diet should be recommended, and again this diet has been found to be associated with higher bicarbonate levels and improved phosphorus balance in our patients. So we should be using these diets for our CKD patients. This is another article to show the benefits of the plant protein, and they are definitely more. And if you just again see the benefit of about every 33% plant to total protein ratio increases the association with a 23% lower risk of mortality in CKD patients. So definitely this study again shows the benefit of a low protein diet, that means a vegetarian diet. So just to summarize, vegetarian diet is associated with less hemodynamic changes, it is associated with lesser chemical changes, and they should be recommended to patients of chronic kidney disease. This is all I wanted to discuss and talk about. So over to you, Ipshita.
At the onset, I would like to thank Anita ma'am for inviting me here, and thank you for the kind introduction. So let me share my slides. Am I visible and audible both?
Yes, Ipshita.
Thank you so much. But my speech has become a little difficult because Anita ma'am has spoken so much about vegetarian diet and as well as Zamrud. But I would like to try my experience and my opinion on non-vegetarianism, because the area I work, so they are basically non-veg people, and I agree. During CKD, we have lots and lots of complications. Management of nutritional aspects are really a big challenge. Mostly when they come to us, at least 40% of the patients are malnourished with their increased mortality and morbidity. And because the number of comorbidities are also associated with CKD, like diabetes, hypertension, some cardiometabolic problems. So lots of complications are there. So nutritional treatment for these patients are a little difficult. So what could be the aims? We need to maintain the normal biochemistry levels, minimize the symptoms, because mostly patients are with azotemia, acidosis, hyperkalemia, hyperphosphatemia, low calcium levels. So these all are there. Even protein energy wasting is also there. So we need to focus on all these things. So most importantly, we as a clinical dietitian, when we sit in the chamber or we visit an IPD patient, we need to give a patient hearing about the choices of the patient, because in eastern part of India, they are mostly non-vegetarian, and considering that, we need to focus on the choice, because as it is there, a CKD patient maybe different stages, patients intake goes low. So, and at that point of time also, if we withdraw these non-veg items, they feel sick more, because psychologically it's a progressive disease. So when they are diagnosed with CKD, they are already psychologically depressed and upset. So we need to focus on that also. So as we know the importance of protein, it is helpful for building muscle, for healing, to fight infection, for healthy lifestyle. So protein requirement depends on your age, sex, along with the blood parameters. And the essential amino acids, which are the building blocks of protein. So animal sources like amount of fat and fat, like whole milk and milk product, egg yolk, and white fatty cuts of the meat. So these are all high content of saturated fat. So we can choose the product like lean meat, some fish, and low fat or fat-free dairy products. Fluids are restricted, so we can give some curd and cottage cheese made out of low fat. Along with that, if phosphorus is high, we can give egg whites, which already Anita ma'am has explained that that's a very good source of protein. So we can decide on the protein, and excess protein waste can build up in bloodstream. So while making a diet plan for a particular CKD patient on whatever stage, maybe 2, maybe 3, maybe 4, before dialysis, when we are planning. So we need to focus on the nausea, the loss of appetite, the muscle wastage, the weakness, the change of taste. We need to focus on everything. So proteins repairing, they heal the tissues, helping making hormones. These are all important functions of protein. It maintains the acid balance, acid-base balance, fluid balance, electrolytes, and some part of energy is also available from your protein. So protein intake, it's really a controversy. Somebody these days, vegetarian proteins like plateau diet, these are very in thing these days. But mostly lack of compliance with a low protein diet also. So literature suggests that KDOK recommendation are stages 1 to 4, 0.6 to 0.8 gram per kg body weight, and stage 5, when patient is receiving dialysis, then we need to increase the protein and quality of protein. All the time we say 50% has to be from high biological value. So high biological value, we all know it comes from first class protein. So again, I agree, protein is associated, good amount of protein is associated with phosphorus. There comes the role of a, clinical dietitian. So 1 gram of protein has around 13 to 15 milligram of phosphorus, of which 30 to 70% is absorbed through intestine. So many foods, especially animal foods, dairy products, nuts and seeds, these whole grains and legumes, these all contain good amount of phosphorus. So how can I control? Phosphate binders are mostly given to the patients where phosphate levels are high. So we need to focus on all the blood parameters while making a diet set. When the phosphorus found in animal protein, those are easily absorbed. So again, we need to focus on the quantity, whatever we are giving to that particular patient. So this is a graphical representation. You can say I am only supporting non-veg, but I am showing this slide. On the left-hand side, the green portion is the vegetarian part. The red portion is the non-vegetarian part. So we can easily see the phosphorus, digestible phosphorus available in non-veg part, which is, I agree, is higher. But we need to consider essential amino acid. Its glycemic index is high. Of course, all vegetarian like dal and dal products, some vegetables, fruits, these are all rich in potassium. So we need to concentrate on that also. So while choosing a particular type of food, so phosphorus protein ratio we can look into, and we can choose the products. So these are the products which are rich in phosphorus. So normal health 2.5 to 4.5, stages 3 and 4, 2.6 to 2.7 to 4.6 mg per dl. So these are the level of phosphorus, and stage 5 and dialysis 3.5 to 5.5. So we have to give focus on hyperphosphatemia. I am repeating, but we need to look into the quality of protein. So protein restriction can lead to malnutrition. So quality of protein regarding veg protein, so that is a poor quality protein. That's a second class protein. So while choosing these days, there is a fair chances of buying packaged food. So these are all rich in phosphate. So while choosing a product, one should read the label properly. So content of protein, at the same time, what phosphate is there as preservative or as for the shelf life of the product. So we need to read the food label. So in conclusion, dietary management is essential component of CKD. Malnutrition occurs commonly in CKD, but traditional markers of nutritional status like albumin may reflect inflammatory status and comorbid conditions. Monitoring change in target weight and evaluation of recent intake may be the best tools to alert the clinician to change in nutritional status. Foods rich in protein contribute to phosphorus and potassium intake, and it has some sodium, but we need to give a close focus on the intake and whatever we are prescribing. A balanced and individualized dietary approach based on low protein diet should be elaborated with periodic dietitian counseling and surveillance to optimize management of CKD to ensure adequate protein and energy intake to avoid correct protein energy wasting. Thank you so much.
Thank you, Ipshita, and thank you, Zamrud, for that excellent your views on whether the patient should be given vegetarian protein or a non-vegetarian protein. Well, I am of the opinion that cultural food habits cannot be changed, should not be changed. Otherwise, the patient will not be able to cope at all with your prescription. So I am neither negating you nor am I negating her. I'm favoring her, Zamrud, because, well, vegetarian diets are good, but definitely if the international guidelines, they recommend that 50% of your protein should be of high biological value, then it has to be there, and the patients are really nutritionally deficient. And then Ipshita's point of view that well, they 40% of the patients do come malnourished, and this is true. Everybody will accept. And so if you really have to fight malnutrition in these patients, and if to really, it's kind of rehabilitation of these patients is very, very important. So for me, I think I would like to invite Dr. Shruti, and I think we should get on with the panel discussion along with this, and we can take this up in the discussion. So for the panel discussion, actually, I'd like to invite Dr. Arpana Iyengar. Let me share my screen. Who is a professor in the Department of Pediatric Nephrology at Bangalore, St. John's National Academy of Health. And she's chair International Society of Nephrology, Clinical Research Committee, and the lead ISN mentorship program. And she is also a subject editor of ISN Academy and core executive member of ISN South Asia Regional Board. So welcome, Dr. Arpana. And now I'd like to invite Dr. Sushma Tiwari. She is consultant medical nutritional therapist at Prayagraj, Saket Hospital, Yashrok Hospital and Research Center, and she's the regional officer of IPN Prayagraj. And she's a speaker. She's been speaking at various conferences. She's very nice and bright. She's a columnist in city newspapers and designed and made the first inpatient kitchen in the city of Prayagraj. And she's a former senior dietitian at Sir H.N. Hospital, Lilavati Hospital and Research Center, and Asian Heart Institute and Research Center. And also, I'd like to invite Dr. Ashwini Ukalkar, who is the administrator and director at Ashwini Kidney and Dialysis Center since 2000. She's a lead auditor for the NABL accreditation, treasurer of Ashwini Kidney Trust at an NGO for the promotion of awareness and prevention of kidney disease since 2005. She's faculty since 2013 for students of dialysis course run by Nephrology Society under RTMN University, and she's the immediate past secretary of Vidarbha Association of Pathologists and Microbiologists in 2021. She's authored several chapters in the handbook, various books, and particularly in the Handbook of Dialysis. And also she's a qualified assessor for Dialysis Center, Accreditation for Quality and Accreditation Institute, member of Technical Committee Accreditation Program for Dialysis Centers for Quality and Accreditation Institute. So welcome, Dr. Ukalkar. Okay. Right, sure. So may I invite, may I have Dr. Arpana Iyengar, if she's around? She is there. Or
Dr. Arpana, you are there? Let me just check.
She was there.
Yeah. Okay, let's start. If she joins in.
Yeah, we can start with Dr. Ashwini Ukalkar.
Yeah.
Right. So in pre-dialysis stage, if a patient is not eating too well, how well can you still maintain the nutrition status of the patient? Is Dr. Ukalkar there? No, it's okay. So the question goes to Dr. Sushmita Tiwari. Would you like to unmute yourself?
Yeah, sure. Thank you. Good evening. That was a long wait since 5 o'clock at least. At last, I got to say something. But indeed, congratulations all, ma'am. It's been a nostalgia, basically from Bombay, and now I see my friend Zamrud. I see you from Global Hospital and Ma'am Anita from Lucknow. So thank you for this opportunity. To answer your question, when we talk about patient not eating well prior to dialysis, is this the question, ma'am?
Yes, in pre-dialysis stage, yes.
Yes. So when we are talking that because of the increased creatinine levels, we understand that the intake obviously is compromised. What I remember Dr. Shruti saying very categorically is that it needs to be a patient-centric approach. As you, ma'am, have said that, it has to be something that is related very close to the cultural likes, dislikes, food preferences of the patient. So yes, depending on what the patient would like to have, we will kind of chalk out our diet plan. If the need be, we may, just like I remember Dr. Shruti talking about giving mangoes and ice creams to patients who would want it so, because here the basis is for them to eat, for us to encourage them to eat. So yes, let them tell us what would they want to have, and then we change it according to those calorie, proteins, etc. Because those scientific calculation is ours. But what the patient wants is either a yes or a no. They may not really understand when you're talking about high phosphorus and proteins, etc. So yes, trying to give trying to make it as close to whatever the diet preferences are, meeting the schedule or the dietary regime of the patient. If the need be, adding an oral nutrition supplement. So it could be something like paneer for a non-diabetic, to a safed chene ka rasgulla for a diabetic. It could be simple thing as a khichdi or a doodh roti or a kheer or a sevai, from maybe to an upma or a poha with some lentils or some nuts added to it. So the variety could be many. It could also be something for a non-vegetarian, could be just the white of the egg. I see Ma'am Ipsita, so I need to add some non-vegetarian sources as well. But yes, of course, egg is a dear friend for all of us. And that is one of those kind of things, that comes as a easy thing for most of these pre-dialysis patients, as also the post ones. So yeah, the options are quite a few. And most importantly, besides what you're giving, how you present it, how you make it palatable too happens to be a challenge. So as the dear friend Samrud had suggested, adding something like amchur powder to cinnamon, to maybe just a vaghar, to something like a khichdi and a curry, instead of just plain khichdi. We all like khichdi with a top of ghee on it. So those are the ways in which lime juice, of course, is there. So many, many options. So the basic challenge, I believe, for all of us is to keep the integrity of our professional. It's quite easy. It's not as difficult to make the diet prescribed nutritious, a balanced diet. Keeping all the nutrients in mind, it may be challenging for a few, but at the same time, it's not something that cannot happen. So yes, ma'am, these are the suggestions for pre-dialysis diet.
Yes, great. That's an excellent answer to what I wanted to hear. I know dietitians will find a way out to feed the patient. And Zamrud, I think, are you going to be a favorite dietitian for that matter? Because you offering them all those, the fried stuff. And so I'm sure, patients are going to love this kind of consultant that, well, I get to eat everything, that kind of thing. And
so I can put in, we have a patient actually presently getting dialyzed. Every dialysis he comes, he goes to the canteen, he gets a pani puri and a sev puri, and then he comes up for dialysis. He says, "Aapne mujhe bola hai, sab kha sakta hu. I am enjoying."
Ma'am, to that, if I may say, Dr. Shruti, if I may say, during dialysis, just like when you're talking about mangoes, here you have something called water chestnuts. Singhara.
Yes. Even we have them in Mumbai.
Yeah, and it's quite seasonal here in winter, especially. Then we have the pea season. Now the pea season, matar. It is from us. It is from November to February. So it is very difficult for us to tell patients ki matar nahi khana. तो what we tell them is कि यहाँ पे लेकर के आइए और खाइए, मटर का पराठा खाइए, सब खाइए.
That's what we tell them.
Yes,
That's what
so
we
now
tell
these
them.
are the things that we have learned from yesteryears. I think during 30 years past that we've learned our nutrition science, and that continues even today. It is just, it is the same thing in a different way. But yeah, during dialysis, whatever things that is in low, something like simple makhana, we know that it may be high in potassium, but when we have makhana, bhuna chana, mungfali, let them have for
So
dialysis.
in Mumbai, what we used to do previously for our dialysis, Zamrut can put it in, that, we used to not serve food from the hospital, but we used to serve them chikki, good and groundnut.
Chikki,
The favorite for the Anganwadi workers, for the Bal Vidyalayas and all that, because it is nutritious, it has calories, it has proteins, and it is not costly.
Yes, economical. Very, very economical.
We used to have a assistant to Madam Vidya Acharya. If you know Madam Vidya
Yes,
Acharya.
very well, very
So
well.
the assistant to her was not educated, but she helped us providing these chikkis for our patient after Madam Acharya passed away. We employed her, you provide chikki to our dialysis patients. So we would order her so that she earns a living. At the same time, we would be able to give nutritious food to our patients. And we would explain to the patient.
I have been an intern at KEM Hospital. That time when Dr. Acharya was the head. So we know her, and we know the kind of strict discipline that she used to have in a KD department.
Correct.
So yes, ma'am, as you correctly said, during dialysis, the choices are umpteen. Whatever cannot be had can be had during that time.
Right.
Yes,
My
ma'am.
question to Ipshita. Ipshita, if you're like your patients are they're very fond of fish. Now, if your patient is not willing to eat fish because he's just not able to eat, what is the option then left for you?
Because in few cases, fish has its own smell. So
Yeah.
in those cases, sometimes we opt out, we give choices for chicken or egg whites. So in that way, we can give permutation combination also. Otherwise, like the chena or curd ka kuch, because fluid is also restricted, so we can't give milk. So as it's counted as milk. So curd ka kuch preparation, chena ka kuch preparation, some kheer sort of a thing. Even in few cases, like fish ka kuch chop type ka fish ka stuffing dekhe, and like potassium is high most of the time. Many of the times, special potassium is high. So I told them to make a batter. What we normally make it with besan, I tell them to make it with rice ka powder. So that will give calorie at the same time that crunch also. So in that way, permutation combination, I always prescribe them. Even chena stuffing, fish ka stuffing, kuch paratha type ka, seka hua paratha type ka. So these are the few things which is prescribed instead of giving direct a piece of fish.
Okay. Another question for you. Now, you from a rice eating belt, and patients here say if we take rice, we'll gain weight. Interdialytic weight gain will be higher if they take rice. What is your take on this?
Basically, that's basically a wrong concept, because high fiber is good, I agree, because if I get a roti, if I get some millets, those are fine. But in rice, if a portion control, if I control the portion, so the calorie for rice and wheat, hardly any difference is there, hardly.
No, I'm not talking about the calorie content. I'm talking about the water content. There's a misconception that you don't take rice because it's got a lot of water content. I'm not talking
because it absorbs 4 times of water.
Yeah.
So it's sometimes when a person is extremely edematous, few doctors come and tell us, don't give them rice, but in my practice, I don't stop them. I don't stop, because as it is, they cannot eat anything. Rice eating zone where I am presently working. So I give them. I always give them. Even that is so, if patient is highly edematous, ascitic fluid is there, fluid restriction is there, I calculate other sources of fluid, like a gravy preparation. I always tell them to make it a thick gravy so that you don't have to mix the rice with so much of liquid gravy. So in that way, I reduce the portion size, but I give rice. I give rice. Whoever is, even few cannot tolerate rotis and all, some gluten intolerance. So them also I give.
Yeah, but
Because
this
it
is a
a
myth, no? But
visible
this is
water.
definitely a myth
So
that
it's a definitely a myth that
It's
what,
myth.
yeah,
that's
when
what I
you-
want to
Absolutely
because it's a
clarify.
bound form, it is not freely available to the system. So
Absolutely.
it's a myth.
Absolutely. I don't accept. I mean, I don't
Yeah.
follow. It's a myth.
That's
basically.
that's what I wanted to. Okay.
Yeah.
Yeah.
Shruti, would you like to say something?
Yeah, I think I agree. I think we have to tailor to each patient. I
Absolutely.
feel you talk to the patient, you understand कि okay, rice khana hai, you reduce your fluid like that. Give what they want, but adjust on your dialysis. Is what I say people. I tell the technicians also, I tell the dialysis nurses also कि मना मत करो, हमारे पास लेके आओ, हम टेलर करके देंगे. In fact, so many times I just pick up the phone, call Zamrud ki ye patient ka thoda dekh lena. Whenever she takes rounds, she will take care of it. And in fact, I wanted to ask Zamrud a question that, when you have children and you have CKD, you have nephrotic syndrome, how do you handle their food? Dialysis patients, how do you handle their food and their, I would say their taste and their cravings?
So it's very easy, Shruti, for children or adults. If you ask me, you just have to not say a no, you should give them the substitute. So for example, I just showed in my slide that for salt, the substitute is amchur powder. So people had a craving for chaat masala. We came out with the chaat masala. Patients become happy and they are satisfied. So you need
What
to
is
work very closely. Yeah.
Zamrud, but this
Yeah.
amchur powder is dried mango powder. Is it not
yeah.
high in potassium?
No, raw mango is low in potassium. Ripe mango is high in potassium. Okay, if you see the nutritive value, only the processing of this raw mango, when it is done at the home level, normally we take the mango, raw mango, slit it and we put salt and we sun dry it. But when it is done commercially, it is done in the drummers. No salt is used. These slices are just dehydrated and they are powdered. So there is no salt. Actually, the sodium content probably is around 8 to 10 milligrams per 100 grams.
No, I'm not talking about this. I'm not.
Yeah, even the potassium content is potassium content is not high.
Raw mango,
in fact, raw mango is low. And in fact, in the mango season, when the raw mangoes come, we actually ask the patients who are given salt restrictions to chop this and to add it to the food and get the natural flavor. In fact, it's very useful and it saves, gives a very good flavor. You can increase the appetite of a person when you use that.
As also
So with pediatrics, that way it works.
Even that, if a non-diabetic person can make it a chutney sort of a thing, because we Bengalis do it, the raw mango chutney, and you can, so that every meal you can have a little bit from that. So that will also taste, I mean, increase the appetite also.
Not too much of it any which ways. So raw mango is something that you cannot really have much without the salt. So if you're just giving amchur topping on it is kind of a good thing.
Yeah.
In fact, we try to tell patients to make murmura ka bhel and all that with amchur in it, so that even CKD patients can enjoy it in the evening time for a snack, because it is low in protein, it does not have salt, and it gives all the flavors, because you add tomato, you add a lemon, you add some chutney, and it's done.
Some kheera, tomato, whatever. Even some boiled potato, so it's like a chaat sort of a thing.
So it adds the calories.
Absolutely.
I just had a question in my mind, if I may ask. Ma'am Anita, can I just ask something if it's possible?
Sure, why not? Why not?
Thank you. We are talking about dryness of the mouth. When we are saying that, they feel thirsty because of the medicines or because of the fluid restrictions. Correct me if I'm not. Lychee. So if a person is given one lychee, so how bad is it? एक lychee full पानी दे रहे हैं, just the data of lychee. We have the glove.
So why can't we use it? We can definitely use it, na Sushma?
Use it, isn't? Yeah, that's just what I want to confirm. We are on similar lines. I just wanted to confirm. Okay,
Yes, we definitely use that flavors.
Because I generally tell my patients, when they complain of
voice was cracking.
I couldn't hear her very well. Yeah,
absolutely. Me too. I couldn't.
Her connection was.
Yeah. She was basically asking that to use for cardamom or clove to be given to patient to quench their thirst.
Yes,
so it is something that can be recommended. That's what she was asking. That should we recommend or not? So it is.
Yeah, she was mentioning about it.
Yeah.
Yes. That's fine. Absolutely fine. Okay, so I think Dr. Arpana has not joined, and she was there actually, but right now she's not there. So, Dr. Shruti, shall we wrap up the?
I think so. It is 9
Okay.
p.m. We've had a good session.
We've had an
And
excellent
there are
session.
multiple questions which are there, and we've tried to answer. I've tried to answer whatever I could, and I have requested the panelists also that if they can answer in the chat box, they could do so, and we wrap up the session.
So, you don't want to answer the questions now?
So I think most of them.
So there is a question on millet-based diet.
Yes, that was the last question.
So
which
probably
Dr.
I'll
Manish
answer
had.
that. Millet-based diets are good diets which give high fiber content. But only problem with millet-based diets are for people who have hyperkalemia. Probably if your potassium levels are high, you need to be careful while using. Probably today we have patients who like the millet so well that they boil. That means they leach out the potassium. And they have been using it. So I don't see there is anything wrong in doing that, but probably the process has to be followed of leaching. Millet-based diets can be used for people who don't have a potassium challenge.
All right. Okay.
Another person asked egg white to be given to vegetarian low protein. So if there is no choice, if like veg, if she or he can have egg, easily it can be given. Even one whole egg, phosphorus is under control. Even one whole egg can also be given. One thing for a CKD or a dialyzed patient, you have to keep a close contact with the dietitian as well as the clinician, because it is a regular affair. Your blood parameters can change. So you have to, like, once you take the diet chart or take the advice and you go just push off from scene for 6 months or so, that way it cannot be. You have to be in touch with us.
But
that is the major
definitely, I'd
thing.
like to, I would like to give this message that one should always, egg white is an excellent friend. I always tell, and I'm really fond of prescribing it to my patients, because I said this is the best way for you to get a,
protein, albumin,
protein of high biological value. But there are some people who try to push vegetarians who've never even taken a non-veg ever in their life.
Going to talk about
they
that.
won't even accept the flights of the egg is given along with it. So for them, one should not push such patients
Absolutely.
so one has to respect there, because there are a lot of dietitians
beliefs and
So probably, Dr. Anita, you have vegetarian options. You can use soya, you can use pulses, you can use a cereal pulse combination. You can improve the biological value of your vegetarian protein. Probably dietitians are the best to guide the patients. It is not necessary to use only egg whites.
Yeah.
So as per the cultural values of the person, the ethnic background the person has, you can prescribe the diet.
Absolutely. We have
give
to
due respect to the patient's natural.
That's very important.
It's very important.
And very important. Otherwise, it'll maybe if he's not having nausea, he'll start having nausea after taking eggs. So that's the message I wanted to give to the dietitians, so that you have to be very careful. Don't push somebody.
Even thought of that non-veg item gives their they feel nauseated. And
even when non-vegetarians are, many of the non-vegetarian CKD patients are not able to take non-veg food as their disease advances. So we are talking of vegetarians eating that food. That's not
converting them into non-vegetarian.
It happens.
So we have options, and we should be using those options.
All right. Any other question that needs to be answered?
There is a question in the chat box. What is the correct process of leaching stepwise? How long it can be continued?
So probably we had done a study long back where we tried to use the foods. So probably the leaching happens between 40 to 80% only. Okay, some foods would get leached. Again, it depends on how small the vegetable size you're cutting and you're boiling, the amount of water that you're using for boiling. Ideally, if you cut the cubes of the vegetable into 1 inch and you use almost 5 to 10 times the volume of the vegetable to water, you boil it for 1 minute, around 60 seconds to around 120 seconds, 1 to 2 minutes, and you discard that water and you just put these vegetables into cold water. Okay, that helps in maximum leaching of potassium. So that is, and again, this also helps in maintaining the texture of the vegetables. So there is nothing, no paper which would say that this much time, this much portion size, but approximately between 40 to 80% of potassium can be leached if you follow this process.
There is an article by Dr. Geraldine Burrows, on leaching, just have a look. It says a very, very small equal-sized pieces of the vegetables have to be chopped, and it has to be leached and
surface
drained.
area, the more the surface
Yeah.
area, the
Yes.
leaching percentage is higher.
Yes.
And one more thing I would like to add, many a times patients come and say, I only have dal water. I would suggest, if you want to have dal, have the bottom, the thicker portion, because whatever potassium is coming out, it will come out in the dal water. So if you feel like having dal, a bowl full of dal, you have the bottom thicker part. So it's a wrong thing. Again, it's a myth that dal water contains a lesser amount of potassium. So don't have it in that way.
Actually, what happens, ma'am, generally we say, some of us say that dal kam khaya karo. So what they think is ki dal kam khana matlab patli dal.
Patli dal.
Yeah,
Exactly.
patli dal is
That's our responsibility to make them.
That is a CKD suggestion which is given, and that they follow during dialysis. So we have to change their thought process.
Yeah, that's
So
important.
probably once they change the therapy, the diet needs to be changed. That has to be also be explained to them when they come. The counseling has to be done in that order. Probably we don't counsel them. If we don't counsel them rightly, then probably these problems happen.
Yeah, that's what the counseling is, the most important thing that will take your message across, and the patient will follow it. And I'm sure they will benefit if the patient's been counseled enough, if patients been able to understand, and the caretakers have been able to understand the importance of everything that you're saying, and that I think 50% of your job is already done. So I think we'll wrap up the session now, and thank you all the speakers and participants and panelists for joining us and in celebrating our second day of the World Kidney Week, the WIN India's initiative. And I'm sure we all have benefited from this, and we do look forward to your participation over and over again in our next future endeavors. Thank you very much, and I sign off for now. Bye-bye.
Bye.
Thank you very much.
Happy World Kidney